Hello, welcome back. Day two of the 16th Annual Neonatal Pediatric ECLS Educational Conference. This is day two. This will be our last day of virtual. Tomorrow for our guests here in person, we'll have to do some hands-on. We're really excited about what we have lined up for you. We have some really good speakers today. Just some basic housekeeping. Oh, I have to change slides. For continuing education information, please just follow along with that. Take a picture of it or screenshot of it. Need to have this completed, and as well as the continuing education information that you'll need. You need to have this completed before October 22nd, 2025. Pretty easy to do. If you have any problem, please reach out to Merritt or myself and we'll help you along with it. So I'm going to go ahead and start off the day. Today, again, thank you for everyone's coming. It is my pleasure to introduce our first speaker of the day, Elizabeth Moore. Elizabeth is the Educational Director at ELSO, where she leads the global efforts and development to standardize ECMO education. She has played a key role in advancing ECLS training worldwide, and we're honored to have her here today. Please join me in welcoming her for her talk, ELSO Endorsed Education, Raising the Standards. Thank you, Elizabeth, for joining us.
Hi, everyone. Thank you so much for having me. I'm just sorry I couldn't be there in person, although I see I'm very strong and with a lot of participants online here. So wonderful to join you all. And thank you so much for the opportunity to share the work going on at ELSO. Let me just work to make sure you guys can see everything you need to. And I'm hopeful you guys are now looking at my slide deck. So as said, my talk is talking about the endorsed education and rising the standards globally around this topic. And this really has been my passion work, so to speak, for the last almost 20 years with ELSO. I'm also the Associate Director at the Heart and Vascular Center at the University of Iowa. That's my other side fun job where I get to still interact and work with our ECMO team directly in the cardiovascular service line. No disclosures. And so really what I wanted to first start off with is really in the few minutes I have with you guys today is to try to present a clear case for why ECMO clinicians and centers really must adopt standardized training to ensure consistency, competence, and collaboration across all teams. And probably more importantly, what I will do is show you the resources that have been created and exist to help you make that transition. And really to start off with that, for the conversation today, talking about training, it's really important to understand when I mention ECMO practitioner, who am I speaking about? And for the work that's been created over the last 10 years, the definition of who we're looking at as an ECMO practitioner really is that group that comes from the diverse clinical background with varying roles and core skills, that we're all trained in these core concepts to understand how to manage ECMO. And these practitioners are from the backgrounds, as we all likely know, and we're sitting in the room amongst, is nurses, RTs, perfusionists, and physicians of varying backgrounds. And some of the conversations I'll have is referenced from the position paper that was noted below, and I'll go into more depth. But this is a really important first part of really defining what education should look like globally, is really understanding who this education was created for. Trying to sum up the necessity of why this work has been created. So just pulled recently looking at the Bureau of Labor and trying to understand the workforce. And really what this was trying to understand on average what the transitions look like for these backgrounds and how many different hospitals that they may transition between over the life of their career. And it just shows kind of some rough estimates of where physicians can work anywhere between 2 and 5 distinct hospitals, maybe between health systems and locations. Obviously, training background will greatly impact that. I think the disruptor of the pandemic, nurses can move between 3 to 6, and especially if you start talking about travel nursing or changing specialties, that can be more profound. More challenging as we get into the RTs. But there were some assumptions that could be made that it was roughly the same between 2 and 5. And then for perfusionists, likely fewer transitions, although there are very large, as we know, contract companies that will employ perfusionists to give them the opportunity to transition within the company between sites. So why is this important? As I'm talking about ECMO training, I think that one of the biggest lessons in the pandemic that we learned was the need for helping to support the multitude of ECMO cases that were happening across the globe, across the regions, across states. And so people were desperate and looking for people to come help staff their ECMO pumps. And what we have been seeing lately, so this is a screenshot of what the various job sites can look like now, is that people are hiring directly into the role of an ECMO specialist. So full-time ECMO specialists working in institutions. And as I referenced, I'm at Iowa, and we even have job postings for that. So now think about that. As of even today, the training that one gets to become an ECMO specialist is about as varied as you can imagine. And so hospitals are making these big asks of looking for these people to come work in their hospital when the fundamentals of what they've learned and how they've learned, there's no clear pathway to understand how they got their training and really what it is that they would understand. And so there's a piece to this that I think, having talked to many hospitals and listening to kind of the nightmare stories of, people who were desperate during the pandemic or post-pandemic after transitions of workforce, and they would hire on people that would say, yeah, I did ECMO at X hospital. And the practitioners would move across the country, move to different hospitals, and their skill sets were very different and very challenged from what was needed in that role in that hospital. And so obviously, as I said, the work has been underway for quite some time, but I think that post-pandemic job markets in the arena of ECMO have really heightened the need and the demand that we're seeing for this call to action of what standard ECMO education could look like. So I've referenced, and the reference has been made elsewhere, there's a group called ELSO Ed. And so who was this group? So this was a team of about 40 ECMO experts that really had a passion for education and came together in Santiago, Chile in 2018 with kind of a goal of trying to better grasp the varied nature of ECMO training that people were seeing. And the little arrow shows to me in the back. I was very honored to be invited and join this miraculous group. And the subsequent slides are largely products of publications and work that have been done from this group in the subsequent years as kind of a follow-up for what we learned when we spent our time together in Chile for 3 days, kind of looking through and investigating where ECMO education was. One of the first things that came out of that time together was this position paper that was published in 2020. And really what this paper does a great job of putting together is it really describes the state of ECMO education worldwide. It showed the disparity and variability across the globe of what people were coining as ECMO education and how they were training specialists. And probably more importantly, what the paper ended up outlining is a blueprint for what we could be doing over the next few years to really come together as an international community to collaborate on an approach towards what standardization could look like. From that paper and from that group, what was determined is there were 7 categories of ECMO education that really needed better definition and understanding, and hopefully then able to put some constructs around what that topic could entail. So for each one of those 40 people were broken up into the 7 groups. Curriculum, that group was tasked with looking at how to create a standardized curriculum, incorporating both knowledge and psychomotor skills and learning objectives, and really defining when someone says, I've been through ECMO training, what are the learning objectives that a practitioner must have exposure to really be called an ECMO training course. The other second group was courses, and this was a team that was brought together to talk about how to structure these courses and really be able to talk about a minimum educational quality level. If someone's going to call a course a ECMO training course versus a symposium versus a conference, and that kind of blended into three, which were, there's obviously opportunity and especially even since the inception of this paper to talk about cannulation workshops, ECPR workshops. And so this group started to really define complementary workshops to supplement the courses. And with that, what they did is things that weren't necessarily included in the core curriculum, but found to be an important topic. So ECPR being one of them. How do we help enrich the practitioners who have gone through core training and now want to dabble into the ECPR world? What's the definition for what should be included in that workshop? The fourth work group was on online education. Admittedly so in 2020, in 2018, this was pre-pandemic. And ironically enough, the online work group was considered the stretch group. Nobody at that point in 2018 really thought online mediums were something that could be achievable in the next 5 to 10 years. I think our mental model was around being in a classroom and being in a space together. And so while a group did start to think about what type of platform we would use and how we would adapt to online learning, that one had probably the least traction when we left the meeting in 2018. I think, again, pandemic dramatically changed that. Endorsement, that's a process to say if we define what we need to teach, if we define how we're going to teach it, can also cover the globe to help create regional training sites. And with that, that's what the endorsement title is it's really just a way of saying that a center is adopting the standard curriculum and how they're providing the course in a way that they are stood up as an ELSO regional training site. And so that process right now, we have 27 centers worldwide. We have 9 that are in process and 4 going for re-endorsement. And we truly are in every chapter and every continent, minus Antarctica, for endorsement activity. So that's been a fun process to watch that team craft what this would look like and then really seeing the global community's adoption of this. The 6th group was certification. Their challenge was to create a validated assessment tool. For any practitioner who's been in the ECMO space for any period of time, you know that there's always been a recommendation that there's some type of written test at the end of training. However, there's been very few assessments put out there that has had global adoption. I know Dr. Bartlett many years ago put out a multiple choice test free for anyone online that he created. And so with that kind of mentality and concept in mind, this group partnered with the National Board of Medical Examiners and went through an extremely rigorous process to bring an interdisciplinary team together to create a knowledge assessment exam that has gone now through psychometric validation. I'll speak a little bit about where certification is today. And last but not least is research. So part of this is, all these are great ideas and all these are set on the basis and principle of we think that this is the right thing to do. And so the research group was challenged to say, how do we make sure that we perform studies to validate that what we're doing has value and has merit and actually allows a learner to have a better outcome and a better understanding of ECMO concepts. So as I referenced, this ELSO Ed group then started to mass produce studies and research projects in succession after that initial paper. So this is a paper that came out in 2023 that really was looking at the international education and credentialing practices. So before we kind of put pen to paper and finalized what things were looking like, we ended up assembling and putting out there and requesting feedback from over 700 centers to give us some feedback on do they offer training and do they offer credentialing and a whole host of other details about how they're offering their training. We had 41 countries represented, and we did find that of the centers queried, 92% did offer some type of training. But we also interestingly found that it tended to be more in high volume centers, that they were more likely to offer training versus low volume centers. And less than half, so only 42% actually had credentialing standards set forth for their ECMO program. So very few were having any type of competency assessment process and standardized credentialing practice. And again, it was favored only in the high volume centers that tended to be more of the structured credentialing practices. So after we knew a little bit more about what people were doing in terms of education, we knew a little bit more about what they were doing in credentialing. The course curriculum group went to work. We used Kern's methodology. So that's a medical education process that really does a 6-step process to look at what's the problem that we are trying to fix. And for us, it was variability of ECMO education globally. Who is the audience we're trying to teach? And that goes back to the stressing that I made about defining the ECMO practitioner. So we really did look at tailoring education with specific disciplines in mind. And then, you can see through the rest of the steps of goals and objectives, the strategies, implementation, evaluation, and feedback. So that's the full loop of how we came about what we're defining as core curriculum. And through that, we used a modified Delphi approach, so an international consensus group that came together. And really what their task or ask was is to say, if someone is going to say they know ECMO, what learning objectives must they have exposure to? And with that, the expert panel identified 54 learning objectives that must or should be covered in ECMO training, where there are 32 that are included in the exam. So when we'll get to the certification process, we utilized this expert panel to help identify which learning objectives would be on the cognitive validation or cognitive assessment and tested on to verify that they understood the concepts. So this really did create kind of the foundation for the first international certification program that also has for adults. And I'm proud to say now that is close to this audience that the NeoPEDS certification is also live, as well as the NeoPEDS course curriculum is also live and published. So a lot of work in the last few years to create this course curriculum. The next piece was a publication that was done on saying, this was kind of getting to the heart of the research piece to say, if we're going to go through the rigors of identifying what should be taught and how it should be taught, how are we going to validate whether or not what's being taught is going to produce any type of improvement in performance of the learner? So this group ended up developing a standardized course assessment. So what we did is we measured at that juncture any ELSO course that was endorsed. So we knew they were teaching the standard curriculum and simulations. We collected demographic information on the learners. The learners went through a standard self-assessment to share their competence pre and post course. They went through a knowledge examination, which was a multiple choice questionnaire looking at their pre and post understanding of the knowledge. And then as well, we did a psychomotor skill assessment. So we looked at response to critical action points. And that's what you see in the table is showing you the pre and post time. And what we were able to show in this study is with use of this methodology that ELSO is creating, we had significant reduction in times to critical actions in 3 of the 4 scored simulation scenarios. And so this was kind of one of those early testaments that helped give us, a positive feeling that we were making grounds and making headway on how we were teaching and what we were teaching. The course group spent a lot of time as well, and I will say that our publication is in process. But what we ended up as well doing is assembling again another expert group that went through a modified Delphi process to create essential sims for NeoPEDS and adult. And with that group ended up creating a frame for standard simulations. And then with those standard simulations, that group also scored critical action points for testing psychomotor skills for the different topics. And really, the important part about this is kind of the statement I have at the top that we noticed the biggest disparity in is, a lot of people offered training. A majority of people were offering what I would call is water drill training. So they were practicing the skill, a wet to wet connect, practicing clamping off, practicing, all the steps required for air extraction in a circuit. But it was not in a simulated environment. So there were no bells and whistles, alarms going off, that adrenaline surge that you feel when, those other extraneous noises are going on were not present. And so again, with the course assessment and with our response times, obviously there's a difference if you're sitting in a room and things are quiet and you have absolute concentration versus, the adrenaline is surging and the hands get shaky. And so with this group and what will be published as well in our education guidelines is really a call to action that, simulation-based education is a must for ECMO training courses. Water drills are a necessity to teach people the skills that are required to perform the simulations, but they are distinctly different. And so that's my a soapbox on that one and a piece that is really important for certification. That's typically what the committee sees as the biggest challenge is that documentation is submitted saying people went through wet drills or they got through as checklists on signing off skills. Really for certification, we're looking to see that the learner had exposure to simulation and more so the essential sims are listed at the side. Those were the 7 that the expert group determined were necessary to have exposure to for sim training. And then last in the 3 steps of what I would call for certification is bedside experience. This one as well is undergoing what's called a step 3 study or the exact study where they're looking at competency assessment. So more to come on this one and we are actually recruiting for our study on this currently, but what the language says today is that in order for a candidate they have to validate that they have bedside experience and they must have a minimum of 16 to 32 proctored hours for their training. And then they must have a minimum of 1 8-hour shift every 8 weeks for an average of 56 hours of ECMO patient care per year. And this is a little bit of a challenge with the differences in disciplines. This might be a little easier to track for an ECMO specialist, for an ECMO provider, physician. That gets a little bit more challenging because they don't, cover by shifts. But I think for those, what we're trying to do is in the letter that is verifying their competence is that they're just explaining the volume and the minimum number of weeks of coverage they have to also demonstrate that they've had the exposure to patient care. I will put the note in here that's sometimes overlooked is that ECMO hours completed during fellowship do not count towards this requirement. Part of this, or the big piece of this, is that when I explained who the target audience was, trainees were not part of the initial look at the definition of who we were looking at. And so part of that whole target audience was understanding the bedrock information and what their background would be. So at this point, a fellow could do step 1 and step 2. So they could do the didactic training, they could do the sim training. But really, once they get their first position outside of fellowship, usually within the first 6 months, I would imagine they, if they're at an ECMO program, would have enough volume to submit for certification 6 months on the job. And as I said, it's currently under revision with the study. So I imagine sometime in 2026, we'll have some changes to help provide a little bit more coherent guidance versus just giving some arbitrary hours. And then this is what this looks like is the steps. So didactic course, a sim lab, bedside experience, you apply for the exam. And once the exam committee reviews the first 3 steps, the applicant then is allowed entrance to sit for the exam. And then with a passing score would achieve certification. And as I said, the adult and the NeoPeds certification are now live for individuals. Then we have endorsement. And so endorsement is that process that I mentioned where we have a reviewer come and look at an educational activity to determine if they meet all pre-specified standardized criteria. And really what we're looking there is the curriculum. We're looking at the teaching and simulation. We're looking though, also I'd say is resources and programmatic administration. So we're looking at how the education is taught, and the experience from the learner and what their feedback and experience has been as well. So it's a on-site for as many days as the course is being run, that a surveyor will come and give feedback to the centers, with a goal of eventually moving towards what you see in the corner is that seal or logo stating that a course has been endorsed by ELSO, and therefore somebody wanting to sit for certification just has to submit their certificate of completion for those endorsed sites, and that's all that's required with their letter of recommendation to sit for their exam. What's also coming is what's called Train the Trainer. So we're working on creating a standard in how people are trained to be trainers. So we have a process in development. We've done a couple beta tests of this course. So we were in Abu Dhabi last in February. This course has kind of circled the globe a few times, trying to refine how we're able to put together the curriculum for how we're training instructors. This goes through Delphi this fall, and we hope to have the final curriculum published again in 2026. I think with all of what I've shared with you here in our last 20 minutes here, is that really what ELSO is trying to do is create this unified vision for how we're teaching and what we're teaching. But what we're asking for those educators that, as I showed there in the survey that was done, 92% of centers are already offering education. My challenge to you all, if you're involved in any part of producing education, is to really think about how you're offering that education a little differently. Really spending the time to think about what is it that you're teaching, and are you giving your learner the full complement of materials needed to understand the core concepts. If your goal is to create ECMO specialists and ECMO practitioners, I highly encourage using those core concepts to allow that learner to become more of a learner or eventually an ECMO practitioner that can cross borders. So you're building them to be able to do ECMO anywhere they go in the globe, because those core concepts are what was deemed fundamental for needing to be an ECMO practitioner. Think about what skills you're teaching, thinking about how you're effectively assessing the learner's knowledge and skills. So it's great that you do the course, but how are you making sure that you're getting better as a teacher, or that you are providing a great product so that they actually understand what you taught, and thinking about what kind of assessment tools that you have as a course director of a course. Determine the interval for training. So really thinking about what the retention cycle of understanding is for your individual team, and how often that you'll need to be training them. And the point I made before is, what you're teaching them, is it able to travel with them as a learner? And does it make them a well-rounded ECMO practitioner, or are you only teaching them how to do ECMO at your institution? And that's for each hospital to kind of determine what their goal is. Our goal is, by adopting the standardized roles and resources, we ensure effective training, stronger teams, and ultimately, my before I retire goal is figuring out a way to tie it back to how this has produced better patient outcomes. And why is this necessary? Again, I go back to what I showed before. If people are out there applying to jobs, or maybe you're looking to fill a vacancy of an ECMO specialist and you're looking to hire from someone from outside, making sure that you're getting someone who really has been trained to all the necessary components is so vital. And I would argue that in order to get there, it's not hard. The materials are now out there. The core curriculum is available for free online. You can look on ELSO website and find all the curriculum available for neopeds and adult. The essential sims are listed. the critical action points are coming, how to train is coming. And so hopefully with the list of articles I shared with you, you can dive in and see some of the work that's been published on this. And probably more importantly, the new revisions to the ELSO education guideline that embarrassingly were from, I believe, 2014. Those just were submitted to publication at SIO this week. So I am hopeful that you all will be seeing as well the really it's a compilation of everything that I shared in my talk, going into the deep dive of each category of what we're expecting to see or what we were recommending to see. So with that, I'll leave you with some of my ways to contact me. I'd love to hear from people that have questions in this space or offer any insights or support as others are embarking on their educational journeys and trying to help create training wherever you are. So thank you so much again to the UPMC team for the invite, and best of luck at a fantastic course. I'm sorry I couldn't participate on site because the course looks fantastic. So thank you so much.
Thanks, Liz. Hey, it's Merritt. I have a quick question for you. When we're thinking about certification and we're looking at certification for, say, basically 3 different sets of providers, so critical care physicians, APPs, and then ECMO specialists, so we'll lump perfusion and ECMO specialists into one. When we're looking at bedside hours, how do we determine like the appropriate amount of bedside hours? I mean, critical care physician is pretty easy. Somebody who's say like a primer ECMO specialist, that's also pretty easy. But your nursing staff that is tasked with, watching pump, but not necessarily doing like the crazy interventions and the emergencies, or your APP staff who takes great care of the patients, but they also don't have that hands-on pump experience. How do we decide what bedside hours are appropriate to count?
Yeah, it's a great question. So I think I'd go back to the definition of ECMO practitioners, and I'll just kind of share what's top of mind based on what you shared. But keep in mind, this certification is intended only for those people who are intervening and directly managing the ECMO patient. And so, you'd have to make a decision that, the bedside nurse have a vital role, but if you're not training them how to actually get in and intervene on the ECMO system, they may not be appropriate for certification, and therefore, the hours are arbitrary for them. We really are trying to focus this in at those that really just meet the criteria or the definition of an ECMO practitioner. And for those, like I said, I think you kind of hit those that are nearest the pump. It's pretty easy to calculate the hours, and those are the ones that are eligible for certification.
Great, thank you.
Of course.
Thank you, Elizabeth.
Thank you.
Okay, next up in person, we have Dennis Simon. He is the Director of Pediatric Neocritical Care Medicine. He'll be here live in person. We have you all queued up here.
Thank you, and thank you to the organizers for having us to speak here today. So I want to start actually with 2 patients, the top row and bottom row. On top is a little girl who had influenza and MRSA pneumonia. The CT on the left is when she went on to ECMO. She had about a month run. The middle CT is about 6 weeks later, and The CT on the right is from this year, which is about 9 years after her ECMO run. On the bottom is a little girl who had presumed Bactrim hypersensitivity reaction. She had 2 CTs while she was on ECMO, on the left and in the middle. And then on the right is a chest X-ray, again, from about 3 years after her ECMO course. Both of these girls now they live a more sedentary lifestyle, but they're participating in youth activities, youth sports. They have bronchiectasis. They take a nebulizer therapy and chest vest therapy, but they're both active in school and really leading full lives. And neither one had a neurologic complication or a significant neurologic complication on ECMO. And that's really one of my driving messages, is that if we can get these kids off ECMO without a neurologic complication, they can go on to really, despite lungs that look like these on the left, they can go on to really high functioning. In our ICU, if you just look at patients with or without a pre-existing condition, a lot of the mortality that we see is related to neurologic injury. And neurologic injury is one of the more common reasons that children have a terminal wean from ECMO. There are many reasons that a child can have a neurologic injury on ECMO, some of them patient-related factors, hypotension, hypoxemia. A lot of times these are the reasons patients are going on to ECMO, and circuit-related factors. Coagulopathy, both being pro and prothrombotic, and as well as likely to have hemorrhage. And if we look at the ELSO registry, we see both in neonatal respiratory and neonatal cardiac complications that in terms of just what's reported, seizures, CNS infarction, CNS hemorrhage are quite common in the neonates, and we see the same thing in pediatric patients. I think the next speaker, Kate, is going to talk about some outcomes, right, Kate? Doing outcome? Complications. Okay, perfect. So we're gonna get into this more. But what's reported is that neurologic injury is of course quite common when you're on ECMO. So this is just a 2-center study from Mel Bembia at Hopkins, who's done a lot of the work in this area. And they saw 50% of patients had abnormal imaging, primarily by MRI, that was obtained during and after ECMO, and then was associated with lower Vineland scores and increased mortality. And similar findings if we compile all of these small, mostly single center reports about neurologic complications into a systematic review. So these higher rates of neurologic morbidity have really led us to have more of an interest in neuromonitoring. Can we detect neurologic injury early in the course? And if so, is there something that we can do to potentially reduce the risk of neurologic morbidity? And from the ELSO guidelines, there are some neuromonitoring modalities that are recommended. Some that are listed as optional. I'll say that the level of evidence for these remains still quite low. But what's recommended on the left column, so head ultrasound for patients, particularly neonates that have an open fontanelle. And it's generally considered for daily for 3 to 5 days, and then can be performed intermittently thereafter. Continuous EEG monitoring is recommended, often for the first 48 to 72 hours. This is the highest risk where we see for seizure, but EEG can be used for many other things, looking for changes in terms of asymmetry or voltage attenuation that can also be harbingers of a structural injury like a stroke. Cerebral NIRS Measuring regional saturations is also often done, particularly in the cardiac units, in patients that have the thinner skull, and can also primarily be used to look for either asymmetry, or what's also used is a decrease of 20% from baseline, again, suggesting that further workup. And then last is imaging. Of course, this will tell you if you're doing a CT, if there's a hemorrhage, less sensitive for stroke, and the main downside here is can you get the patient to the CT scanner? Some of the optional modalities, which we'll touch on briefly, are SSEP, transcranial Dopplers, brain injury biomarkers, and pupillometry. So just taking these one at a time. So neuroimaging, again, we talked about this. So head ultrasounds, they're easy, they're portable. We can bring them to the patient. Limitations of them is even with good quality scans, they can still miss significant. If you're missing significant, you're also going to miss subtle intracranial injuries, both hemorrhage and ischemia. There was one study that looked at 50 neonates, and the MRI obtained after ECMO showed that 50% of the newborns with a normal head ultrasound had abnormalities seen on MRI. Head CT we do have portable CT scanners. They are easier, of course. You don't have concerns bringing the pump in, and we perform them when not frequently, but when we think there are findings that could change ECMO management. Particularly, there's been a change in exam. Someone has a new focal deficit, pupillary changes, findings on head ultrasound, or findings on EEG. Compared to MRI, it's of course going to be less sensitive and specific for ischemia, and also some of the microembolic or microhemorrhages that can be seen on MRI. And this is, again, just showing that in a nationwide evaluation from neonates, there was about a 17% rate of brain injury by head ultrasound. No changes that were really noticeable in terms of percentage with normal versus abnormal head ultrasound over time. Like most of the data here, looked at, so 46% of patients had a head CT, and so you're looking at an enriched sample here. 60% of those patients had pathology, either infarction or hemorrhage being the primary findings. One of the main risk factors that they found was initial serum lactate. And this has been our experience here as well. The sicker you are going on to ECMO is generally been where we see the higher risk of particularly early neurologic injury. So our patients with shock, sepsis, when they go on, we tend to see more early ischemic changes on neuroimaging. And when you see those changes, abnormal neuroimaging, it's of course going to be associated with lower survival and worse outcome scores. So this neuroimaging is something you do intermittently. You can do it daily for head ultrasounds with significant change for CT. EEG is nice because you can do it continuously. So you have a continuous monitor on the patient. You can do both EEG and NIRS monitoring if you wanted to. There is room. This is just showing one of our term neonates who had an electrographic seizure. And you can see we're picking it up here both with a full montage in this patient as well as with amplitude adjusted EEG, which can be done with fewer electrodes and is often done in our neonates. The EEG can provide actionable information. So the most basic finding that you'll have on it is a seizure. Seizures are common in the ECMO population. And in patients that have a seizure, 90% of those patients, it's electrographic, right? A lot of times these patients are muscle relaxed. You'll have very few physical exam findings that you can even follow. And so this is where continuous EEG can really play an important role. And then in addition to seizures, you can look for other more subtle findings. And I highly recommend involvement of neurology and talking to your EEG techs who are monitoring this continuously to let them know that what you're looking for. So asymmetry, focal abnormalities, changes in background, and those can also be on a spectrum, but at the highest level, seeing voltage attenuation. Transcranial Doppler is one of these things that has a lot of interest in it, but really hasn't shown to improve or change management, change outcomes. But it is something that I think physiologically is an interesting study. I hope it does lead somewhere. Essentially, what you're looking at is blood flow velocities, typically incidentating the middle cerebral artery and comparing that to flows in the carotid arteries. There have been a couple studies. I would say the most well-done studies have been by Nicole O'Brien and Mark Hall at Columbus. This was a study in 18 newborns and children. And they found that in patients with hemorrhage, they had supernormal systolic blood flow velocities, often days before the hemorrhage was recognized. And so whether or not this this signal will continue in larger and prospective studies, I think will be interesting. Another application of TCD is to use it more as a continuous monitor. And a lot of this is extrapolated from work that's been done for patients on pump in the OR, where you can continuously insonate, for example, the middle cerebral artery, and look for what you see here, this bright spot here, the signal. This is a microemboli. So it could be a tiny clot, tiny air bubble. And again, if you're seeing this for someone who's on a extracorporeal circuit, concerned that they may have be at risk for a neurologic injury. They do make head devices that are made to be worn for long term. They even have computer operated devices that can adjust with the patient to optimize the signal. Again, not widely adopted yet, but I think potentially one of the future applications. Cerebral NIRS is another continuous monitor. Again, advantage is it's non-invasive, it's continuous, can be used in conjunction with other abnormalities. Limitations, it's not great as a quantitative measure. It does have poor reproducibility, but you can use trends potentially as helpful data. And considering how often we use it, my editorial statement would be, I'm disappointed that we don't have better data for it. But again, I think it can potentially be used to guide further studies with NIRS. This is just one of the studies, again, looking at where they compared NIRS in survivors for ECMO and non-survivors. And what you can see is that the change of 20 or greater is what really was associated with risk of non-survivorship, and any values below 50% were also associated with decreased survival. One of the potentially really cool areas that may extend from other indications like trauma to the ECMO field are plasma biomarkers. We have biomarkers for all sorts of organ injury. We have LFTs, AST, ALT. We have creatinine for the kidneys. We don't have that for the brain. But what we've learned over the past really decade, 15 years, is a lot of these brain injury biomarkers can be detected in the plasma. And I've listed some of them here on this slide. Some of the biomarkers are associated more with neuronal injury, blood vessel injury, or glial injury like astrocytes. From other types of brain injury, we kind of know their normal trajectory, so they're not immediate, but often for things like UCHL1, which is a neuronal biomarker, GFAP, which is an astrocytic biomarker, they peak within 24 hours, sort of like a CRP or a procalcitonin. So they can be useful. And a lot of times you could have brain injury that's clinically detected, as we talked about, days later. So this might be a better sort of early warning system than just our physical exam. This is a study that measured some of these biomarkers. These graphs show GFAP in patients that had or did not have acute neurologic injury. And you can see just the graphs are a little tricky because you have to adjust for the scale on the y-axis. But for many of the patients with acute neurologic injury, GFAP was elevated within a day or two of that injury. It's not perfect though. You can see some patients had neurologic injury with totally normal GFAP. So not a panacea, but potentially another tool that we can have. And for these biomarkers, we would be looking more at a panel. What's nice is that they're now FDA approved for other indications. So we have GFAP and UCHL1, both have FDA approval for detecting traumatic brain injury in patients. It's not really widely clinically adopted yet, but it is moving that way. And we even have now iStat devices, so it can be a point of care test to measure these biomarkers. In addition to brain injury biomarkers, we can do things like look at inflammatory markers. Again, a lot of the sepsis patients, they have shock, they have endothelial activation. These are patients where we've seen early neurologic injury. This is just looking at a panel of 4 cytokines, interferon gamma, IL-6, IL-1 beta, and TNF. And both are higher in patients with abnormal imaging as early as day 1. And you can see here, these graphs here. So potentially a panel of biomarkers may be useful. And remember, why do we care so much about shock and endothelial activation? Well, particularly if we do a neck cannulation, we have a big cannula sitting in the right carotid artery, pointing down to the aortic arch. We're really relying on collateral flow through the circle of Willis, through these small arteries from to perfuse the right side, the right hemisphere. You have to go through these, anterior communicating artery, posterior communicating arteries to be able to get that collateral circulation. So any changes in flow through those arteries could be very clinically meaningful. So I'm going to just jump ahead so I don't go too much or don't go too over time. What are some neuroprotective strategies? Again, a lot of this is not, I'll say it up front, is not evidence-based, sort of more personal opinion in terms of blood pressure targets. So post-arrest, the AHA recommends that you should maintain a systolic blood pressure greater than the 5th percentile. A lot of times with ECMO, of course, we have decreased systolic blood pressure. We're looking at mean arterial pressure. Can we use things like NIRS to optimize our blood pressure targets? So there's this concept of mean arterial pressure optimal. And optimal meaning, where do we have the optimal degree of autoregulation? So this is just a cerebral blood flow and mean arterial pressure curve. What happens when our blood pressures are low is our arterioles can dilate to maintain cerebral blood flow. When our blood pressure is high, they constrict. So you get this area of autoregulation. If you go above that, you have increased cerebral blood flow, maybe at risk for hemorrhagic injury. If you go below that, you have decreased cerebral blood flow at risk for ischemic injury. So can we define this using NIRS? And there's some studies that say maybe. So essentially what you're looking for, if you have good autoregulation, you should have a low correlation between your blood pressure and your cerebral oximetry measurements. If you have high correlation, it means you're either at the high or low end of that scale. So this is just a regression progression, looking at where is this relationship lowest. And that would define your mean arterial pressure optimal for this patient. So can we essentially personalize it? And again, the studies here are just really starting to come out. There's a group at CHOP who's doing this with some more advanced NIRS measures in the neonatal population. So I would say this may be an area we are going. Again, it's not clear that MAP-OPT is the right target, but this is as opposed to just looking at other measures of organ perfusion, but it is an area where the field is going. In terms of management of CO2 and O2, there's been a lot of concerns, again, with observational data that hyperoxia is a risk factor for neurologic injury. It's really easy to make a patient hyperoxic when you have a great new oxygenator on the circuit. So trying to avoid that and targeting SATs, similar in some of our neonatal post-arrest guidelines of 94 to 98%. And then another concern that's been raised when patients go on pump is, particularly if they have respiratory failure and hypercarbia, if we lower their CO2 too quickly, is that going to lead to cerebral hypoxia from vasoconstriction? Again, I would say not great data. It's something that we can, but I don't see really any harm with trying to come down slowly with the CO2. And then last two things. One, just want to bring attention to an interventional study that's going on, led out of Boston Children's, called the Hydrogen Fast Trial. It's a helium hydrogen trial where they blend hydrogen into the circuit just at 2%. So you're not really, you can still have a lot of room if you need a higher FiO2. It's a phase 1 safety trial, essentially. So hydrogen is a powerful reducing agent. It's a proposed mechanism of action. There was a similar trial that was done in adults for out-of-hospital cardiac arrest that was halted due to COVID, but it showed some good benefits in terms of secondary outcomes. So a higher proportion of survivors had a normal Rankin score and higher 90-day survival. So something we may see potentially in the future. And last, we get a lot of questions about what should our temperature management be, particularly if in ECPR patients. And I would say that really the data would strongly support targeted normothermia. Hypothermia, really no evidence of benefit if we look retrospectively at patients in the THAPCA trial who had ECMO support or within the ELSA registry. Neonatal HIE patients who are already on hypothermic management, I think that's an area of active investigation. I'll skip this one, unless we have more time, but should I skip ahead? Okay. This is, again, just an area that I think might be interesting for the future. So we talked about MRI and benefits of MRI for detecting neurologic injury that's not seen by other methods, head ultrasound or CT. This was a patient in our cardiac unit who had focal neurologic findings, and so went for CT, and they had a CT angiogram performed. And what you'll see is that there is blood flow to both sides. There is asymmetry. It's subtle here on the right where you have decreased perfusion, but all of the large blood vessels were all open, had contrast in them. And so it was unclear if we should really act on this. Should we try to get the patient off more quickly, change our ventilation strategy or what? But the CTA was a little bit falsely reassuring, because when we got the patient off pump and got an MRI subsequently, they had a large hemispheric infarct. So could we potentially do better? And what we're looking at here at Children's is the use of CT perfusion. So this is for patients, again, you can't bring the pump into an MRI scanner, but can we do perfusion scanning? So CT perfusion is done all the time in adult hospitals. It requires technologist training, some software, and some other things to be able to bring it to the Children's Hospital here. It's not been done frequently in the past because of concerns for higher radiation exposure to children, but the amount of radiation exposure has come down very significantly over time with these scans. It's about 10 times now, 5 to 10 times what a normal CT would be. But if it can give you actionable intelligence, I think most people would take that trade-off. So one potential for advanced scanning in the future for these patients. And then last, I want to bring attention to one of our former fellows who's now at Children's Mercy, who got an AHA grant to look at these ultra low field MRIs in ECMO patients. Really cool idea. So normal MRI scanner would be a 3 Tesla, maybe 1.5. These are like 0.1 Tesla. So not going to pull anything into the scanner. They're very safe. And even though the quality of the MRI is not going to be quite as high, again, because of the low magnetic field, it is certainly going to be better than a CT. So this is a patient, CT is here, and then the MRI showing diffusion weighted imaging here, clearly highlighting areas of abnormality. So that's all I had, and happy to take any questions.
Okay, we do have a couple of questions in the chat. What are your thoughts or recommendations or your practice for reducing neurometabolic needs early post-cannulation? So heavy sedation and paralysis, seizure prophylaxis, et cetera.
Yeah, that's a good question. So, so all of our patients typically are going to be sedated and muscle relaxed after they go, particularly after they go on ECMO, so in the early period. And they're going to be on a deeper level of sedation because, again, because they're muscle relaxed. I would say we don't necessarily have metabolic targets. It's an interesting question. We do do early EEG for patients that go on to ECMO, which has been shown to not only pick up more seizures, but pick them up earlier, right? Because you're not relying on just clinical findings, changes in heart rate, changes in blood pressure, or pupillary changes. So I would say our main approaches there are, we do sedate. We don't have a metabolic target with sedation, but all of our patients get continuous EEG in the ICU when they go on ECMO.
Thank you. That was the last question. The other comment in the chat is another reference that somebody posted, so it might be of interest to some of our attendees.
Perfect.
Okay, our next guest is a pediatric critical care physician. Is Caitlin McNamara. She'll be here with us in person today.
Lower that. Hi, everyone. I'm Kate McNamara. I'm one of the PICU faculty, relatively new, and my focus is on neurocritical care. So I'm going to talk about the pediatric neurologic complications in pediatric ECMO, which are the leading causes of morbidity and mortality, with up to 50% of patients experiencing some neurologic complication. I have no disclosures except for the fact that after this presentation, you'll be able to tell that I've been trained by Dr. Simon and that this presentation is quite similar in content. So for the next 15-ish minutes, we'll be talking about what are the common complications, what are the risk factors, what's the pathophysiology, how do we detect and monitor, and then we'll briefly touch on how do we end up treating some of those complications, and what are the related outcomes. So the most common neurologic complications we've talked a little bit about already include seizures, intracranial hemorrhage, embolism, ischemia, and edema. These complications are interconnected. If ischemia or hemorrhage occurs, then seizures and edema are likely to follow. Embolism can lead to ischemia, which can then progress to hemorrhagic transformation. So once you have one of these complications, vigilant monitoring for the others becomes really critical. And this interconnected nature makes prevention and early detection, which we've already talked about, all the more important. Seizures occur in about 20% of patients on ECMO, and this is notably higher than the rates of seizures in adult ECMO due to the neonatal population who have a higher seizure risk due to brain and neuronal immaturity, as well as lower seizure thresholds. Most seizures, as we've talked about, are subclinical, meaning they have no visible clinical signs. And most of that is probably compounded by the fact, like we've talked about, that we have those deep sedation and paralysis strategies necessary for ECMO management in the beginning, which then masks any outward seizure activity. And then perhaps most concerning is that half of the patients who seize go into status epilepticus in the first 24 hours of ECMO. And the longer a patient seizes, the harder and more challenging it is to treat. And so as I mentioned previously, seizures are also associated with other intracranial pathology and are also associated with worse outcomes. And I think that that's multifactorial. First, there's the underlying pathology that causes seizures in the first place, whether that's ischemia, hemorrhage, primary. But beyond that, seizures themselves can also cause harm because they dramatically increase the metabolic demand with oxygen and glucose consumption, increasing up to 2 times during a seizure. And in the setting of an already injured brain with a compromised perfusion, this creates a mismatch between supply and demand, leading to secondary hypoxic ischemic injury and cytotoxic edema. When we start thinking about neuromonitoring, we've talked a lot about EEG already, and this is recommended on ECMO and in post-arrest. In addition to detecting seizures, the EEG background can also provide prognostic and physiologic information. And so changes in that background activity can alert us to evolving ischemia of cerebral perfusion and can also help, again, with that prognostic. There's quite a few studies looking at that too. Interestingly, a paper examining the PHYS database, which is the Pediatric Health Information System, only 62% of ECMO patients had continuous EEG, which is really interesting considering the ELSO guidelines, as well as kind of the risk of seizures in this population. Our typical protocol, though, is to place the continuous EEG on as soon as possible, and which is supported by a study that showed that with that change in protocol, they saw a decrease of patients once they got on EEG. They had 62% of their patients having being in status epilepticus when they first went on, and then after the protocol, 0% of their patients were in status epilepticus after that protocol of adding continuous EEG standardized. There are definitely disadvantages to EEG. Neonatal EEG can be notoriously challenging to interpret. So you'll have someone overnight saying there's no seizures and someone during the day saying there are. EEG interpretation can also be altered by factors unique to ECMO, such as fluid overload, which is common in ECMO patients. That causes that scalp edema, increases the distance between the EEG electrodes and the cerebral cortex, which can lead to voltage attenuation, and that mimics a pathologic pattern, which then could lead to unnecessary imaging. Similarly, changes in cerebral blood flow from cannula positioning or ECMO flow rates can also alter EEG patterns, though arguably that would be more concerning for an actual pathologic blood flow that could impact outcomes. And while not intracranial in nature, but still important, EEG leads are the leading cause of skin breakdown and pressure injuries in our CICU and PICU right now. So it's something that we're always thinking about in terms of the pros and cons of utilizing the EEG at that moment. So is there a way to prevent seizures? Someone had kind of asked about seizure prophylaxis, and it's a logical consideration. But fascinatingly, there's no evidence on the utilization of seizure prophylaxis in pediatric ECMO or post-arrest. And the minimal evidence in adult data does not suggest any benefit. So currently, seizure prophylaxis is not in the ELSO ECMO guidelines or in the AHA post-arrest guidelines. Both suggest treating seizures when they happen versus prophylactically. That being said, our institution's post-cardiac arrest guidelines recommend prescribing Keppra, and this represents, our institutional practice based on our expert consensus. But we definitely need to look into more data to see if that can be actually helpful. Intracranial hemorrhage occurs in about 16% of pediatric ECMO cases. The most common types include intraparenchymal, subarachnoid, and subdural hemorrhages. These can occur at any time on ECMO, but the highest time frame of incidence is in the first 72 hours. That timing likely reflects the period of most aggressive anticoagulation strategies combined with peak hemodynamic instability. Hemorrhage, unsurprisingly, is associated with increased mortality, poor outcomes, and seizures. And risk factors for hemorrhage include younger age, particularly the neonates who have more fragile cerebral vasculature and immature coagulation systems. And then also thrombocytopenia and coagulopathy are obvious risk factors giving the bleeding mechanism. And like Dr. Simon already noted, a higher pericannulation lactate and a lower PO2 in the first 24 hours of ECMO are associated with intracranial hemorrhage, which suggests a higher severity of illness. So sicker patients with more profound shock or hypoxemia may have already had that microvascular injury that predisposes to bleeding. Unfortunately, there's no specific anticoagulation strategy that has been shown to decrease the risk of intracranial hemorrhage. In observational studies, platelets below 100 and fibrinogen levels below 200 are associated with increased bleeding risk. So most protocols suggest these thresholds while on ECMO. When intracranial has occurred, it is recommended to decrease anticoagulation, putting the wrist circuit at risk for thrombosis, which then often means discontinuing ECMO as soon as we can. For detection of intracranial hemorrhage, we've discussed at length near infrared spectroscopy or NIRS, which has been shown to be able to detect extraaxial bleeds greater than 3.5 mLs, but would probably be more challenging for intraparenchymal hemorrhages. NIRS works by using the infrared light to measure the relative concentrations of oxyhemoglobin and deoxyhemoglobin in the brain tissue, reflecting that oxygen supply and consumption. So a sudden drop, so that trend in cerebral oximetry and NIRS can indicate intracranial pathology. In children with open fontanelles, a head ultrasound can be performed at the bedside, which is nice because it's quick and non-invasive. And most of our protocols say to do it daily for the first couple of days. But it has limited sensitivity for those smaller hemorrhages and ischemia and can't really visualize the entire brain, unfortunately. That posterior fossa is often missed. Currently, a head CT is our current gold standard for while on ECMO. And thankfully, we have a portable CT, which makes it the transport and kind of the risk associated a little bit more limited. Ischemia is one of the most common complications on ECMO neurologically, occurring in up to 33%. And the pre-ECMO scenario plays a huge part in those rates of ischemia. Many patients require ECMO after prolonged cardiac arrest or severe hypoxia, meaning they've already sustained significant hypoxic ischemic injury before ECMO even starts. The clinical presentation of ischemia can be varied with focal or diffuse neurologic signs. So, weakness on one side or altered mental status. But that can be challenging to assess when we have heavy sedation and paralysis. Seizures occur in 30% of patients with ischemia. And the most common ischemic locations include the cerebral cortex, particularly those watershed areas between arterial territories, followed by cerebellum, brainstem, and basal ganglia. The basal ganglia is particularly vulnerable in hypoxic ischemic injury because of the high metabolic demand of that area. If the ischemia is not from pre-ECMO insult, then there are also multiple aspects of ECMO that can lead to ischemia. First, a thrombotic embolism is highly possible. ECMO circuits are highly prothrombotic, hence why we use anticoagulation in the first place. Air embolism is also possible, but much lower rates than thrombotic. There are also hypotheses that while on VA ECMO, the lack of pulsatile blood flow can lead to endothelial dysfunction, disruption of that cerebral autoregulation. So normally the brain maintains that constant blood flow across a wide range of blood pressures through autoregulation, but that pulsatile blood flow seems to possibly be really important for that mechanism. And so the continuous non-pulsatile flow from ECMO may impair that, leaving the brain vulnerable to kind of that graph that Dr. Simon showed of kind of hypertension leading to hemorrhage or hypotension leading to ischemia. Interestingly, we've also talked about this, the magnitude of the change in CO2 levels, the difference between pre-ECMO and CO2 and post-ECMO CO2 has been shown to be associated with ischemia in observational studies. And CO2 is a potent regulator of cerebral blood flow. So a rapid decrease in CO2 then leads to severe intracranial vasoconstriction, is the hypothesis, in a brain that is often already taken a hypoxic or low perfusion hit. So slow controlled CO2 normalization after cannulation would be recommended. Additionally, the cannulation strategy can also lead to ischemia. The most common location of cannulation for VA ECMO is the right IJ and right carotid, which means the right carotid, which supplies the right side of the brain, is being sacrificed or flow reversed. And for those who haven't thought about the circle of Willis, so we did mention it, it's really an anatomic safety net, right? Because of all those connections between the major cerebral arteries on both sides. And that redundancy, if one vessel is compromised, can, we lose that redundancy. And interestingly, the circle of Willis is also not complete in every person, which we don't know pre-cannulation. And so if someone has an incomplete circle of Willis and you cannulate the right carotid, the right hemisphere might not be receiving that collateral flow, which could then lead to a watershed infarction. And even if you have an intact circle of Willis, perhaps the metabolic needs of that right hemisphere are not going to be met by that collateral flow. So lots of different things to think about. But even if we're femorally cannulating, we also face a different risk. As cardiac function is recovering, patients are at risk for Harlequin syndrome, or also called north-south syndrome, or differential hypoxemia. And as the patient's recovering heart is ejecting deoxygenated blood that preferentially perfuses the upper body, including the brain, while the oxygenated blood from the ECMO circuit goes to the lower body. Again, NIRS and EEG are important resources. And so as cerebral perfusion decreases, the EEG loses faster frequencies and then increased slower frequencies, followed by suppression. And so those are more subtle changes that we should really be trying to talk to our neuro and EEG colleagues to try to detect earlier. And perhaps with the rise in quantitative EEG, that could also be something that we might be able to detect in real time for detection of intracranial pathology. And then finally, as I did a preview there, I wanted to talk about the most devastating outcomes that can occur after any of these neurologic complications. In the ELSO database, around 6% of pediatric ECMO patients were diagnosed with brain death, so a real possibility, unfortunately. And this underscores why vigilant neuromonitoring and early intervention is so critical. There was a new 2023 national brain death guidelines, and at CHP, literally a month ago, our brain death guidelines have changed and been rewritten to be more consistent with that. And I think importantly, we often think that it's more challenging to diagnose brain death while on ECMO because the circuit is doing the whole work of the lung and the heart. But it definitely can occur, and that aspect, definitely off sedation. But an apnea test can occur on VV ECMO more easily by turning down the sweep and oxygenation, which allows for a more classic test of monitoring for spontaneous breathing and a CO2 rise up to the target level of 60 or 20 points above baseline. While on VA ECMO, you titrate the sweep gas to a level of hypercarbia, and then followed by monitoring for spontaneous breathing and a decrease in the CO2 levels, indicating patient-initiated ventilation. So to bring this full circle, neurologic complications in pediatric ECMO are unfortunately common, very interconnected, and associated with significant morbidity and mortality. So our approach should be multimodal, combining all of these different things we've talked about: EEGs, NIRS, imaging, and we didn't mention, but sedation holidays to do those neuro exams. And that is all I have. So happy to answer any questions.
Thanks, Kate. One quick question for you. When we're talking about increased CO2s right after we go on ECMO and how we like to have a slow controlled drop in the CO2. So from like a perfusion mindset or an ECMO specialist mindset, the idea is you look at this CO2, you plug it into your sweep calculation, and you just target 40. So what is the best approach that we can take? And also what can we add when we're educating our people? Like how slow should we be bringing down our CO2? And, how can we drive that home with our people? Like the importance of that slow controlled wean. Like you don't want to go from 70 to 40 with one quick sweep adjustment. How can we, work together to create something that is, go this many points over this amount of time and stuff like that? Do you have recommendations for that?
Yeah, unfortunately, there's not any studies that have looked at kind of the time frame of that. And certainly something that could be probably easily done. But I think that it's also very patient scenario dependent, right? Is this per someone who has had a prolonged arrest? So they're already have that ischemic hit, so we're already at risk for edema. And so I think that unfortunately I don't have a standard thing to tell you, but more that this should at least be a conversation, right? After we've gone on ECMO and are starting to go through that plan, I think this should be a conversation with all the providers to say, okay, this is our goal for the first hour, or this is, I'm really worried about dropping the CO2 too quickly. And I think it's not something that I commonly, we talk about regular targets, but we don't talk about that as much. So I think it's something that should be part of that initial kind of plan making at the bedside.
Okay, any other questions? Okay, we're going to keep on track. We're doing good time today. Our next guest is Elizabeth Bentoncourt. She's from our physical therapy team, and it's neurodevelopmental outcomes and pediatric ECMO. All teed up.
Thanks, everyone. Looking forward to being here today and talking a little bit about our neurodevelopmental outcomes. And I think when we think about outcomes, it's not a matter of just the patient's time on ECMO, but looking at their clinical course and where they were leading up to the circumstances that landed them on ECMO, and then after that. So I want to talk a little bit about it in a broader context today and kind of bring to the table some considerations that we can do from an environmental standpoint that can supplement the interventions that are being done from a medical standpoint. I have no disclosures, so I just want to talk a little bit about the factors impacting neurodevelopment and strategies to promote neuroprotection at some of those critical time points. Talk briefly about the current literature that's looking at neurodevelopmental outcomes specific to pediatric ECMO patients, and then just talk a little bit about what we're doing here with our programming to support and follow up with patients that are pediatric ECMO survivors. So even thinking prenatally, especially for a lot of our cardiac patients, we are starting from a basis of a high likelihood of decreased brain volumes. Brain maturation can be delayed in patients with congenital heart disease by up to a month. So similar to brain development in a premature newborn, a term neonate with congenital heart disease can have delayed brain maturation. We frequently see impaired brain metabolism with an increased likelihood of structural brain abnormalities and brain injuries. So a lot of these babies, maybe even well before need for pediatric ECMO, already have a structural brain abnormality or insult on neuroimaging. And then we also, of course, have to consider, placental function and oxygen delivery, as well as the risk of infection. There's also maternal factors that are going to impact our patients' neurodevelopment, maternal nutrition, maternal stress, environmental toxins, as well as social determinants of health. And then what happened to the baby in their delivery room experience. So whether a standardized approach was used, if they required delivery room resuscitation, what the cerebral physiology was in the delivery room, delayed cord clamping, delivery timing, close attention to thermoregulation and whether they had an opportunity for kangaroo care prior to being transferred for a higher level of care. Preoperatively in a hospital environment, we're looking at interrupted sleep, frequently excessive noise levels. The recommended noise exposure for a newborn is less than 45 decibels, which is just quiet speech. So all of us that have been in a ICU know that pretty much all day long, their noise exposure is higher than that. Abnormal light exposure. So the recommendation is for natural light during the day with cycled lighting, a clear differentiation between day and nighttime. And then our patients often have limited opportunities for skin to skin and positive touch. Not going to talk much about the perioperative factors. I think that's probably discussed, much, but just to kind of think about that surgical timing and the impact of the patient's gestational age at birth as it relates to their need for surgery. Preemies, infants that are born preterm generally do worse than term patients. And then there's several studies right now that are looking at age at surgery for different cardiac interventions and what that impact is on their long-term neurodevelopmental outcomes. Obviously, the type of perfusion and the risk of anesthetic toxicity will impact long-term neurodevelopment. And then post-operatively, the risk of unstable hemodynamics and cerebral oxygen delivery. Obviously, there's been a lot of talk about the increased risk of seizures, cardiac arrest, and then leading to risk for ECMO requirement. Often there's prolonged mechanical ventilation. These babies, especially once they have the ECMO requirement, have significant exposure to sedation and analgesia in the setting of neuromuscular blockade, and then as they're recovering, a higher risk of delirium. And then stepping back to kind of think about the environmental factors that our patients are exposed to. They have frequent noxious stimuli, so a lot of the touch that they are receiving is noxious. I mentioned the noise levels earlier. Frequently, there's tissue edema, which is impacting range of motion and impacting the baby's ability to move through a full range of motion. A huge consideration is family anxiety and stress and how that impacts the family's ability to interact with their baby. We know that parent interaction is protective, but if the family is experiencing high levels of stress with inadequate support, it often is a barrier to them being able to engage and be present at bedside during a critical period in their baby's development. And then especially with muscle relaxing, babies are often left in gravity dependent positioning rather than the preferred physiologic flexion of the newborn. So how do we mitigate risk? What are we doing to address the factors that we can control? So thinking about neuroprotective strategies kind of at every interval along that continuum of care. In our institution, we have weekly neurodevelopmental rounds, both in our cardiac ICU and on our step-down unit. And we have a neurodevelopmental care plan for each patient with specific recommendations based on their current medical status and developmental age. And then an emphasis on family-centered care. So we have a dedicated neuropsychologist available to support maternal mental health and work with our parents to give them adequate support so that they're equipped to be resources for their infants. So some of the categories that we can have a practical impact on as far as neuroprotection, sound. So being mindful of keeping noise levels down when we can. Sound machines are great, but often I walk into a room and there's a sound machine right next to the baby's head that's turned up full blast. So while the idea is great, let's get a sound machine in there to kind of override some of the background noise. If it's right next to the baby's head, we're kind of working against the goal that we're trying to accomplish. So just educating our staff on, if you're going to have a sound machine on, make sure it's 7 to 10 feet away from the baby. If you're going to have music playing, make sure that we're thinking about the volume of that music. Let's make sure that the speaker's not right next to the baby's head. Also making sure that the baby's getting positive sound experiences. So if the parents are available, having parents sit and talk to them so they're hearing the parent's voice. If parents can't be bedside, having volunteers sit and read books to that infant so that they're getting exposure to normal speech and language as well. Lighting, I touched on briefly earlier, but same thing, cycled lighting with lights on, natural light during the day, focus on dim lighting at night. Another thing that's often, I think, overlooked in the moment is if there's procedural lighting used for something, making sure that the baby has eye protection on. It's a really little thing, but it can make a significant difference to the child's experience of that moment. And then sleep, there's significant sleep disturbances in an intensive care setting, and even in a step-down setting, but trying to cluster cares as it's appropriate based on the child's medical acuity, and trying to protect sleep as much as we can is a goal. Optimizing nutrition so that the child has adequate calories. There could be a whole talk about that. And then kind of central here, I have family involvement, because I think that's one thing that we can do that will impact not just the child's experience in the moment, but has one of the biggest impacts on their long-term trajectory. So empowering a family to be present and help to implement some of these things that are going to help support their child in the ICU when there's very little that family can do. If their infant's on ECMO and sedated and muscle relaxed, as a parent, that takes away a lot of agency. So empowering parents to have a role during that time, whether it's, they're in charge of sitting and reading to their child, they're in charge of making sure that the lights are getting turned off at night before they leave. Maybe they're in charge of some containment if the baby needs to have a extra stick or something. The parent can come over to the bedside, put their hand on that baby's head and let them know that they're there. Giving parents back some of that agency and restoring their role can be crucial to establishing the bonding that they need to really optimize care for that infant down the road. And then keeping our patients comfortable. So regularly assessing for pain using pharmacologic and non-pharmacologic interventions. So I think as an institution, we do a really good job about pharmacologic institutions, and we're really working to educate about the options that are out there for non-pharmacologic pain management. So things like providing positive touch prior to procedural touch. So what that might look like is if a baby needs to get an IV placed and they're sleeping and swaddled, instead of just unwrapping them and starting the procedure, taking 30 seconds before and putting our hand on the top of their head and on their chest, letting them know that we're there, telling them verbally what we're going to do, and then slowly unswaddling. I have four-handed care up here, and that's the idea that there's one caregiver, whether it's a medical provider or a parent, that's solely responsible for the baby's comfort during the procedure. So that person may just keep that positive touch during the procedure that needs to happen. That person may offer a pacifier for like a positive oral experience and non-nutritive sucking. But there's one provider that's just focused on supporting the baby, while the other provider is focused on whatever medical intervention needs to be done. And then thinking about positioning, there's lots of documented benefits of positioning, you know, all the way through decreasing metabolic demand. But the iPad is a positioning assessment tool that is just a quick visual that can help kind of optimize what position we would like the babies to be in for optimum comfort. So they're head aligned and midline. The idea is basically we want them coming in towards the middle. We want them tucked. We want boundaries in place to support that if the baby isn't able to support that position themselves. And to speak a little bit to neurodevelopmental outcomes, specifically in our ECMO population. This systematic review was just published this year. They reviewed, I don't know, it was well into, I think maybe 8,000 studies. There were 8 that met their inclusion criteria, representing 302 patients. And one of the biggest conclusions was the impact of pre-ECMO clinical status on long-term neurodevelopment. So what conditions and situation led that patient to require ECMO in the first place? Most of the studies demonstrated a motor impairment, specifically gross motor, as the most significantly impacted domain of development. But interestingly, it was noted in looking at various studies across the board that the early assessments weren't always predictive of long-term outcomes. And I think this is encouraging because babies that maybe didn't look so good initially, but were identified and given adequate supports and services often showed very good recovery. So I think that's one of our goals, is recognizing impairments early so that we can provide appropriate supports and services to those patients. So in Kadir's study in 2022, 62.1% of their patients had gross motor impairments, and 10.3% had severe cognitive impairments at their 12-month follow-up. But DeLeo did a study published in 2019 that looked at patients at a mean interval of 19.72 years post-ECMO, and they reported that 90% of the long-term ECMO survivors had no disability based on self-reporting. There's obviously a little bit of bias because it was a self-reported study. It wasn't a clinician-administered exam, but even still, I would say if 90% of people that have survived ECMO don't perceive themselves as having limitations, that's a nice goal to work towards. Neurodevelopmental recovery depended on multiple factors across the studies that you looked at. The length of follow-up was significant. So earlier follow-up times were associated with more impaired outcomes, and then the type and timing of interventions that the patients received along the course post-ECMO cannulation. The severity of their underlying cardiac condition and their comorbidities definitely contributed, as well as the duration of mechanical circulatory support. This study that looked at, again, early neurodevelopmental outcomes in children supported with ECMO for cardiac indications, they found correlations between poor outcomes in patients with older age at first cannulation, and then more cardiac catheterizations and more cardiac operations. 44% of ECMO survivors in their cohort had CNS injury documented by neuroimaging. So that's pretty significant. And then I think the other thing that this study reported that I think is important for us to consider is hearing loss was seen in 25% of their ECMO survivors. So making sure that we have standardized screenings in place for our patients post-ECMO and are considering the impact of hearing loss on speech and language development, which can then also impact cognitive development as well. This was a single center's experience with some long-term follow-up of their ECMO populations. And this kind of supports the other studies that showed that impairments did not necessarily persist. So patients that had higher Piper Plus scores were correlated with lower Bailey scales of infant development, which is a pretty standard measure of multi-system development in pediatric patients. So the sicker patients pre-ECMO had lower developmental scales at their 12-month follow-up, but by 24 months, that association was no longer present. So knowing the importance of long-term follow-up and appropriate supports to these patients, we at our institution established a dedicated cardiac neurodevelopmental follow-up clinic. It was established in June of 2024. And as of June of this year, we had 40 patient visits representing 35 unique patients. We had seen some return patients. 5 of those patients had a history of ECMO. And we are using the Bailey as our primary neurodevelopmental outcome, standardized outcome. And one of the biggest goals for starting the clinic was making sure that our patients are receiving appropriate services. So in our first year of the clinic, 40% of the patients that we saw received new referrals to therapy. So for services that they weren't currently getting, they were referred. Nearly 20% of them received orthosis prescriptions. So some kind of orthoses to promote improved biomechanics with standing or walking. And then 10% of them received durable medical equipment referral. So that, may have been a wheelchair, a bath seat, a mobility device. And our goal is ultimately that all of our ECMO patients are seen in this clinic or our neonatal follow-up clinic, and that we're having consistent follow-ups so that we can ensure that they're referred for services that they need and equipment that they need in a timely fashion. So just to kind of close, I think the 3 main takeaways: neuroprotection is crucial at every point in a patient's trajectory. Early assessments don't always predict long-term outcomes. And early screening and intervention is crucial to optimize long-term neurodevelopmental outcomes in our ECMO survivors. Thanks.
All righty. On track again. So our next speaker, it will be Caitlin Jenkins from our PT, and she'll be speaking on benefits of early mobility on ECMO, which is always a hot topic. Just so you know, after she gets done speaking, we'll just I'll come back up. Then we'll probably go ahead and take a little break, have everyone go get their lunch, and then we're going to have our keynote speaker at that time. So just so everyone knows. So don't run off after this talk. I'll come up and give everyone an idea of what we're going to do next. So without any further ado, okay, thank you.
Good morning. Thanks for having me this morning. I'm going to talk about a little bit, tagging off of Elizabeth's talk about the benefits of early mobility on ECMO. I got it. I don't have any disclosures. These are the learning objectives I'm going to talk about today. I'm going to talk about the evidence and the feasibility of early mobility, specifically in pediatric ECMO, recognizing the considerations, the precautions, and the contraindications for mobilizing on ECMO, describing the role of the multidisciplinary ECMO team in coordination with my team and my department, differentiating between when it's appropriate to do therapy that's in bed versus out of bed versus ambulation, and then identifying some of the challenges and barriers to mobilizing on ECMO. Why does early mobility matter? Some of the things that Elizabeth touched on in our really small neonatal population also applies as the child grows through the continuum of their life. Anytime we have our patients in an ICU on neuromuscular blockade, we're always worried about ICU acquired weakness. So early mobility can preserve muscle mass and reduce any kind of disuse atrophy. It also promotes ventilator liberation and can sometimes reduce the duration of patients being on mechanical ventilation. Many of our patients ultimately end up with tracheostomy, but being mobilized and upright and out of bed can sometimes help them wean off of that as well. Supporting cardiovascular and respiratory function, and also secretion management in coordination with their ventilator settings. Conservative measures to decrease the risk and the duration of delirium symptoms that they may be experiencing after a long time in the ICU. This one's probably my favorite one, setting the stage for an easier transition to a step down or an outpatient setting. A lot of these patients, they're not just in the ICU, they go through our step-through units, they go through our floors, they then go to outpatient, and then they go to our rehab units. They're kind of with us for the long haul, so supporting their transition along each step of the way. And then some of the evidence supports physical, developmental, and psychological recovery in children, as well as shortening their stay overall. These are 4 studies that I looked at to kind of support mobilization on ECMO. I will say that a lot of the literature that's out there regarding mobilization on ECMO, especially since the era of COVID, is focused on adults. There is emerging research coming out with pediatrics and mobilizing pediatric-sized patients on ECMO. However, the research is little. These are the studies that I ultimately looked at, and I think that overall, all of them really kind of came to the conclusion that early and intense physical rehab, physical and occupational therapy can be related to a decrease in the hospital stay and reduction in the duration of mechanical ventilation. Looking at the ELSO guideline, they did a 2024-2025 update about the safe application of early rehab, and their conclusion was that with adequate resources and a highly trained multidisciplinary team, mobilization on ECMO is safe, it is feasible, and it's actually encouraged to include exercise in the patient's plan of care. A lot of institutions are using an ABCDEF bundle, with the E incorporating early mobility. And it has shown to assist with liberating patients on the ventilators, targeting the use of sedation when we're mobilizing these patients or wanting to mobilize these patients, and allowing us to increase participation overall in mobility. So the bottom line of the literature is that overall there's a lack of pediatric literature, but that in the adult population and our patients that are on ECMO that are ultimately adult sized and in their teenage years, mobilization on ECMO is safe with the appropriate resources and an appropriately trained multidisciplinary team. Some of the considerations that we think about before and during mobilization is always going to be surrounding safety. Always want to consider your cannula, the location of your cannula, the security of your cannula, kind of what your cannula site looks like. Has there been any oozing or bleeding? And is it safe to be mobilized with the patient? You also want to think about hemodynamic stability. So any ECMO flow changes that are happening, even just with nursing care, any vasoactive requirements that the patient's needing with nursing care or repositioning prior to doing any therapy. Most of the studies that I read, any of the adverse effects that were coming up with mobilization on ECMO were relating to bleeding at the cannula site. So taking into consideration if there has been any bleeding, if it's possible to be mobilized. And then something that comes up a lot here at our institution is the individualized strength and the level of mobility following a prolonged medical course. We see a lot of our patients that are on heavy sedation for a month, 2 months, maybe at a time. So then once their sedation is lifted, becomes really difficult to just start mobilizing them. Their level of myopathy and polyneuropathies tends to be very significant. So it takes a very long time to kind of start from zero to get to where we need to be and mobilize these patients. That goes hand in hand with the level of sedation that they medically require for their medical complexity. And then an added layer is your airway, whether the patient is intubated or if they have a tracheostomy. Both situations are able to be mobilized, just kind of depends on who you have available, what the settings are, and how the patient is tolerating their care. And then in pediatrics, obviously the developmental capacity to cooperate, thinking about the developmental level of these patients prior to coming to the hospital, the situation that required them to be put on to ECMO, anxiety in these prepubescent or pubescent teenagers is really something to consider and can be a barrier during therapy and during mobilization. These are the members that we utilize of the ECMO team. Of course, the ECMO physician and the surgeon, they're the ones that are going to give my team the clinical clearance and inform us of any significant risk factors, tell us if the cannula site is stable and secure, and ultimately allow us to intervene. Then we have our perfusionists or also our ECMO specialists. They're the ones that are with us at the bedside, monitoring the circuit, doing an ongoing cannula assessment, securing the cannula, helping us kind of brainstorm what's the best way to secure the cannula, and then be present with us while we are mobilizing as needed. Nursing is doing their continuous monitoring of the patient's hemodynamics, their vital signs, any meds or medication adjustments that they may need. And then, of course, the respiratory therapist if you're dealing with mechanical ventilation. And then the role of the therapy team, PT and or OT, oftentimes we work together. Assessing the baseline function of the patient pre and post ECMO, and setting realistic and goals that are able to be accomplished. So you want to determine which level of therapy intervention is most appropriate for your patient, depending on their level of myopathy, weakness, participation, and safety. And then we're able to prescribe age-appropriate in-bed and out-of-bed interventions. And we can do that from all the way as young as the preterm neonate all the way up until the full-size adult. We always try to have one person lead the mobility session, whether it's someone from the therapy team or someone, the ECMO specialist, part of the ECMO team. But really the role of the therapist would be coordinating the staff that's appropriate for a mobilization session, the time and the distance of the activity. So if you're ambulating, making a clear-cut directive of how far you're planning to ambulate, goal setting with the patient and the family, I find is super important in this ECMO population. A lot of these kids are really not motivated in any way. So finding goals that they are motivated to complete and things that they're interested in that will help them work towards that. And then assessing their hemodynamic tolerance to movement, including objective measures. So doing a timeout, a room setup, all those things. Oftentimes, the room setup itself is on the therapist's role as well. If you've ever been in an ICU, there tends to be pumps on one side, the ventilator on the other side of the bed. Sometimes there's pumps behind the bed. And then, of course, the ECMO circuit. So brainstorming what is the best setup to move the patient out of bed, and if you're going to ambulate, how you're going to do that. This is kind of a busy slide, but this is a brief overview of how we differentiate what kind of therapy interventions we're going to be doing with the patient. So we've kind of broken it down into 3 sections: the in-bed therapy, which can include positioning, range of motion, developmental touch, positive stimulation, as Elizabeth touched on. And this can be even when the patient is under that heavy sedation. So this is part of early intervention and early physical therapy, is getting in to see these patients so we can recognize impairments earlier on in their course, and we can address them before they become complicated. So optimizing positioning, promoting tolerance to handling and positional changes. And then before we even make any moves to get out of bed or get into an upright position, making sure that the patient has enough strength, range of motion, and tolerance to do so. And then moving on, we have in-room therapy. So this would include transferring to the edge of the bed, transferring over to a cardiac chair, standing and marching in place, stand pivoting to a chair. A lot of institutions now are using walking pads at the bedside to promote ambulation for kids that are unable to actually ambulate outside of the room. So looking into doing that here. And then assessing appropriate seating device for upright tolerance. A lot of our patients are unable to sit in a regular bedside chair just because of how weak and profound weakness that they're demonstrating. So setting them up with the appropriate alignment in a seating device that is custom for them. And then the last level of our progressive mobility on ECMO is ambulation. So determining their medical stability by the primary medical team in conjunction with the ECMO physician can allow us to kind of work together and determine if a patient's ready to ambulate. Here at CHP, we really want to see the patient be able to be fully awake, alert, following directions, and demonstrate adequate safety awareness before we attempt to ambulate them. And then we need to have them maintain their hemodynamic stability during the other 2 levels of therapy prior to ambulation. So if they're unable to tolerate sitting in a chair, then they're probably not ready to progress to ambulation. Looking at cannula security, so figuring out what's the best way to secure the cannula. Is it a headband? Is it a Foley attachment to their gown? Is it the ECMO specialist holding the cannulas? Is it all of those things? So we, as a team, have to decide what is the best way to make sure that the cannulas are going to be mobilized with us. And then making sure you have the appropriate staff and the staff ability to take on such a task as ambulation. These are just some of the pictures of a couple kids that we've had here, but also some Google images that are out there of patients that are being mobilized on ECMO. These first 2 images are here at Children's. You'll see 2 separate seating devices that we've kind of positioned this patient in. Here in this first picture, this patient I mean, it's the same patient, but at one point he was centrally cannulated. So we were able to do a lot with him. But prior to that, he was peripherally cannulated in his cervical spine or his carotid. So trying to figure out in different stages of this patient being on ECMO, what's the best seating device? What's the best thing that he can be mobilized into? This patient here is just a Google image. This is a new day and age progressive hospital bed, actually, that turns into a standing frame. So this patient is on ECMO and they're able to stay in bed and also work on some standing. And then all three of these pictures here is another patient, peripherally cannulated, working on ambulation with a walker. And I think this is some of the barriers, trying to figure out where everybody goes and where all of the equipment goes when you're ambulating a patient. So working together with your ECMO team to sort out some of those logistics. And these two patients on the right-hand side here, this one's riding a bike on ECMO, peripherally cannulated, and this little baby was 10 months old, using a gait trainer to ambulate. So ambulation, riding a bike, playing basketball, all of these things are possible while on ECMO, as long as you have the staff availability, the safety procedures in place, the equipment, and the resources. And then some of the main challenges that we come across with mobilizing patients on ECMO, of course, cannula security also ties into the anxiety and fear of the patient themselves of displacing the cannula. It's a pretty large cannula, so these patients are aware that it's there. They are nervous that it's going to come out if they move in any way. Where the cannula placement is, the studies that I looked at did report that it is safe to mobilize a patient with central cannulation, femoral cannulation, or carotid cannulation. So thinking about where your cannula is and how to best mobilize them. And then, of course, additional support lines, continuous renal replacement therapy, or an ET tube obviously make things a little bit more challenging, but not impossible. Staffing constraints and lack of trained personnel or the equipment that you need to do ambulation or seating or getting these patients out of bed. A complex medical status, which requires a high level of sedation or a high level of delirium, which causes a safety concern when mobilizing. And then just having inconsistent protocols amongst multiple teams and different units in the hospital. So that's why it's important to make sure that you have these safety procedures and protocols in place with all your teams and all your units prior to mobilizing. And then the last one that I already touched on before was just a lack of pediatric specific evidence guiding our practice. So hopefully in the next few years or so, some more research relating to mobilization on ECMO will be available. And that's all I have today. Thank you.
All righty. We're going to go ahead and take a short break here. If everyone wants to go ahead and get some food, come back, sit down like in 5 minutes. We're going to go ahead. I'm going to introduce our keynote speaker, and then we're going to go ahead and get going with that. But so please feel free to get up, stretch your legs, use the restroom, and grab something to eat. Then we'll introduce our keynote speaker. Hello, welcome back. We're going to go ahead and get started. Hopefully everyone's got something to eat. I'm going to go ahead and start. Again, thanks for everyone for coming. Again, we're over 600 people in attendance, plus all you people here today. Again, today is our last day of the virtual, and then tomorrow we start a little bit more fun, a little bit more hands-on. So one thing is, I joked around with Merritt earlier about the course. Meanwhile, she's doing all the emailing, the vendors, like pretty much 99% of work. My job was, Mike, you have to introduce anyone. So she goes, make sure you introduce Harvey Borowitz, our keynote speaker. Well, I've met Harvey Borowitz. I don't know if he remembers it. It was early in my career back in like 2000. I was a young perfusionist over at a Presby, but I have met him in the past. I've heard him speak multiple times. So my job was to give an introduction to for him today. So I kind of Googled a few things and I kept coming up like, how in the hell am I going to come up with a short introduction for all this guy's done and his commitment and what he's done in this field? But I'm going to give it my best, but here we go. It's my honor to introduce our keynote speaker today, Dr. Harvey Borowitz. Dr. Harvey Borowitz is a distinguished professor of bioengineering at the University of Pittsburgh and a senior leader at the McGowan Institute of Regenerative Medicine. For more than 4 decades, his work has advanced mechanical circulatory support for both pediatric and adults, including pioneering contributions to pediatric ventricular assist devices. In 2024, he received SIA's inaugural Vishnu Ingal Lifetime Achievement Award in recognition of his extraordinary impact in the field. We are honored to have him with us today. Please join me in welcoming Dr. Harvey Borowitz with his talk, Pediatric Ventricular Assist Devices, Old and New. All you do is you advance your slide right here. Just click it right there.
Well, thank you for the very kind introduction. Are you sure it's about me? Never quite know, but then thanks the organizers. It's a treat for me truly to be here today to speak to so many wonderful people. So the organizers may not have been aware that when they established these dates for this conference, in 2 weeks hence, we'll be recognizing the 40th anniversary of the first use of the total artificial heart as a bridge to cardiac transplantation at Presby. And as you can see here, on that last weekend in October 1985, this was headline news. It was absolutely headline news from the Pittsburgh Press, which has been a defunct newspaper in Pittsburgh for a very long time. But what you see in the picture below, of course, you know the patient is the person, Mr. Tom Gadish, wearing the Presby shirt. He was a 47-year-old retired steelworker, and he received a heart, total artificial heart for several days, was transplanted, lived an additional 8 years as one of the really strongest supporters of our fledgling program in mechanical circulatory support. See. So this is a picture of the folks who were responsible for this first wonderful achievement. And the person on the far left, as you look at the screen, is actually Dr. Robert Hardesty. And it was Dr. Hardesty who performed the first pediatric ECMOs at our Children's Hospital of Pittsburgh in the mid-1970s. Standing next to Dr. Hardesty is Dr. Bartley Griffith, who is world-renowned and famous. Many of you may know of Dr. Griffith most recently for his performing the organ transplants from porcine to 2 human patients at the University of Maryland. Next to Dr. Griffith is the patient looking wonderfully healthy and happy post-transplant, Mr. Gadish. And finally, the person shown there was a CT fellow back in 1985, Dr. Alfredo Trento, who's now for many years been head of cardiac transplant at Cedars-Sinai in Los Angeles. So the device we used 40 years ago is shown here, the total artificial heart. Actually, it's the version in the middle, the J7-100, which meant it had a 100 cc priming volume. And you could literally see how it was planted by Dr. Griffith in the procedure. And what I always have a joke with my students in the class when I show this image is that the two ventricles are connected together by Velcro. And it's not something, the biomaterial you might have thought of choice for this, but it certainly worked very well. So fast forward from 1985 to today, and you'll see that we have implanted more than 2,000 mechanical blood pumps in patients over the decades. More than 117 of them have been children. And if you actually go take a look at some of the basic data, this is a slide, one slide that shows the numbers. So the x-axis is the calendar year, starting with calendar year 1985 on the far left, all the way through the present calendar year 2025. The y-axis is the total number of pumps implanted, and you can see pretty much a monotonic increase in pump implantation over the years that pretty much is continuing today. If you refine your search a little bit more, you can actually look at the types of pumps that have been implanted over the years. This graph starts on the far right with calendar year 1985. To the far left is calendar year 2025 as you look at the image. And you'll see the frequency of use of some of these pumps. Early on, we were doing the first generation pumps, the Thortex and the Novacores and whatnot. But by the year 2000, you'll see increase in HeartMate 2s and HeartMate 3, the HVAD, and most recently, the primary focus on the Impella family of blood pumps. As far as relevance to this audience, if we look at the Berlin Heart numbers over the years, what you can see is that primarily Children's has been utilizing the left ventricular assist pump solely, several RVADs and a few BiVADs. And if you actually follow the orange line, you'll see that over the last several years, pretty much a half a dozen Berlin Hearts have been implanted in patients with some regularity over the last half dozen years. So to my actual talk, and I have nothing to disclose. So let's look at some of the old devices. And some of these were actually, this first device and the second device are actually 1980 devices. They actually look like the Thortec PVAD, only much, much smaller. And these were really ingenious devices. Very, very small priming volumes you would see with their own cannula set. So the two organizations that were most responsible for these back in the day were Penn State and University of Utah. And this was one version of it. And here's another version of it. Again, very, very small priming volume cannula set. These pumps worked quite well. The problem was that the flow is disturbed around the very small inflow and outflow valves. And so you would generate thrombus at those locations. And work on these types of pumps is still ongoing, actually, trying to continue to address the thrombosis problem. An early pump that I really like came from a company called Abiomed, actually. It was done by Dr. Robert Kung. And this development was actually the first pediatric ventricular assist device to be supported by the NIH SBIR program, Small Business Innovative Research Program. What's so interesting about this technology is it really is nothing more than a tube that is heat formed to produce a ventricular assist device. It's really, compared to the devices we use today, it really is quite simple in design. And remember, we're talking here in the 1980s, 1990. And if you look at the way Dr. Kung and Abiomed designed this, you basically had two sizes, right? One that would allow flows up to, the larger one at the top would be up to 3.5 liters per minute. And the other one, the smaller one, would allow flows up to 0.5 liter per minute. If you actually look at the operation of how this actually worked, and again, all these are pictures from Dr. Kang's work. What you see is you really have simply a chamber that's filling and emptying, right? And so I think this particular version is filling when you're actually filling the pump. The outflow valve is closed, and you're actually filling it up with blood. And then at some synchronous signal, the outflow valve would open, and you would expel the volume. Pretty much how all the first generation pumps worked, but for whatever reason, Biomed never followed up with this, and I always thought it was a pretty interesting concept. Our own consortium has been involved in this for a very long time, and we formed in the early 1990s a joint venture effort, development effort with a company called Nimbus, which is located in Rancho Cordova, California. You may know Nimbus better as the company that developed the HeartMate 2. And so we were working with Nimbus on a pediatric pump, and our design was a centrifugal pump that kind of looks like this. You actually see the pump itself and the impeller. It looks strikingly similar perhaps to the PDMag or CentraMag in terms of general flow characteristics. And the way this was developed, you can see there's the controller, the motor, and the pump all in a very compact package, which was certainly ahead of its time way back when. And this was done in the 1990s. We were always very excited about this product. We actually did some in vivo work done at the McGowan Institute. And this were some 6-day in vivo experiments showing the functionality of the pump, and everything would maintain quite normal. We thought we had an industrial sponsor in Boston Scientific, but unfortunately that did not work out. So in 1995, I was pretty sad that this pump never quite made it to prime time. 30 years later, I'm still kind of sad because I really think it was a terrific pump, and it never just quite made it across the finish line. Fortunately for the field, Dr. Kurt Dassey and his company Levitronics brought forth the CentraMag and PDMag to the clinics, and all of you are familiar with those pumps, I'm sure. What you may not know is that the PDMag was co-developed by our consortium here at the University of Pittsburgh, and that work was done under the direction of Dr. Peter Weirden. You might remember Dr. Weirden was a heart surgeon here, a wonderful collaborator. In fact, under Dr. Weirden's direction, we had received what's known as an SBIR Phase 3 award, which meant that the final year of our funding would be dedicated to the early feasibility studies of the PDMag pump. And those early feasibility studies were to be conducted at Children's Hospital. Unfortunately, Levitronics was acquired by Thoratec, another company, and they didn't follow through with that effort from Dr. Weirden. So if you look at a timeline for pediatric VADs, and I've highlighted the ones in blue that we've talked about a little bit, the first use of the Berlin pediatric heart 35 years ago, its first use in the United States in the year 2000, the Berlin pediatric trial, which began in 2007, the PDMag getting its first implant in the UK and achieving the CE mark, and the Berlin heart being approved for pediatric application by the FDA in the year 2011. So what have we learned, at least somewhat, from many of the uses of these pumps over the years? And this is one, it's a paper that's been accepted for publication. And so I have a draft of it, which I could download from PubMed. But basically, I think the key point of this particular paper is shown in the next slide in the population, in the summary, text summary, which basically said that patients who are less than 18 years old with congenital heart disease bridged to transplant with VAD achieved the same post-transplant outcomes as those who were not bridged with VAD, which basically said you can use a VAD to support these kids, and when they're transplanted, they'll do just as well as the patients who were not supported by VAD, and that's obviously an extremely important finding. So another part from the old section of the talk is the NHLBI Pumpkin Contract Program. Pumpkin stood for Pumps for Kids, Infants, and Neonates. And this was an NHLBI funded project. The program director is Dr. Tim Baldwin. And the most recent publication on the pumpkin trowel is 1 year old from Dr. Chris Ullman at Stanford and a whole team of colleagues who've been working on this pumpkin project for many, many years. And the data that was presented in this paper I'm showing in this particular slide, and without going into all the details, there's been about a half a dozen patients over the years who have been implanted with the Jarvik 2015 for part of the pumpkin trowel. Some of the results have been very good, some not so good. The trial has kind of been in suspended animation for quite some time. Some of it involves the passing of Dr. Jarvik, financial considerations and manufacturing considerations. I know that Dr. Kirk Dassey is still interested in moving this trial forward, and perhaps we'll be able to see further updates on the pumpkin trial moving forward. I just wanted to highlight two of our patients from years gone by, children, adolescents, both of them. And the first one is Brian Williams. You see him at the top. He was a NovaCore patient, one of our first generation pumps from years gone by. I think he's sitting either at one of the outside benches at Children's, the old Children's in Oakland, or at Montefiore, I can't remember which. But Brian Williams was the first patient to be discharged out of the hospital with an implanted ventricular assist device. This was done by Dr. Griffith in 1992. And the bottom picture shows Brian Williams with his family. He lived for another 35 years. He just very recently passed away. He was like the underpinnings for all of us. He was such an amazing person, such a wonderful individual in so many ways, a dear friend to many of us. And so he was one example. And another wonderful patient we had is Ms. Andrea Spinola, showed here. And you can see that she's a VAD patient. You would never know it unless you look at the yellow circle. And there she's wearing a Thortec PVAD. Now this picture is an interesting one because it's taken at the old Civic Arena at a Pittsburgh Penguin playoff game. So if I'm mentioning Pittsburgh Penguin playoff, you know that was a while ago because they haven't been a very good hockey team for the last several years. But what's really interesting is how our engineers and the console associated with the Thortec PVAD was also very, very large. And so our bioengineers designed scaffolding to be erected at the Civic Arena so that Andrea Spinola and her parents could actually attend the Penguins hockey game. And for her 20th year post-heart transplant, Andrea put together a kind of like a history of her own experiences. And basically you can see it, I think it's readable that she was diagnosed with cardiomyopathy at age 14. She spent 156 days at UPMC on a Thortec. She left the hospital, obviously, to attend the hockey game. She married and was one of the few transplant recipients back in the day to actually have children. She celebrated her 20th anniversary post-heart transplant. I think we're up now to 25, something like that. Recently saw Andrea, and I hope she'll have a 30th celebration that we can all attend and just be thrilled about this wonderful, wonderful person. So these are just a few examples of the old. What about the new? Well, there's several to mention. One is the Fontan pump. There's been many, many research efforts over the time in developing blood pumps for Fontan patients. And I think the person who's had the most success doing this is Mark Rodefeld at Indiana. And he presents various updates at the SIO annual meetings. And he's determined to keep going, even though it's a very small market. But Dr. Rodefeld's been very involved in this for many years. Another new concept is what's shown here. This is from Dr. Amy Throckmorton and colleagues at Drexel University. And basically what's interesting about this particular pump is it has both a centrifugal and an axial component to it. And you can see the anatomic connections. The team at Drexel claims there's a significant advantage of approaching it this way. And every year we'll get an update at the ASAIO meetings and see what progress has been made. Our own team has been working on a pump called the PediaFlow for many, many years. We have lots of wonderful things to say about this project, and the technology really is as small as it is. It's an implantable blood pump the size of a AA cell battery that can be actually used to support infants as small as 5 kilograms, maybe even smaller. And what is the PediaFlow exactly? Oops. The PediaFlow is what it says, a biocompatible miniature implantable heart assist device to treat these most precious patients. And we've actually taken this pump as long as, with Dr. Weirden, again, leading the way in the in vivo preclinicals, we've actually implanted this pump in animals for 60 days and 72 days, and it's worked flawlessly, and there's been absolutely no bioincompatibility, zero hemolysis, actually. And over the decades, we've actually, you can see how we've shrunk the size. You know, the first generation PF1 was basically about the size of a D cell battery, now down to the current one, which is the size of a AA cell battery. And we actually think, and this work is now centered at Cornell under the direction of Dr. James Antaki, and we actually think that that same concept can not only be used to support the smallest children by operating the motor at 10,000 RPM, we could actually take to even higher, to up to 3.5 liters per minute to support a much wider range of pediatric patients who need mechanical circulatory support. So what does the future hold in this field? So I apologize that this is not very readable, but there's a reason, and I'll read what I think is important. At the recent ISHLT meeting, so that's International Society for Heart-Lung Transplantation meeting that was held in Boston this past spring, Dr. Angela Lortz, who's in charge, one of the leaders of an organization called ACTION, ACTION, which is a group of committed people to seeing pediatric ventricular assist devices move forward, submitted this press release at the meeting. And the second paragraph is what I'll read. It says, advances in pediatric cardiac disease are underfunded and understudied. Therapies are rarely developed for children. We modify adult therapies to use in pediatrics. And then also, halfway down, kids really don't get the therapies they need because mechanical circulatory support devices are designed by adults. The patient population is relatively small, and there is often concern about return on investment for small devices. So companies struggle to invest in them in many cases, and adult devices are used off-label in pediatric patients. And finally, the bottom paragraph, we need to get these kids home to their houses with their devices. That's what adults get to do, and children should be in the same position. These are all quotes from Dr. Lortz in her press release. And finally, several more paragraphs. The device manufacturers are aware of the problem, but we still need alternative ways to allocate funds to support a pediatric device initiative so we can save these kids' lives and help get them home with their devices. And finally, she said, we always use adult therapies and try to jury rig them. there are kids who die now because we don't have the right device. We can do better. And to follow up with what Dr. Lort said, recent study from Stanford Biolab actually shows the significance of the challenge. So the two bars here, the bar on the left says number of U.S. seed investments, and there are three color codes on these bars, black, blue, and red. The red represents the number of investments, U.S. seed investments in pediatric applications. And what you see for pediatric applications, only 1.5% of U.S. seed investments has been in pediatric applications only. If you look at how much money has been invested, and again, same color scheme, less than 1% of all the money that's been invested in these seed investments for state-of-the-art technologies like pediatric VADs, less than 1% has been invested in pediatric applications only. And you can even take it one step further because very recently, on July 16, the FDA formally added pediatric ventricular assist devices to its medical device shortages list. So if you go to the FDA website and look, you'll see pediatric ventricular assist devices is on that list. And of course, all of you know or are aware of the challenges of the Berlin Heart, even the difficulty in securing Berlin Heart technology these days. And it's unavailable and it's really needed. We need these types of technologies. So where are the next technologies going to come from? What are we going to offer to all you wonderful experts at Children's Hospital who care for these critically ill patients? What are the next technologies we're going to offer? Well, I think the fair answer is we're going to offer you technologies that come from China. And I just pulled out two press releases. This is not scientific literature, just two recent press releases. One talked about a Wuhan boy implanted with the world's smallest magnetically levitated artificial heart. Now, I will say that this particular press release mentioned that from concept to clinical took 3 years. And of course, nothing like this occurs in the United States within 3 years. And if you look at the device that they're talking about, I'm sure it looks familiar to some of the technology you've seen over the years. And they try to link it to a bottle cap. You know, it's kind of the size of a bottle cap. And another one, again, from the lay press, you show a whole nother different type of heart. It looks a little bit like the Carmat heart, if you will, again from China. And I think it's fair to say that these companies are coming to the United States. In fact, our artificial heart program has been contacted, our clinical artificial heart program has been contacted by several of these companies from China. They want to come to the United States. They want to do their final preclinical tests in our laboratories. They want to submit their IDEs and they want to conduct their first clinical trials with us and, of course, get FDA approval in the United States. So I'm not sure whether that's good or bad, but I think it's fair to say that at least right now, the next generation of pumps that you folks will be seeing will likely somehow come from China. And finally, for those of us who are still doing this, who are still trying to design pediatric ventricular assist devices, I think it's fair to say that all of us are thinking about access, guiding our design decisions. As we move forward, we'll focus on affordability, usability, and ultimately scalability. So I thank everyone for your attention. I thank the organizers for kindly inviting me and giving me the opportunity to speak with you today. Thank you very much.
Appreciate it. My pleasure. Thank you, Dr. Borowitz. Great pleasure having you here. Always interesting to see what's in the past and what we got to look forward to in the future. Thanks again for coming. Okay, we're going to move right on to the fireside chats. First fireside chat is going to be virtual. And we're going to have Rod Gazmezada and Juan Sanchez de Toledo will be coming in virtually too.
Hi, everybody. Can you guys hear us okay?
Hi, Rod. Hi, everybody.
Can you guys hear us in the conference room okay?
We can hear you.
Wonderful. It's a great pleasure to be here. Thank you to the organizers of the conference for inviting us. Sorry we can't be there in person, but we're there in spirit, and I have loved the conference so far. So thank you so much to the organizers, and thank you for the opportunity to have a fireside chat with Dr. Sanchez de Toledo. I'm Dr. Gassimzadeh. We're both cardiac intensivists at Children's. Okay, we're gonna go through kind of a question and answer sort of fireside chat about a patient who requires mechanical support in the CICU. I can't see. You guys can see my screen.
We
The
do
presentation.
not see your slides.
All
Do you know
right,
how to share them?
Second. Let me try. There's one extra button in Zoom. How about now?
We see them. Just go into presentation mode.
Perfect. All right, everything good?
Everything's good.
All right. So, Dr. Sanchez, we have a 2-month-old infant male who was previously a 32-weeker who presents from an outside hospital with URI symptoms and cardiomegaly on chest X-ray. His testing for respiratory viral illnesses, the panel was positive for rhinoenterovirus. And you get a call from the CICU fellow overnight who says the ED has called them because they have this kiddo and they're very tachypnic downstairs. They've already put the kid on high-flow cannula. Here's the X-ray of that kiddo, and then the cardiology fellow is also down there doing this echo, and this is the echo that's playing out. So I just wondering what your general approach. You hear about this kid from the fellow, and you have to guide him or her through the night. And what's your general approach?
Yeah, thank you. And first of all, I want to just thank Rod just for not letting me see the images before. So I would like him to go back 2 slides and go back to the X-ray, because here we just sell the cake, and I saw a very dysfunctional ventricle, but this is a very good example of what we can see in the ED with a kid that has a suspected bronchiolitis. That the first thing that probably that will have nowadays, before the exam, is an X-ray. So in the X-ray, at least we have to see something that it's atypical, and of course here there's a small cardiomegaly. So you can doubt, you can question yourself whether there is a massive cardiomegaly that will trigger you to do an echo sooner rather than late. But in this case, we had a fast and bright fellow that showed us the echo before putting the stethoscope. Probably the stethoscope on this patient gave us some signs of tachycardia, a gallop, and also on the exam, this patient would be on impending a low cardiac output, cold, poor perfusion. So next one, you showed me an echo that obviously we all know that has a severe left ventricular dysfunction with some spontaneous contrast on the LV. And I would like to ask the fellow how the patient is doing. Is the patient eating something, or is he almost going to arrest?
Yeah, he's not eating. He hasn't been taking it for a little bit. He's very tachypnic on high flow, and it appears his eyes are sort of sunken, very pale appearing, so not looking great.
Yeah, obviously that changes the situation, because we'll if we have time, we'll bring this patient to the ICU, right? And we'll try to start working with him, trying to support his lack of cardiac output. So we just need to give some strategies to provide an organ perfusion. We'll start to give a little bit of supplemental oxygen, supplemental flow. We'll try to get a peripheral IV as quick as we can to get some labs to secure an access and to start some treatments. I guess that we can probably see after if the patient is not in impending respiratory failure that needs intubation, we might have some labs back. I don't know if I can ask for some labs or.
Yeah, so you get a bedside lactate, and it's 8, and you get some electrolyte that looks like there's a metabolic acidosis and signs of dehydration, some mildly elevated labs, hemoglobin that's like 8, and white count that's, 6 or 7, something in the normal range.
So it doesn't look good, right? So
Yeah.
someone might argue that if you look for a lactate of 8 on a kid that has a peripheral sample obtained with a tourniquet, that you can blame the tourniquet for a lactate of 8. But in a kid that looks bad, really bad, so I would probably trust this lactate.
At what point do you start? Because I've worked in a few different institutions with different availability of surgeons and different call setup for consideration of mechanical support. When do you start? Would you be calling the surgeon right away to talk about ECMO, or is this something that you wait and get the kid to the unit and see if you can work through it? Because everyone in the ICU is always thinking, what's the next step? What if this doesn't work? What if this doesn't work?
Yeah, this is a great question, right? I think that all depends on how the clinical status of the patient is. If this is an impending respiratory failure and cardiogenic shock, and you think that you have to intubate this patient, the minute you think that this patient will require mechanical ventilation and you have to decide to intubate, you have to activate the ECMO team and surgeon at the bedside. As we're going to see, and we've seen in previous lectures, the minute you intubate an impending left ventricular dysfunction, the patient can get in immediate arrest, and then you go from a situation that's critical to a disaster. So you have to be prepared, you have to anticipate, you have to have the team ready. Once the team is ready and the surgeon is available, then you can try to manage this patient, intubate, make positive pressure, and then if you're lucky enough, central access, and try some enodilators to support cardiac output.
Yeah, I know at Pittsburgh, we're very focused on avoiding a cardiac arrest, because we think that if we're able to avoid that, it will limit the morbidities that are associated with what likely in this case might be a myocarditis that's short term and self-limiting, although could also be a cardiomyopathy. So on presentation, as we discussed, worsening tachypnea, pale, poor perfusion, intubated successfully, and a right IJ CVL was placed. The SVO2 that we got was 40%. The lactate is now 9. Worsening blood pressures despite fluid resuscitation and vasoactive inotropes. And due to clinical decompensation, despite medical therapy, you and the team decide to proceed with cannulating onto ECMO. So I was just wondering if you can comment on your expert opinion related to, cannulation strategy in this patient, or, a patient that might be older, a child or teenager that comes to our CICU. Kind of what's a conversation that you have with the CT surgeon about when do you pull the trigger, and how you prepare for a cannulation, and sort of your considerations once you're coming on, and once the pump is moving and getting started, what are your immediate management that you to ensure that things get kicked off in the right way?
Yeah, I think that you just solved the case, right? And you gave me all the information to trigger rapid ECMO cannulation. I think that here the discussion would have been where to place the CVL on this patient, knowing that the chances for him to sustain his cardiac output without mechanical circulatory support are relatively low. And I would argue that probably if I wanna support this patient and try to avoid ECMO, I might go to a femoral access before, just to in case that we need to support him further, do a peripheral cannulation. So I think that this is an important question: is how we're going to cannulate a specific patient. And in this case, we're talking about a neonate with impending with cardiogenic shock. And I think that we will all agree that this is a peripheral neck cannulation. One of the questions that I will have for a surgeon that it's, if it's in the audience, is what do we do with the neck CVL that we have? Do you ask the intensivist to put another line? You don't care, or you just go ahead and cannulate?
Yeah. I know there's a little bit of experience in the literature about peripheral cannulation, even for these smaller kids. That's not something that we typically do at Pittsburgh, but I just wondered if you had any experience in that regard.
Yeah, obviously it depends on the setting and the experience of the team, right? If you have an experienced team, an experienced ECMO team with an expert surgeon, you have to call the surgeon at the bedside, and you want this critical patient to be cannulated by an expert surgeon. The other question would be, you are in a different setting where a surgeon with experience is not present, and you have a CVL in place. So of course you can cannulate this patient peripherally. So the short answer is yes, it could be done, but ideally a surgeon should cannulate always these patients.
Yes. One thing I might add in addition to is the importance of having a sense of a vascular map of a patient if there's time. We've had many patients, you know, in pediatrics, we get presentation of genetic and metabolic disorders presenting with cardiomyopathy, and oftentimes their vessels are very abnormal and a difficult cannulation. Knowing that as much as you can ahead of time helps with developing that strategy, especially with potential audible from peripheral to central cannulation. All that stuff is good to know if possible ahead of time. Okay, so you're cannulated and you get the post-cannulation X-ray, and things are running really well. What's your focus in the immediate post-cannulation period?
Well, I think that the basics of ECMO support have been discussed previously. I think that we have a later talk that will go into the specifics of a cardiac ECMO within the CICU. But we have to always focus on just making sure that we're going to perfuse the organs, that we will just allow for the myocardium to recovery while we make sure that the brain is intact, right? The thing is how we're going to support this myocardium. Remember that we're talking about cardiac ECMO, and probably at the time that we just put the patient on full flows, we might lose pulsatility. So we just need to make sure that we understand the principles of cardiac output, cardiac index, and we have a machine that will provide our artificial cardiac output. And if the patient doesn't support anything above this cardiac output, this is what we have to support the end organ perfusion. So we just need to play with our end organ surrogates, whether this is lab or exam, and combine those with the settings of the ECMO to support our patients. So you have, of course, a number, what will be your cardiac output. You will have a CVP, and you will have a mean arterial pressure. And with these three numbers, you just need to make sure that you puzzle the end organ perfusion of your patient.
Yeah, and I know that you're going to go into in another lecture potentially ensuring that we've maximized myocardial recovery. And I would add to some of the monitoring that we utilize very heavily especially now more recently, NIRS monitoring for continuous secondary signs of mixed venous saturation or cardiac output, and monitoring as a trend, and also EEG looking at neurologic function, as a lot of these patients can have seizures in the post-cannulation period. Okay, so if only everything ran exactly like you wanted it to. Unfortunately, this patient is now becoming hypotensive on ECMO, which not much more you can go from mechanical support of cardiac output. So how do we deal with troubleshooting hypotension for a patient on ECMO?
Yeah, that's what we don't want, right? We had a problem. We thought that the problem was solved, and now we have a patient that's intubated, sedated on ECMO, and he's severely hypotensive. So you have to go through your exam, and now you have another piece on your exam, which is your equipment. You have the device and all the equipment that it's associated to the device. So your exam it needs to be brought into all these specific things. Obviously, after just making sure that you go through the main reasons of hypotension and you address the volume, the tone, etc., you have to focus on what's going on in the circuit. Is the circuit running okay? Is the circuit full enough? Are the cannulas in a good position? So let's see. Let's see if you can give me some information about this patient.
Sure. So some of the things you mentioned, and we'll go through some pictures.
So I think that you're telling me that the patient is okay. That circuit might be giving us some problems.
Yes.
Okay. Okay. So in a hypotensive patient with this X-ray, so if you go back, you don't need to go back, but yes. Okay. So if we assume that this is an relatively not perfect, but this patient, you told me that he was not hypotensive, and we have the venous cannula and the arterial cannula relatively well positioned. In this one, what I see is that if you want to point it out, because I think that you have the pointer. Yeah, exactly. So perfect. Arterial tip to distal. So this is not an arterial cannula that it's well positioned. It's probably just touching the posterior wall of the aorta, and it's increasing the resistance. And even though we are increasing the RPMs on the circuit, the patient is not flowing well. We should know that the pressures on the systems are increasing, and then we need to address this situation. Whether changing the position of the neck might help, or either a surgeon needs to readdress this issue. It's something to be seen.
Yeah, and I can't overemphasize the importance of an X-ray. Oftentimes it's very difficult because one X-ray may have a slightly different projection than the other in a portable X-ray, but it's sometimes the last thing you think about when there is a problem. You want to optimize other things first, but getting an X-ray soon before you call the surgeon, it'll save you a second call to a surgeon if you have the X-ray in hand already. All right, this is a potential another version of the X-ray.
Well, I think that could be the same patient. I think obviously somebody has moved the cannula back, but if you look close to the neck, there is some kinking there that might contribute to some, not just increasing pressures and lowering the flows, despite increasing the RPMs, but also creating some thrombus in an arterial side. So this is a serious problem that, with increasing the resistance and changing to a non-laminar flow, this could be a potential source of problems for this patient.
So you get this X-ray, and the radiologist, points out that the ET tube is high, and this is something you might get on a casual morning X-ray, but the patient is hypotensive, so the team's working on replacing the AT tube. But what else might you notice about this X-ray in particular?
Yeah, again, right? You have to be very systematic and important enough. Even though you have to be systematic, the ET tube is not the first thing that you have to look when you have problems in an ECMO patient, right? Exactly. This patient had a significant issue with the venous cannula being really high. So you can see the dot of this cannula probably being in the superior vena cava, and just probably contributing to cutting off or just having issues with the system.
Now you can see with the neck turned and everything, when we wake these patients awake, get them up and moving around, you can get some very serious cannula reposition issues. Okay, how about this one?
Well, same thing that you showed me before, right? But here in the venous side, which is probably a little bit more problematic. We have an area of kinking, probably due to the suture lines around the venous cannula that can create a thrombosis in this area.
It's a very unfortunate child who's gone through.
Yeah.
All right. So they readjust back and forth, and they're like, the surgeon goes, you know what? This one's not going to come out.
No, definitely. I mean, this is a ECMO gastric tube that actually is. You might argue that you don't want to touch this patient if everybody's telling you that the flows are okay. So are the flows okay?
They're not.
Oh, thank you. Okay, and you're giving me information, which is a cannula, something that looks like a cannula that goes back and it doesn't go up.
Yeah, and they're also telling you that the mixed venous previously was in the 60 to 70 range, now is in the 30 range.
And we're not flowing, or we are flowing.
We're not flowing very well.
Yeah. So this is a very unique situation, and I think that this is probably not the best X-ray that we can show, but I think that here is a very unique case of a posterior track of the venous cannula that goes not to the vena cava, but to a vessel behind. So unfortunately, this, as the cannula was being almost out, when they push it back in, instead of going to the vena cava, unfortunately, he went through the azygos. And this is something that you can eventually see. It's been reported, and we've seen it. And when a venous cannula is not flowing well, despite volume, and you do an X-ray study, you can check on maybe do an ultrasound or a lateral X-ray to see if the cannula goes posterior, and then think about this very unusual case of retrograde venous cannulation through this structure, the azygos.
So some things that you mentioned throughout about troubleshooting a circuit not flowing well. Obviously, you had mentioned giving volume multiple times. You mentioned checking cannula and head and neck positions. And usually that's head and neck positions tend to be more of an issue in the beginning of ECMO cannulation. But making sure that you have that in mind, obviously from the standpoint of complications, clotting is a major potential complication, and ensuring that your cannulas are free of clot. And as the patient is awakened and you have issues with sedation, patient activity might become more of an issue. And not to like prematurely close on the body itself, some other things to consider in regards to volume of the patient. The patient showed up with cardiomyopathy and needed ECMO support, but never forgetting that with the inflammation that occurs with severe critical illness and exposure to artificial material of the cannulas, capillary leak and third spacing that may require multiple boluses of volume, evaluating for bleeding. We do frequent, monitoring with head ultrasounds to look for bleeding either in the brain or the abdomen. Potentially for cardiac and we want to restrict fluid, sometimes we can be too aggressive, either with restriction or diuresis. So ensuring that we find the right space for a kid. So let's rewind a little bit and go back to this patient originally being cannulated. And you get a good x-ray initially, and then the repeat x-ray the next morning looks like this. What might be your considerations here?
Yeah, this is interesting poor course for this patient. So this is not an atypical course after a cannulating a severe cardiogenic shock with severe ventricular dysfunction, right? I think that here what we are seeing is a severe pulmonary edema from severe LA hypertension caused by the increased afterload of the ECMO cannulation. I think that shows us how vulnerable are those patients, especially when the ventricular function is extremely poor and you are supporting them from an ECMO strategy, just decompressing the right side and putting the blood back to the aorta, increasing the afterload. So that takes you to the next step, and I think that is something that we'll treat in the next set of lectures. Let's decompress this patient, right? How are we going to decompress this left side that it's tremendously dilated with severely increased LVDP and a severe pulmonary edema. So obviously this patient got a balloon atrial septectomy or septostomy or perforation, but there is other strategies that can be done in this setting if needed. But yeah, I think that this patient showed the importance of decompressing the left side in peripheral ECMO.
Which is obviously a very controversial question, and how to do it, when to do it, and what strategies to use, and what's the best one, I know is still a topic of frequent conversation and research. So I very much look forward to your thoughts on that. I think some other patient activity, kind of sedation, ensuring the patient is very comfortable, and keeping an eye out for complications on ECMO, which I know that you'll discuss in a later time. I think that brings us to the end. Any questions or any thoughts we can help address?
Thank you, Rod.
You have one question in the chat. What
let
is
me
your
see.
philosophy about maintaining adequate organ perfusion pressure without providing too much pressure to cause intracranial bleeding, especially in infants? How high is too high?
Yeah, that's a great question. Dr. Sanchez?
Well, I think that this is always what we fear, right? And we change the way we're going to provide the cardiac output, but we have to still think about the same parameters that keep the end organ perfusion in that given patient. So if you go above his percentile mean arterial blood pressure, then you will have problems. So then you have to always work with your afterload, your preload, and then play with your native cardiac output if you have, right? The lack of cardiac output is the worst thing that you can have sometimes, because then it's very difficult to titrate. When you have some native cardiac output, you can titrate in the case of hypotension. If you have hypertension, the only thing that you have to do is just decrease the afterload. Decrease the afterload and ensure end organ perfusion. normal CVP, normal mean arterial blood pressure to secure the end organ perfusion pressure.
I would say for our infants, they're pretty resilient in terms of lack of or allowing us a little room to figure that stuff out. I think our team is really good about deciding what an adequate cardiac output should be based on best case scenario, what's the perfusion necessary for the end organs, and as Dr. Sanchez had mentioned, very aggressively reducing the afterload with inodilators like nicardipine and milrinone to help optimize the flow for the ECMO circuit, get the best flow with the less RPMs. That way, we have less hemolysis and less complications from the circuit, as well as optimizing the flow to the body and the end organs. So we think about if we can achieve this cardiac output, we're winning. And how do we support the patient? Only decrease that level when it's clear that we're having ECMO complications, or despite our best efforts and all the medication in the world, we can't get that pressure down. But I'd be curious to hear about how the NICU colleagues feel about that, because their patient population is obviously more at risk for interventricular hemorrhage.
Thank you. Thank you both for joining in and your insight. We appreciate your
Thank
help.
you. Thanks, everybody.
Thank you.
Okay, now we're going to switch gears to the back of the room. This is one of the more popular things with our courses. It's called our fireside chat. Our first fireside chat is going to be with the NICU department, and I will hand it off to Burhan Mahmood, the director of the ECMO program in NICU, and he'll introduce his team at the fireside chat. Sir.
Hello, good afternoon. Hope the conference is going well. Believe it or not, finally, cold has descended in Pittsburgh. Cold advisory, winter advisory is in place now. So perfect time for a fireside chat with the NICU team. I have a wonderful panel. We have Amanda over here, Amanda Monteverde. We have Tara Beck and John Ibrahim, who are part of our NICU team. And the way it's going to go is we have a couple of case scenarios. We will ask your opinion of what's going on, troubleshoot these bedside problems. That's what we worry about. As you heard in the last talk, in the NICU, babies are fragile, and on ECMO, bad things can happen. So when alarms go off at the bedside, we have to try to figure things out. And that's the whole idea of this session. So we're going to start off. I'm going to start off with the first case. Can put it up on the... Oh, I have to click it, sorry. There we go. Well, that's our team. All right, scenario number one. So we have a baby Smith, who is 2.5 kilogram late preterm infant, admitted to the NICU with respiratory distress and persistent pulmonary hypertension. The infant is cannulated onto veno-arterial ECMO by our CT surgery colleagues on day of life 1 for hypoxemic respiratory failure. Infant has a 10 French venous cannula in the right IJ and an 8 French arterial cannula in the right common carotid artery. Before going on ECMO, the infant required vasopressors, dopamine, and hydrocortisone for hypertension and was coagulopathic with oozing at the umbilical line sites. Once cannulated, the mean arterial blood pressures normalized, so dopamine was weaned off, and the coagulopathy was corrected after blood transfusions, packed cells, FFP, and platelets. So now it's on second day of life, ECMO day 2, and you have been called to the bedside due to an abrupt decrease in ECMO flows. It happens very quickly, we all know that, and an increase in the pre-oxygenator or P2 pressure. The mean arterial pressure is increasing, went from 50 to the 90s. Infant is awake and moving and not liking it. These are the initial ECMO pump settings. You have an RPM of 3100, acceptable for our population. ECMO flows are 120 cc's per kilogram per minute. These are our goal flows. The negative venous pressure is -15. The pre-oxygenator arterial pressure is 180. Sweep gas is 300 mLs per minute. and the ECMO pump FiO2 is 30%. So these are the settings on the pump before all these changes started happening. So upon entering the patient's room, the flows are decreasing from 300 mLs per minute to 200 mLs per minute. The pre-oxygenator pressure is increasingly positive. The ECMO pump is starting to alarm. Heart rate is 190, mean blood pressure is 90, infant's oxygen saturations are 88, and the mixed venous saturation is 60%. These are the ventilator settings. As you can see, not very high. Rest settings. Urine output is 1 per kilo. Infant is positively fluid balanced by about 700 cc's within 2 days of going on ECMO. Heparin is running at 20 units. A little bit of sedation is going on. Fentanyl, Versed. Infant is on TPN, and hydrocortisone at stress dosing 1 per kilo Q 8 hours. These are the labs. So the CBC looks okay. Patient's blood gases are there. You have the electrolytes, basic CMP. On the right side, you see some heme labs with anti-10A, 0.45, 83 of 68, PTT of 65, INR 1.4, fibrinogen 250, platelets are normal as well. And that's the infant's X-ray. You can see the arterial cannula is just below the clavicles or at the level, and the venous cannula seems to be in the right atrium. So I'm going to hand off the mic to Amanda to take over.
Hello. Yeah. So do you want to give me the clicker so I can switch there? Yeah. So I'm Amanda. I'm one of the nurse practitioners up in the NICU, and I would often be kind of one of the first calls to the bedside in a situation like this. And I would arrive at the bedside trying to figure out kind of what's going on before calling in some of the big guns over here to my left. So when we get to the bedside, we're trying to think of, okay, this alarm's going off, the pre-oxygenator pressure is increasing, and what could that mean? What are all the things that could potentially cause that scenario to be happening? And so we have our multiple choice up here. Does anyone have any kind of thoughts on to which of these things could possibly lead to that alarm?
And you will put your responses in the chat, and we will go over the responses. We have our in-person audience here. We will get their responses directly face to face. So
yes, so F is definitely one of them. It listed A, B, and E. So an increase in the ECMO pump RPMs. How do I get back to the presentation on there? Okay, there we are. Okay, there we go. I list them all there for you. So your cannula malposition, systemic hypertension, and clots in the oxygenator. So when we're thinking about this kind of pressure being high, we're thinking of what is the resistance in that area of the pump that's causing that. So those are all kind of the different things. So the next steps in management for this baby, knowing the possibilities of what might be happening, what would you do kind of right there at the bedside to initially troubleshoot this problem? I know I'm trying to, there we go.
yeah.
Yeah, repositioning, maybe we need to check, our cannula placement, things like that. So kind of going through the different situations of what could have happened to cause that. So we have low flows, we have high pre-oxygenator pressure. Do we have our arterial cannula in the right position? Is it butted up against something that's causing a resistance to flow? Is there some kind of kink, as we saw, in our prior fireside chat with the cardiac colleagues? Is there some kind of kink that's causing an obstruction? Maybe there's thrombus formation beginning in that area of the cannula, or could there be thrombus formation in the oxygenator? These are all things that we would talk with our bedside perfusionist or ECMO specialist about right there. Have you seen anything new? Have you seen any increase in clots? Are you worried about anything from that standpoint? We could get our imaging of our cannula if we feel like it might be a malpositioning problem, an X-ray or perhaps an echo to make sure that those things are, in the right spot, particularly the arterial cannula when we're talking about these kind of alarms. And, do we have systemic hypertension, which in this baby, we heard Dr. Mahmood saying that our blood pressure just kind of abruptly increased. And what are all the reasons why that could happen in one of our babies on ECMO? So kind of elaborating more on that hypertension subject, we have lots of reasons why one of our babies may be hypertensive on ECMO, and it's something that we do see fairly often with these patients. So kind of one of the easier things to control and to roll out is just like, is this an agitation and sedation issue? Are we not adequately sedated? Were the drugs that we were using prior to cannulation really maybe not cutting it anymore? Is the baby, becoming tolerant? Are we needing higher doses just due to the pump, the pharmacokinetics and things like that? So we can try giving extra sedation, increase our dosing, talking to our NICU pharmacist and making sure everything is looking good from that aspect. The other thing that we consider, especially kind of when it's an abrupt onset of the hypertension, is seizure activity. This is something that's also unfortunately common that we see with our babies on ECMO. A lot of the indications for our babies going on ECMO can already make them prone to having seizures. We will have some babies, with HIE or different issues that has affected their brain function even prior to cannulation. And then afterwards, certainly they're at risk. So that's something we would evaluate for, put the baby on EEG. Fluid overload, also kind of a more obvious answer as to why the baby might be hypertensive. ECMO cannulation comes with a lot of boluses and product replacements and things like that. So that's definitely something common that we see. Do we need to maybe diurese the baby more, see if that could be helpful for our blood pressures? And then excessive ECMO flows. Do we need to be flowing as high as we're flowing right now? Can the baby still maintain adequate oxygenation and perfusion at maybe a little bit lower of a flow? Do we need to have 120 per kilo right now? Can we maybe run at 110? Will that help the blood pressure? Will the baby still be safe flowing at those types of flows? So considering all of those things. We talked a bit about this already. And so we do work really closely with our NICU PharmDs to help us kind of with making sure our dosing is good and, switching between morphine and fentanyl when we know that one binds to the circuit more often than the other, just keeping all these things in mind. And it is something we try to go over fairly quickly into our ECMO course. In terms of muscle relaxation, it's not something that we, do as a routine process when the baby's on ECMO. We do muscle relax them for the cannulation, but it's not our goal to keep them muscle relaxed the whole time, with the kind of caveat, if the movement is affecting our flows, then surely that's sometimes indicated, is one of the more common situations I would say we use the muscle relaxant for. In terms of seizures, yes, we would place the baby on an EEG. We would also kind of consider, why did this baby now start seizing? Is it a baby with history of HIE? Were we undergoing therapeutic hypothermia and now we're rewarming perhaps? What are the risk factors? Do we need to get imaging to make sure that there's no new bleeds, no new thrombus formation or ischemia, anything that could have triggered this to happen at this moment right now? And so we're likely already in conversation with our neurology fellows at this point in time, but kind of keeping them updated as well and getting their input is very helpful. And then we talk about, iatrogenic causes. So oftentimes we're on lots of different forms of inotropic support prior to cannulation. And then in this particular patient, it sounds like we came off of our dopamine rather quickly, but maybe we're still on hydrocortisone. And that's something that we will sometimes try to maintain if the baby tolerates it, just to help with the systemic inflammatory response when you're on ECMO. We'll often keep the hydrocortisone on, but in cases like this, when we're experiencing significant hypertension, especially if it's affecting ECMO flows, then we would try to probably hold off on the hydrocort for a little bit. We also routinely will start antihypertensive therapy, whether that's in PRN or continuous infusion form. In terms of fluid overload, we talked a little bit about this already, but the problem we often run into is a decreased urine output and needing to start some form of diuretic therapy. Usually our typical NICU ECMO runs are kind of like, a day or two of stabilization and then kind of really focusing on getting fluid status under control and lung recovery for the remainder of the run. And so My colleague Tara Beck over here just did a lot of work on fluid status and ECMO in the NICU with her dual neonatology and nephro fellowship that she's working on right now. So more to come on that, but we do utilize hemofiltration as necessary. It's not something that's necessarily routine, but that has been very helpful to us when needed. And then just in terms of general renal dysfunction, you know, we have our babies on VA ECMO up in the NICU here is what we use. And so that comes with, you know, a non-pulsatile blood flow, and the kidneys don't love that. Leads to a decreased urine output, I think an increased like renin secretion and some vasoconstriction. And so the blood flow isn't as great with that type of flow, so they're not very happy. Different medications that we use might require different dose adjustments when you're on ECMO, so that's something to consider as well. But it's just kind of a matter of, you know, keeping the kidneys, trying to keep them as happy as you can. And while they're in the state of being unhappy on ECMO, what can we do to support them and support the urine output and support their perfusion and all those things? The last topic was, you know, excessive ECMO flows. Our goals for our babies are 100 and 120 mLs per kilogram per minute, with the goal of avoiding high RPMs and avoiding that hemolysis. So can we wean the flows and still keep the SVO2s in an appropriate range for our baby? Our SVO2s don't need to be 89, 90. We can certainly do 70 to 80 and be just fine. So can we come down a little bit? And that's kind of an immediate, more like quicker fix for our blood pressure.
Okay, thank you, Amanda. So yeah, we like gentle ECMO support and happy babies. And as you can see, when you're troubleshooting, you got to look at everything, the patient, the circuit, and review everything that is going on medication-wise. What's the status of the baby? What could be contributing to that problem with the low flows? And that's the way to approach when suddenly alarms are going off in the room with ECMO flow issues. I'll hand over to Tara now.
All righty, thank you. Amanda, do you mind if I have the clicker? All right, guys, I'm Tara Beck. I'm one of the neonatology fellows. Like Amanda mentioned, I'm also a pediatric nephrology fellow. So I've gotten to work with a lot of you in that capacity as well, which has been a lot of fun. I do apologize. I am on service right now in case my pager goes off. But let's take it away with case number 2. So we have a 27-year-old G1P0 mom giving birth to her first baby, otherwise negative serologies, negative GBS, delivered a term infant at 39 weeks. Thick meconium was present at birth. The baby was placed on CPAP in the delivery room for some increased work of breathing and hypoxia, requiring an FiO2 of 70%. Baby Smith is admitted to the NICU for respiratory distress at a birth weight of 3 kilos. You could see, and this was a post-intubation film that we got of this baby shortly after birth, just the hallmark of meconium aspiration, right? You've just got that thick atelectatic appearing lung, or those thick opacities, I should say. So the initial ABG down in the delivery room showing a pH of 6.79 with a CO2 greater than 95. The baby was intubated, like we mentioned, with a 3.5 ET tube. FiO2 is escalating to 100% now. The baby's still hypoxemic in the 70s, placed on the oscillator with a MAP of 18 and amplitude of 40. Shortly thereafter, started on nitric and given a dose of surfactant. Repeat ABG with those interventions is 6.8, CO2 of 98, and a PaO2 of 35. Baby's blood pressures are a bit softer, so started on some hydrocortisone and some dopamine. Question for the audience and for the chat, how do you calculate an OI? And what is this baby's OI? And this would be based on our MAP of 18, our FiO2 of 100, and our PaO2 of 35.
It's not going to be good.
It's not going to be good. So doing the math there, it's about 51. So at this point, we can presume that this type of baby, right, with these first interventions is at our delivery hospital, McGee, down the road. So this is pretty critical. And I think something for us in the NICU world need to keep note of, right, is that when a baby like this has this high of an OI at the time of delivery, we have to ship this baby off to Children's or an ECMO referral center ASAP just to get this baby evaluated for potential ECMO. So of course, with that OI, the baby is referred to an ECMO center and is cannulated by CT surgery, eventually for hypoxemic respiratory failure. Cannulated with a 10 French venous cannula and an 8 French arterial cannula. Just something to know for the group is that 8 French is the smallest cannula size that we do offer. In our current protocol right now, we offer ECMO or consider it in babies greater than 34 weeks and greater than or equal to 2 kilos. But you can obviously imagine part of that consultation process is the fact that the size of the cannula may be a limiting factor in a baby that's too small. So our initial pump settings based on this 3 kilo baby, an RPM of 3,000 in order to achieve flows of 100 per kilo per minute or flows of 300 per minute. Negative venous pressure is beautiful initially, -15. We like to keep that anywhere from -15, really no more negative than -40. We have our P2 pressure then post-pump pre-oxygenator of 200, which is within our range as well. And our sweet gas started at 0.4 with a pump FiO2 at 35%. Our ventilator settings, pretty typical rest settings for us. So a rate of 20, PIP of 18, and a PEEP of 8 with a pressure support of 10. And our FiO2 on our ventilator, of course, at 21%. The urine output for the last 24 hours of this baby is 10 mLs per kilo per hour with a fluid balance of -600 for the ECMO run, which I think we can all agree is pretty unheard of, especially for the day of cannulation for a patient like this. We have our morphine drip running, heparin at 25 units per kilo. Our starting heparin is usually 24 units per kilo per hour. TPN lipids running at about 145 per kilo per day, and our Lasix infusion at 0.1 mg per kg per hour. So the initial set of labs, really focusing on our CBC initially at the time of admission with the H&H of 13 and 38 has downtrended a bit to 10 and 30. With an unremarkable differential. Both the patient and the pump ABGs look pretty standard, no concerns there. Our BMP showing actually fairly normal electrolytes with the exception of that creatinine of 1.2 that certainly as a nephrologist I don't love to see, but it's not surprising. Glucose is stable, iCal is stable. Our anti-10A is certainly on the lower side at 0.1. We like to keep our anti-10As anywhere from 0.3 to 0.5 really in these babies. Our AT3 is low as well, 35%. We like to optimize that at about 60%. PTT is fine at 55, INR of 1.3, a crit, like I mentioned, of 30, fibrinogen of 170, and a platelet count of 75. So the ECMO run has been uneventful. Today's day of life 3, but ECMO day 1. And you're called to the bedside for low ECMO flows, and the pump is alarming. The mean arterial pressure in the patient is also decreased, now with MAPS in the 30s. The infant sedated, appearing pale, edematous, and tachycardic on exam. So upon entering the patient's room, we notice our ECMO flows are decreased to less than 200 mLs per minute, which is certainly below that 100 per kilo threshold that we like. Our venous pressure is increasingly negative from that -15 at the start to -35, which is more negative than we like, and our ECMO pump continues to alarm. Patient's heart rate's elevated at 175. Our MAP, as we mentioned, is low, MAP at 30 with a blood pressure of 35/25. Our SpO2 is 80 and our SvO2 is 60%, so lower than what we'd like. Sorry, give the answer. So why could the ECMO flows be decreasing? And we'll open this up to the room and to the chat. And I think, what do we think is going on with this patient?
So some of the answers we're getting are needs product, hypotension, E. You can see them up there now, Tara.
Awesome. Exactly. So if we can go back to the slides, if we don't mind. Yeah. So exactly, right? So high urine output, especially from Lasix. In a patient like this, it's really uncommon for us to start a Lasix infusion, especially on the day of cannulation, but certainly the first day after cannulation will start. So patients getting, if you remember, that 10 mLs per kilo per hour, having that robust urine output. Certainly venous cannula malposition, like we heard about, especially in the CICU talk, right? That cannula is everything, and that's really the access point that drives our flows. But of course, not to forget that clots could be occurring in the cannula, especially if you have any sort of kinking in the cannula. So to always be thoughtful. So what do we want to do next? And I'm not to ignore, I know somebody in the chat had mentioned giving products, certainly, right? Our platelets were a little on the lower side at 75. We like to keep them above 100 on the day of our cannulation, and then typically above 80. So certainly could give some platelets.
Mostly seeing E as a response.
Right. So let's take a peek back at so E is A, B, and D. So really for this, we would want to give a bolus of 10 mLs per kilo we like to do and stop the Lasix infusion. So the difference would be choice E would include turning up the ECMO RPMs. And we're especially mindful, I think all of the ECMO community, right? If we want to go up on our RPMs, we're going to have a high risk of causing a lot of hemolysis there. I would say the first thing to do is really fluid replete this patient. So giving the bolus, stopping the Lasix infusion, and seeing where our flows would be before going up on the RPMs. So with that fluid repletion and stopping that Lasix infusion, our ECMO flows improve greatly to 360 mLs per minute. Our venous line pressure is down to about -15. And the patient did get AT3 as well as heparin, just for that poor anti-10A of 0.1. I'm going to pass it along to Dr. Ibrahim to tell us about the rest of the case.
Hi, everyone. My name is John Ibrahim. I'm one of the faculty here in the Newborn Medicine Division. All right, so I'm going to take you to the last part of our fireside for the NICU. So a little while later, you have once again been called to the bedside due to the pump alarming for low ECMO flows and also increasing negative venous pressures, and your mixed venous oxygen saturation is about 65%. Looking at the baby, the vital signs, the baby was tachycardic, hypotensive, and hypoxic. So these are the labs. The latest CBC that you have, again, the HNH is 9 and 27 with unremarkable death. The ABG shows low bicarb and metabolic acidosis with -8. And again, the creatinine is 1.2. Some new labs that we got, the anti-10A is now 0.75. A little bit higher than what we want. The anti-10A is 95. We did replace it and replenish it, but maybe we did overshoot a little bit. The PTT is 155. The INR is 2.5. The crate, as I mentioned, is 27. Your fibrinogen now has dropped to 145, and your platelet count is 65. So what will you consider next? You have choices between increasing the Lasix infusion, giving blood, increasing the heparin infusion, transfusing platelets and FFP, decreasing the heparin infusion, and then different choices altogether. So take a minute or two to think it through and choose one of these choices.
Tough choices to ponder at the bedside.
Someone, Tim. There's an excellent comment in the chat. I don't know if someone read it about the differentiation between the obstruction and negative venous pressure for volume. Just want to point out this. So everyone is, there seems to be a general agreement on G. So let's go back. So it's B, D, and E. So blood, transfuse platelets and FFP, and decrease the heparin infusion. Yes, that's the correct answer. Excellent. So we're giving blood, transfuse platelets and FFP, and decrease our heparin infusion. As I stated, we probably overshoot a little bit. So we also turned our Lasix drip off, and turning the Lasix drip, you are not wasting as much or diuresing as much heparin also. So you have to be cognizant about that. So let's quickly talk about a few points and then troubleshooting them. So etiology of hypotension with low flows and SpO2s can be due to acute blood loss, whether there's bleeding at the cannula site, and as stated in the previous case, 2 cases actually, that there could also be, especially in a late preterm or in babies in general, they're at higher risk for intracranial hemorrhage, particularly if the underlying etiology involves some sort of CNS injury such as neonatal encephalopathy. Hypovolemia, maybe we did overdo it with the Lasix drip. And as Tara stated, we usually don't start diuresis on day 1 because of the third spacing and systemic inflammatory response. Usually volume is our friend in the first day or 2 of ECMO run. So this is something to keep an eye on. Or maybe we're not providing insufficient ECMO flows. Other etiologies would be malpositioning of the venous cannula. We do always get an X-ray and an echo once we cannulate the baby. And whenever we run into issues and we have suspicion, we always get another echo to look at the cannula position and site. Worsening anemia, something we keep an eye on, as I stated. Blood products are frequently being given during the ECMO run, and making sure that there is no acute drop that would explain an acute bleeding somewhere, and checking the cannula site also. Especially in babies with coagulopathy, this is something we see in babies with neonatal encephalopathy or hypoxic ischemic encephalopathy or sepsis. And third spacing with being on ECMO, leading to capillary leak and decreased intravascular volume. So, what should we do with an acute blood loss, whether it's bleeding at the cannula site or we have a suspicion of bleeding somewhere else? If we do see a visible bleeding or oozing at the cannula site, we do packing and secure it. We call the surgeons immediately to secure it or place extra sutures. We do some decrease our anticoagulation and then sometimes maybe suspend our anticoagulation. I would say in babies with HIE or neonatal encephalopathy, we do lower or aim for lower anti-10A levels just because of their inherent risk of bleeding. We would aim for higher platelets. Tara did mention 100 in the first day and 80 subsequently. Sometimes when there's an active bleed, we aim for higher platelets, more than 100. And we do correct to the coagulopathy. Generally, we are aggressive with correcting coagulopathy. This does not affect your anticoagulation. And then we aim for H&H of 10 to 12 and 30 to 35. And also, just going back to that point about there is, for every ECMO center, there is a protocol on how to approach a bleeding cannula site that should be present for every baby on ECMO. And I don't know, Dr. Burhan, if you want to elaborate on that, about the bleedings.
Yeah, bleeding is a major complication in babies. As we discussed yesterday in my talk, that the hematologic system is in the early stages of development. It's premature. Patients are coagulopathic. Got to be gentle with our anticoagulation, and our guidelines for the bleeding aim for a lower anti-10A of 0.1 to 0.3, and we aim for a little bit more liberal platelet count. We also have to be mindful not to give too much platelets because that can also cause more problems as well. Some studies have shown that it does increase the risk of mortality, whether it's because of the platelets or patients being sick. But bottom line being that avoid bleeding complication, and bleeding can occur anywhere. Intracranial is much more of a serious problem.
I think maybe just another point to make with that too, and it came up at the end of the CICU talk, is really being mindful about our MAPs, our mean arterial blood pressures as well. So staying really vigilant on repleting our blood products as needed, but then keeping a really close eye on those MAPs and using infusions or PRNs as needed. I feel like we really like to target a MAP of around 40 to 60-ish, and really being stringent about that if it starts to go too high.
Thank you, Tara. So other etiologies for hypovolemia would be increased diuresis. So consider, if you're on a Lasix drip or if you're on diuretics, consider stopping them or decreasing the diuretic therapy. If you're in hemofiltration, obviously discontinue the hemofiltration to manage your hypovolemia. Liberalize your maintenance fluids and consider fluid boluses to replenish the intravascular volume. With insufficient flows, we do aim for flows between 100 to 120 ml per kilo per minute. We make sure that the baby or the patient is not hypovolemic before increasing flows, because if you increase your flows in a baby that's intravascularly depleted, you risk, with high RPMs, you risk hemolysis and increasing your plasma-free hemoglobin that has detrimental side effects on different organs, including the kidneys. Always monitor your venous pressures. As I said, volume is your friend. You're aiming for somewhere between -15 to -25, and monitor your mixed venous oxygen, and your goal is somewhere between 60 to 80. For venous cannula position, should always be in your differential whenever you're having issues with venous pressure. Look at your X-ray, check cannula position with an echo. Make sure there is no kinking, so physically examine it. The perfusionists at bedside are the best friends that you can rely on when a patient is having issues with cannula kinking. So talk to the perfusionist at the bedside, run through the circuit and look at the circuit and look at the clots if there are any clots in the circuit. And if you're having suspicion, call the surgeons to the bedside and huddle with the surgeons about if there's any issues with cannula. For third spacing, as I mentioned, hydrocortisone is our friend. We do use hydrocortisone to minimize the capillary leak and replenish the intravascular volume. So what happens if the baby needs to come off? There is a problem with the cannula and the surgeons need to adjust it. You essentially treat the baby as if the baby is not on ECMO. So you give volume prior to taking the baby off. You start pressors if the baby was having issues with blood pressure. You optimize your ventilator support. All babies, when they're on ECMO, they are on lung rest settings to allow the lungs to heal and minimize further lung injury. But if you're coming off ECMO, you essentially try to use your lungs because this is what the baby is going to rely on. You take your oxygen up to 100%, and if pulmonary hypertension was the active issue and the reason going on ECMO, you put the baby on nitric. Consider switching sedation to the baby and even muscle relaxing the baby if you are worried coming off ECMO and you're worried about the clinical status of the baby. Be prepared to provide resuscitation. The baby went on ECMO for a reason, and if you're emergently coming off when the baby is not ready, you might need to provide resuscitation medications, even CPR or hand bagging. Anything you want to add, Dr.
Great. No, thank you, John. Thank you, my wonderful panelists. And I think the bottom line is judicious use of ECMO when it comes to babies, high risk of complications and morbidity. Be gentle and judicious with anticoagulation. You don't need to aim for very high anti-10As and very high PTTs because it increases the risk of bleeding. And then be mindful of the flows and the RPMs because the risk of hemolysis with these small cannulas is high. Fluid management, very, very important. As Tara pointed out, this baby in this case was negative fluid balance with a lot of diuretics. So avoiding that situation will also make sure that the flows and the ECMO conduct of the ECMO is going to be fine. And then expedite strategies and evaluate for when the baby can come off ECMO support. So thank you so much. Thank you, my panelists, and appreciate the opportunity for this chat.
Thank you. All righty. Next up, we have another fireside chat. It's going to be with two of our staff here at UPMC Children's. And we have Dan Ross, one of our perfusionists, and Kristen Cobbs as one of our newer ECMO specialists. So we'll go ahead and let them go ahead and get started and get on our way. Thank you.
All right. Good afternoon, everybody. I'm Dan Ross. I'm a perfusionist here at Children's Hospital, and this is Kristen Cobb. She's one of our ECMO specialists. We're going to be going over a couple case reviews, just get some crowd feedback and something a little different. So, all right. So case scenario number one, 16-year-old, 55-kilogram male presents to the emergency department in respiratory failure. Patient is intubated and sedated, but begins to suffer pulmonary hemorrhage and acutely decompensates. The ECMO team is paged for emergent cannulation, and the patient is successfully cannulated onto VA ECMO via the right femoral artery and right femoral vein, and also a distal limb perfusion cannula is placed.
All right, so whenever we get the ECMO page here at Children's, it usually comes with the weight and the location of the patient. So when we get that page, we like to do our BSA calculation. We'll use that weight in this emergency situation where we don't have the height of the patient, and we'll use that weight, multiply it by 4, add 7, and divide it over 90 plus the weight. We will then use that BSA to figure out what our target flow would be. Ideally, we'd want to get it to a flow of a cardiac index of 2.0. So we would take that BSA and multiply it by, for this instance, 2. We would do the calculation for the heparin bolus and then determine what size cannulas and cannulation site, usually by contacting the surgeon, and then check availability of PRBCs. So using this chart that we have here at Children's, we would find the patient's weight in kilos, and this will tell us the cannula sizes. So this patient is going to be a femorally cannulated patient. So we would use a 23 French venous cannula and a 19 French arterial cannula.
All right, so here's our initial settings on ECMO. Like Kristen said, we went with the size chart and we're able to get those cannulas in. The flows at a 1.8 index, 2.8 liters. We always initiate with 100% oxygen on our sweep gas at 2.0. Positive pressure is reading 225 and negative is negative 90. All right. And then your initial blood gas comes back, little alkalotic or acidotic at 7.22, CO2 of 59, PO2 is okay at 288, and then bicarb of 18 and deficit of negative 5. And the patient's vitals there on the right. So after receiving that gas, what is your initial plan of action? I'll go back so you guys can take a look. And these are our options here. So A, adjust the sweep using the calculation that everybody follows. B, adjust flow to higher cardiac index. Or C, dose sodium bicarbonate. Or D, all of the above. Give them a couple seconds.
All right, so the correct answer is all of the above. We would go up on our flows to get a cardiac index of 2.0, which is 3,200 liters per minute. We could decrease our FiO2 to 80% based off that ABG with the PaO2 of 288. We would go up on our sweep. So based on that calculation, we would take the 59 times 2 and divide it by a goal of like 40. So that ends up being 2.95, and we can go to a sweep of 3. And then that's what your repeat blood gas would look like after your pH is normalized at 7.39. Your CO2 is 42. PaO2 is 202. And then bicarb has normalized as well.
So we're doing our job. And so next, ECMO doesn't always go smooth. 10 minutes later, negative pressure is reading negative 175 and the flows are down to 1.5 liters. Your CVP is 0 and your MAP is only 45. What is your next plan of action? And here's our options here. So we can either decrease the RPMs until the negative pressure stabilizes, increase the RPMs until the flow is back to at least a cardiac index of 2.0. C, give a fluid bolus, or D, both A and C. All right.
Lots of people answering D.
That is correct.
Yes, that is correct. You would decrease your RPMs, and then you would also give a fluid bolus. So we would do that, give a 10 per kilo normal saline bolus, and then when negative pressures have stabilized, you're able to re-increase your RPMs to that goal cardiac index. So with that, the mean arterial blood pressure comes back to 60, and the CVP instead of 0 is now reading 5.
All right, and then again, flows have stabilized and you are now able to assess both limbs. You discover that the right leg is cool, pale, and pulseless. You place a NIRS monitor on and the reading is 20 on the right leg and 80 on the left leg. What is your next action? Here's our options here. A, assess for flow through the distal perfusion cannula. B, page the surgeon to reposition the distal perfusion cannula. C, apply heat packs to the leg, or D, both A and B.
All right, the correct answer is going to be D, both A and B. So you would assess your DLP cannula and then contact your surgeon. With femoral VA ECMO, one of the major complications could be acute compartment syndrome. So it's important to maintain patency of that distal limb perfusion catheter, and methods to early recognize compartment syndrome would be monitoring for pulses, temperature, perfusion of the lower extremities. and also utilizing the continuous NIRS monitoring of both legs so that you can see if there is a sudden change. And then these are the symptoms that you could see with compartment syndrome.
So the surgeon showed up, arrived, inspected the cannula, and noticed the distal perfusion cannula was malpositioned and bleeding. The cannula was repositioned, blood flow to the leg is reestablished, and the patient goes on to make a full recovery.
All right, so this is going to be our second case. A 3.5 kilo female infant is cannulated onto VA ECMO via the right IJ and the right common carotid artery for meconium aspiration and respiratory insufficiency. Initial settings are this: flows at 420 liters per minute, which gives us 120 milliliters per kilogram. FiO2 set to 100%, sweep at 0.25, positive pressures are 150, and negative pressures are -5.
Here's our initial blood gas here. pH is 7.38, CO2 is normal range 38, PO2 of 180, bicarb 24 and +2. The vitals are 150 beats per minute of normal sinus rhythm, blood pressure of 40, CVP of 11, and saturation of 100%.
So while moving the patient to obtain a chest x-ray, your positive pressure goes to 250 and flows are now 0. What are you concerned about? Are you going to assess tubing and cannulas for kinks, assess for high blood pressures, assess for clot and pressure lines, obtain a chest x-ray to check cannula position, or all of the above?
So the correct answer is all of the above. Obviously, we would, I guess, triage those in different situations. I would obviously check the tubing and cannulas first for any kinks or anything, and then move on to the next ones, assess for a clot, and then last would be cannula position, just because they're the last to arrive, and we can check everything else on our own without any extra tools. So moving on here.
So the cannulating surgeon comes back in and repositions the cannula, flows are restored, and then pressures return. The patient goes on to make a full recovery. All right, that is all we have for you guys today. Thank you so much for listening to us and participating in our questions.
Thank you. I'd like to give an extra shout out to Kristen, our newest member of her team. Thank you, Kristen. Okay, I'd like to introduce our next guest on anticoagulation pediatric ECMO, Dr. Lewin. She will be here giving us his talk. She is an expert in the area, and we have a lot of good projects going on with her. After Molly gets done talking, we're going to take a quick break, and then we're going to have one more fireside chat, and then we'll continue on. So I'd like to introduce Dr. Molly Lewin. There's a big mouse.
And I just click to advance.
You just right here.
Okay,
Just
great.
in your mouse, and right click on it.
Okay, perfect. All right. Hi, everyone. Again, my name is Molly Lewin. I'm one of the pediatric cardiac intensivists here in Pittsburgh. And I have the very straightforward, clear, no controversy topic of anticoagulation in ECMO, which is very much a work in progress. So today we're going to start just by talking about how important yet challenging it is to manage anticoagulation in these patients and summarize the very limited consensus that exists on recommendations of how to do so. And then I'm going to talk about kind of how we've incorporated kind of some of that philosophy to our newly revised anticoagulation guidelines here in the cardiac ICU in Pittsburgh. And then talk about some kind of future goals, directions, and the ever-present challenges. So in general, I think the overarching goal of anticoagulation in ECMO is do no additional harm to a patient who's already suffering from at least single system organ failure and often multi-system organ failure. So the goal of anticoagulation is to enable appropriate functioning of the circuit, and so that it can do its job of supporting the patient without creating new problems for the patient. So we're always walking a tightrope between bleeding risk and clotting risk. And the perfect anticoagulation strategy would kind of be able to straddle the middle so that the patient comes out of their ECMO run, whether that's a bridge to recovery or some other kind of more durable mechanical circulatory support or transplant, without accruing new morbidities or mortality. So that's the goal. I think we all know the reality is very far from that, because bleeding and clotting complications are the most common complications for children on ECMO, and they are unfortunately quite common. So depending on kind of how you define these events and sort of what source you look at, the kind of prevalence ranges, but at least a third of patients develop some sort of clotting complication in either the patient or the circuit. And then as much as 2/3 of patients or even higher develop some sort of bleeding complication. And these include kind of significant neurologic morbidities that some of our colleagues talked about earlier. So the stakes are pretty high for us to optimize this as a critical part of ECMO management. I also like to think about kind of my approach to anticoagulation and ECMO. There are things that I can control. As intensivists, we really like control. I like to think about the things that I can change. So I can choose what type of anticoagulation I use. I can choose what labs I'm going to monitor, how frequently and what tests I'm going to trend, and what my therapeutic range is going to be and how I'm going to titrate my medications to achieve that. I can also define transfusion thresholds for my patient and manage blood product administration. Things that I can't necessarily control, but need to really be thinking of and aware of when I think about each patient and how to anticoagulate them are related partly to patient size and age. So we in pediatrics take care of kind of the smallest to the largest patients. So a smaller patient is inevitably going to have a smaller circuit, smaller diameter cannulas. I'm not going to be able to achieve, the flows that you might with a larger patient. And so you have to think about sort of risk of clot and stasis in the circuit. We have to think about, the maturity of the patient's innate coagulation system, as our colleagues in the NICU talked about. You have to be aware of any pre-existing bleeding or clotting disorders that the patient might have that might influence your management. And then you have to be really mindful of any concurrent end organ dysfunction, like liver dysfunction, renal failure, all things that I can't necessarily control, but are going to be important when I think about, how to manage anticoagulation for my patient. But we'll focus for right now on kind of some of the things that we can control. I also like to think about people who've been doing this for longer than me and know a lot more than I do. What do they say about it? So recently, the Pediatric ECMO Anticoagulation Collaborative released an executive summary of their 2024 consensus conference with some recommendations based on a combination of literature review and expert opinion. I will kind of summarize some of these, but spoiler alert, I'm not going to give you here's the golden ticket for the perfect management, because we just don't have great evidence to support any one particular strategy. But they do make some recommendations about a general approach that I think is quite useful. And then I think this just highlights what we all already know, which is that we really need more research in this space. So we'll start by talking about the selection of anticoagulant. Unfractionated heparin, or I'm just going to call it heparin for the rest of this talk, is definitely the most commonly used. We have the longest history with it and a lot of experience with it. A recent survey published in 2021 of pediatric ECMO centers in the US reported that 94% of centers are still using heparin as their first-line anticoagulant, with the remainder using bivalirudin, which is a direct thrombin inhibitor that I'll kind of talk about in a minute. But I do think that over the past couple of years in particular, bival has gained some traction, is becoming more popular. And so I do think we're going to see probably some shifting in this space. I won't belabor this too much, but just the main differences between heparin and bival. So heparin exerts its anticoagulant effect indirectly via binding of AT3. So it is dependent upon AT3 levels. So kind of both the amount and the function of AT3 to exert its anticoagulant action, which makes it a little bit more challenging to predictably determine the effect, particularly in neonates and infants who may have low levels of AT3. Heparin has a rapid onset and offset of action. It's appealing in that it's immediately reversible with protamine, and it's also the anticoagulant that we use in the operating room on cardiopulmonary bypass. It does have a variable metabolism, but a relatively short half-life. It does obviously carry the risk of immune factors like, or effects like heparin-induced thrombocytopenia, which is much more common in adults, but is something to be mindful of in children as well, given the risk of severe thrombus. Bival, in contrast, is a direct thrombin inhibitor, so it's not dependent upon any other factors to exert its anticoagulant effect. And it inhibits both free and clot-bound thrombin, which in theory makes it appealing. It too has an immediate onset of action, but no reversal agent. And it is renally cleared. And so the half-life of Bival does depend on renal function. And so it needs to be kind of dosed with renal dysfunction in mind. There have been, there's a lot of interest for some of these reasons in using Bival in pediatric ECMO patients. But most of the existing studies have just been kind of single center retrospective observational cohort studies that are difficult to sort of shift practice based upon. But meta-analyses of these studies have suggested that Bival may be associated with less bleeding, less clotting, lower total transfusion volumes, and actually decreased total costs, despite the fact that Bival is actually a more expensive medication. But as I said, these studies have been pretty limited in their methodology, but important for us to think about. There has been kind of, unsurprisingly, a lot of interest in studying this in a prospective randomized way. So recently published data from a single center pilot study that randomized 30 pediatric ECMO patients to heparin or Bival was initially really intended to be a feasibility study and to kind of assess the necessary sample size for a larger definitive trial. But interestingly, even in this small group of just 30 patients, found more clotting complications in the Bival group and less transfusions in the Bival group, but otherwise no significant differences. Again, a very small sample size, but clearly the type of work that we really need to be doing as we look at these things. So what do the experts say? They conclude that, unsurprisingly, we don't really have enough evidence to recommend Bival as a first-line anticoagulant for pediatric ECMO, but that you can use it, particularly if your center is comfortable with it, and in select scenarios such as heparin-induced thrombocytopenia, heparin resistance, and so on. So moving on to our next element of control, so our laboratory monitoring, which includes both the kind of tests that we follow in the therapeutic range. So there's like a veritable alphabet soup of different tests that you can follow to measure the effect of your anticoagulation and sort of the status of your hemostatic system. I'm not going to get into the kind of details of each specific test, but just to emphasize that there's sort of two different types of tests, particularly for heparin. So when we think of monitoring heparin effect, there are sort of time to clot assays. So this includes traditional tests like the ACT, the PTT, and then sort of our viscoelastic assays like the TEG, which are really kind of a general measure of how long it takes for the patient's blood to, coagulate. These kind of include the effect of your anticoagulant, but also include many other factors unrelated to that. So they're not really specific to the effect of your anticoagulation. The anti-factor 10A level, in contrast, is very specific to heparin effect and measures really only heparin effect, and so will not account for any other variables that may be influencing the coagulation profile of the patient. There are some important sort of limitations of the anti-factor 10A assay as well, that it is influenced by kind of other lab abnormalities that need to be considered. But I think it's important to understand what you're measuring and not measuring by the assay that you're following. I think it's also, the tag, as we'll talk about in a minute, is becoming increasingly used. There's really not a lot of evidence to support its use in anticoagulation titration, mainly because there haven't been kind of reference range established for that. But I do think it is a really valuable, very comprehensive measure of the whole kind of life cycle of a clot that can help you pinpoint specific areas of derangement that could be optimized in order to decrease the patient's risk of bleeding or clotting. And then the dilute thrombin time is a very limited assay. It's not something that we have here in Pittsburgh or that I've ever used, but I think is kind of being studied for its value in bivalve titration. But for the most part, the PTT is what is used for bivalve. When you look at the data, for the most part, there's very poor correlation of these laboratory measures to each other, to the dose of anticoagulant you're using, and to the clinical outcomes that we care about. So really helpful. There have been some limited studies suggesting that maintaining an anti-10A level above 0.25 is associated with decreased need for circuit changes, but that's not been consistently replicated. And overall, the data are just kind of murky. But so what are people doing? So the same survey showed that 90% of centers are using anti-10A for heparin titration. This is an increase over the past like 10 to 15 years, I think, when anti-10A was less readily available. 75% of centers are still using ACT in some capacity. And then I think encouragingly, over a third of centers are now using these viscoelastic assays, which will hopefully enable us to kind of get a little bit more data on their utility in this space. And then this is just a chart from that same survey, just showing that a lot of centers are using a combination of studies. So as I said, this, sort of measure of your anticoagulant effect for heparin, and then also one of your kind of time to clot. But by far the most common is still the anti-10A with the ACT. I'll point out, as you'll see in a minute, we are a minority here using the anti-10A, the PTT, and the TAG. But I think it just to show that people are using a mix of different things together to try to make sense and optimize their anticoagulation. So what do the experts have to say about this? So in terms of heparin monitoring, they sort of concede that you probably should be using a combination of assays. So one of these more global time to clot measures like the ACT, the PTT, or the TAG, and then also using a measure of your anticoagulant effect, so your heparin effect with the anti-10A. They do emphasize that it's really important to investigate and understand discrepancies between these assays, as that can sort of help you better clarify the coagulation profile of your patient. And you really need full data to do that. And then they sort of say that there's just not enough evidence to recommend a specific test or range for bivalve, but generally the PTT is what folks seem to be using. And then I'll just briefly touch on kind of the establishment of transfusion thresholds and kind of blood product administration. So you can think about transfusion in ECMO as being either prophylactic or reactive. So there's kind of some basal level of different kind of platelets and coagulation factors that you want to maintain to prevent bleeding. And then there's also sort of the need to treat active bleeding in the setting of coagulopathy, or to kind of resuscitate with blood in the setting of kind of hemorrhage and losses. I think, folks have sort of alluded to this, but the existing literature does show an association between greater transfusion volumes and worse outcomes, although the directionality of that association is a little bit unclear. But in general, I think trying to minimize blood product exposure and transfusion volumes is always a good goal. which is basically what is recommended by the experts. I think one point that they make that I think is important for us to always be mindful of is, rather than setting hemoglobin thresholds and arbitrarily transfusing when we go below that, to really explore the adequacy of oxygen delivery and the mismatch between oxygen delivery and consumption as kind of a better indicator for the need for red blood cells. And then that kind of transfusing just to maintain platelets that are above 100 or to try to get an INR below 1.5 is really unlikely to be very beneficial to the patient. So I think when I kind of think about all of these things, and when we were thinking about this as we revised our guidelines, you know, anticoagulation for children on ECMO needs to be protocolized, but it also really needs to be individualized, which is hard to do. And then, you know, I think that we have to always be thinking about the status of the patient in the circuit, the minute-to-minute bleeding and clotting risks, and any other relevant factors, whether in or out of our control, that we need to be kind of frequently reviewing, evaluating, and discussing in a really systematic, formal way with our multidisciplinary team to inform optimal ongoing management of anticoagulation. Not really a set it and forget it or one size fits all kind of approach. So with that, I'll just talk for the next couple of minutes about our new guidelines here in the cardiac ICU in Pittsburgh, and how we've tried to incorporate some of these principles in our own guidelines here. And I will say, you know, there's lack of consensus like throughout the community in general, and we even have lack of consensus in our own hospital. So we have 3 different units that all provide ECMO, the NICU, the PICU, and the CICU. Each unit has very kind of unique, somewhat overlapping, but distinct patient populations that have very different kind of needs and often different indications for ECMO. And that has led to these sort of different protocols for anticoagulation. So I will talk just about our cardiac ICU guideline. I'm sorry for the formatting issue. But basically here, we use heparin as our primary anticoagulant. So that's our kind of first line, but we can also use bival, and that can be based on either patient history or sort of the preference of the team. We are lab monitoring for heparin. We use the PTT and the anti-10A and the TAG. And then for bival, we use the PTT as well as the TAG. And I'll say, we often don't use, as you'll see in a couple of screenshots, we don't often use the TAG so much for titration, but it's more of a check on some of our other values to help us interpret them, especially when we have a mixed picture. And then we determine our therapeutic ranges and our transfusion thresholds by each patient's individual perceived bleeding and clotting risk and where they sit on that balance at any given time. So sorry again about the formatting, but we basically assign the patient a risk category at the time that we initiate ECMO, and this informs our anticoagulation goals and our transfusion thresholds. So we have 3 categories: a standard risk, a high bleeding risk, and a high clotting risk. And then, you know, we don't just sort of, again, set and forget for each patient, but we are continually reviewing the patient's risk category, the condition of the circuit, and then affirming our anticoagulation goals and transfusion thresholds. And this is formally done and documented at least twice a day in a discussion between our intensivist, the ECMO specialist, and the bedside nurse to ensure that all parties have all relevant information and are all on the same page about where the patient stands and what the goals are. And then we also included in our guideline sort of some recommendations for recognizing and managing bleeding and clotting events, as well as DIC and heparin resistance, which are commonly encountered questions as well in ECMO. So these are just a couple of screenshots in the last few minutes here from our guidelines. So this is sort of, we just emphasize that, you know, the management of anticoagulation isn't about one particular number, but really looking at the whole patient and the whole picture and making thoughtful decisions in light of all of that. So these are sort of our criteria. So standard risk patients don't have any active concerns from a bleeding or clotting standpoint. And then we have criteria for which patients would meet high bleeding risk. In the cardiac ICU, we obviously have a not small percentage of patients who are post-operative with open chest and central cannulation, who are obviously a high bleeding risk. But then we also have some patients who fall into our high clotting risk category. And then we sort of use these risk categories to determine our initial starting heparin dose, as well as our therapeutic anticoagulation goals and our indications for blood product transfusions, or at least to start kind of discussing blood product transfusions. And this has kind of helped us to take a more personalized approach to the patient based on what they need in the given moment. We do also really emphasize in terms of red blood cell transfusions to focus on kind of the clinical context and not just the number of the hemoglobin. So for example, a patient with single ventricle physiology who's going to have a clamp trial and try to come off ECMO the following day may actually need a higher hemoglobin than what you otherwise might target. So you just have to be really mindful of the clinical context of the patient. And then we have the same kind of table for our bivalve titration, just in terms of setting our thresholds and parameters based on the patient's risk category. And then this is just demonstration of our kind of active bleeding guideline with sort of definitions of minor versus major bleeding so that everyone can kind of be on the same page. And then some sort of initial interventions for site-specific bleeding for each patient, as well as some reminders of kind of when to decrease or hold anticoagulation and involve the surgical team. And then we have the same sort of guidance around clotting complications, including kind of how we think about managing that risk in the setting of low flow states like clamp trials or the addition of extracorporeal circuits such as CRRT and how we think about that. So as I said, this is pretty new. We just launched this guideline at the end of July of this year. And it is a formal QI project for which we are collecting data and are continuing to do so. And we're really interested in looking at both kind of the rates of adherence to the guideline, not that people can't deviate, but to kind of understanding when we deviate, why, and then looking at this in association with clinical outcomes so that we can really be continually assessing the appropriateness of the targets that we've defined, how accurately we're able to risk stratify our patients, and if there's a way that we can do that better. And then I think one real benefit has that this has really kind of set scheduled, defined periods at which time the team checks in a multidisciplinary fashion to ensure that all of the key stakeholders are on the same page about what's going on for the patient. So really just briefly wrapping up here, I think, the way that I see the future, and I think, in the way the field is moving is really trying to individualize the management while still using a protocol and kind of optimizing anticoagulation by accurately risk stratifying patients and tailoring their management in such a way. And then, broken record for the past however many years in this space, but we really are desperately needing larger prospective multi-center studies for us to answer some of those questions about, which anticoagulant causes the least harm, what is the best test to follow, and what are the best ranges to target, and what are our ultimate best practices. But obviously there are a lot of barriers to doing so. And that's all I have. And thank you everyone for your time and attention.
Thank you, Molly, for that. We appreciate it. So right now, we're going to go ahead and take a quick, like a 5-minute break. And when you come back, we're going to do another fireside chat. Stretch your legs out.
Although they're like the same shirt. It looks like the same shirt. You have a the top there, so yeah, close it up. So if you want to do that, you can. There is a glare, it's kind of crazy. And then the content, I heard that, but the web cover comment, I really got the I'll give you that here and here, the camera, but the more
Hello, everyone. We're back. This is our last fireside chat for the day. Then we have a couple more talks. So I'm going to go ahead and start off. This is Platinum Perseverance, Raisin and Platinum Bar. Today we have to my right, Carrie Hickley from UPMC Presbyterian Hospital. To the left, Merritt Asmaleiter from UPMC Children's. Remoting in, we have Heather Brady from Children's National and Stephen from Michigan. Glad you guys can join us. Can you hear us okay?
I hear you great. Thank you.
Thanks for joining us. So I put some questions together. I'm going to go ahead and bring them up on the board and show it. Just a little precursor before we start is pretty much going to talk about it also. Everyone on the panel here today has been a member of ELSO, not just a member of ELSO, but have achieved the ELSO Platinum status. And we all receive questions about like, how do you make that transition from the gold standard status to platinum? So we've all been there. Not only have we been there, but we actually repeated and got platinum status multiple times at our institution. So I'm going to put some stuff together, and I came up with some questions. A lot of this was based on some questions that I had asked previously. People asked me about making that transition to gold to platinum. So I'm going to go ahead and start, and I'm going to read the question, and then I'll start with Carrie first, and then we'll just kind of go around the room and have everyone give a little input. Since the ELSO application includes 7 sections that are graded independently, were there any particular areas that needed more focus or collaboration to improve upon? Which sections were scored lower last time, and how did your institution address these?
So I will say at UPMC Presbyterian, our lowest section was actually section 4, which was the training section. I think since we're a perfusion-based staffing model, we led with the idea that every perfusionist coming in already had this high level of experience with ECMO. So our initial training was kind of poor. So I actually collaborated with Mike recently, and we created a new ECMO specialist initial training model.
Thank you, Carrie. Merritt, do you like to add to that?
So for us, we recently completed our application and we were awarded platinum again. And the areas where we seem to struggle actually consistently are 6 and 7. So 1 through 5 are scores. Mike showed them, I think it was yesterday in his slide set. 1 through 4, we are above the median for the platinum centers, which is great. And then you look at 5 and we're kind of like doing well there, but 6 and 7 seems to be like where we have some trouble. So 6 is the program optimization. So benchmarking and how we, benchmark ourselves against like centers. So what we're doing there is we are trying to collaborate with our other UPMC centers that are also centers of excellence, whether platinum or gold, to kind of compare applications and see where somebody did really well and where we're lacking and how we can kind of level up our application to somebody who maybe did better, and kind of draw from their experience to improve on our own. Similarly, with the patient and family focus section, which is section 7, when it's hard for me because when I look at it, I think we do a great job with our patient and family focus. So when we get that score back and it's lower than the median, it kind of hits us really hard because we like to think that we do a great job with that. So that's kind of very eye-opening, and knowing that we need to reach out to other centers that maybe score really well there and see what we can learn from them to improve that score.
Thank you, Merritt. That did hit home when we looked at it. I know Carrie looked at her application too. She goes, wow, your section 7 looks great. And then we get it when it's one of our lowest sections. But anyway, so I'm going to actually ask Steve if he gets some input on that question.
Yeah, thanks for inviting me. We actually probably struggled with, actually not probably, we did struggle with section 6 quite a bit as well. Our 2021 application, we didn't even meet the standard, let alone try to get to platinum. So what we did is we tried to take things a little bit more seriously as far as that portion goes, and then utilize the tools that ELSO actually gives you, and then write about how we were utilizing those tools. So we got really into Arbormetrics, which was helpful, having somebody with a finance business background that is really comfortable with benchmarking, understood that data very well, and could also speak to how we were utilizing it in that way. And then with the other thing that we try to do is to make sure that ELSO knew that we were trying to use all of the tools beyond just Arbormetrics. And we've moved away from Arbormetrics to the data reporting platform, but also made mention that we were using the WhatsApp coordinator app to do a little bit more informal benchmarking that way. And then also kind of demonstrated, we talked about a project where we did a little bit more informal benchmarking of our own. So we had a particular problem in pediatrics as far as just hyperoxia. So just demonstrated that we had reached out to 10 other children's hospital centers to kind of get an idea of how they were dealing with hyperoxia. Compared the protocols they sent us to what we were doing, found out that we were a huge outlier, and then spoke to the process of how we kind of got towards the best practice that would seem to be available from the kind of the informal benchmarking that we were doing.
Steve, thank you. Before you jump over to Heather, you brought up a good point, and that's utilizing the ELSO's the worksheet guide. That's one thing we did. We kind of answer. A lot of people understand if you answer the question from ELSO, it sounds great. But if you look at that workshop, there's a lot of questions in there that are not in the original question. So that's one thing we always do. It's one thing I always want to pass on to other people. You have to use the tools that they give you, because a lot of that's graded on those behind the scenes or small print questions. Okay, now Heather, can we reach out to you?
Yeah. Thank you again for having me. Much like the last two, we struggled with 6 and 7 also. We obviously met the criteria, but we were slightly below where we thought we were going to be. We struggle with benchmarking. One of the issues that we have is this is kind of funny to admit, but we have almost a distrust of the ELSO data being up to date. So we've actually created an internal process for benchmarking against ourselves in the past. And we have decided that relying on that has probably hurt us a bit. So we are getting better at using the Arbormetrics and the new data reporting system to benchmark ourselves against the ELSO data more. And as far as the family, again, just like Merritt said, it kind of hurt us because we do feel like we reach out with the families and we have such good bonds with them. But scoring low on that made us really take a look at everything. So this year we actually looked into some things that we didn't necessarily know that the hospital had to support our families. So the follow-up clinics that we've put into place for our cardiacs for neurologic follow-up, we dove deeper into that, and the same with our NICU families. One of the other things is that we started doing reunions for the families in the NICU. So we're looking to really highlight that with our next application.
Thank you. I think we'll definitely have to get together before our next submission and reach out about that for section 7. But all right, so I'm going to go to the second question. I don't know if we can bring it up. Okay. It says, can you share with other centers, really gold centers applying for ELSO Platinum status, how long the process takes, and which disciplines such as ECMO specialists, perfusionists, medical leadership are involved in putting the application together? It's a 3-year application. So how much time do your team set aside to prepare for your last submission? It seems like every year we go through this and it's like we kind of corral everyone at the last minute. And it's very difficult, especially on those sections 5 and 6, what I call that has a timestamp on it. So it's not like 1 through 4 where that is your program. It shouldn't really vary much, but it's those ones of what have you done in the last 3 years? And those I think really can get you in a little bit of a trouble. So I'll reach out to Steve, if you want to lead that first.
I don't know if I can put like an actual number of how many hours that we put into it, other than to say seemingly more than we ever expected. But we probably started the process about a good year ahead of when the application was due, and where we started that process is it was the people that we found to be the most invaluable were actually the CNSs that were in the ICUs that we work with most closely. They tend to have like the pulse of like the process improvement where we were struggling the best in our institution. Because one of the challenges that we had, I think, in prior submissions was actually knowing what all work is being done, because kind of something that's is a little bit maybe unique to us here in Michigan is that we're doing peds adults with one team across 5 different ICUs. And so just 2 coordinators really didn't have the full perspective of all of the quality initiatives that were ECMO related, ECMO adjacent, that we could actually take credit for and do. And so they were invaluable to us. And then, piggyback off of what Heather said is making sure that we started early enough, because to get our physician involvement in that follow-up was also pretty big for us as well. Previously, we had waited too long, and I'm sure this isn't unique to us at Michigan, but if you try to involve physicians in the process, sometimes it's on snail pace, and it doesn't always make it ahead of submission time. So we started that process a little bit earlier, and I think that played a key role as well.
Thank you, Steve. We're actually staring at our physicians now. They are slow about getting back to you on a few things, but that's a whole nother topic. Anyway, we'll hand the next, Heather, give you some input on that.
Thank you. We actually start the writing process a couple of months before it opens, but we start preparing for it basically as soon as we submit our application. So especially with section 6 talking about the policies and guidelines that you're putting into place and the data. So a couple of things that we've started working on, just for examples, is we're rewriting our CO2 policy for reducing CO2 after going on with our respiratory patients. We're also looking at projects. One of them is scanning our oxygenator to try to figure out where the best placement for a shunt would be with the flow pattern through our oxygenator. So we're really excited about getting that data and then being able to utilize that in our application for next time. But we do involve our physicians. Just like Steve said, it is a slow, painstaking process with them sometimes. So we do try to involve them pretty early just to remind them, hey, we've got this coming up. Do you guys have anything to add? Here's our application from last year. And we do generally get some really good feedback from them. We also involve our chaplains. They've been a really big help with our family and patient section 7 and just helping us with different things that we didn't really realize that we could actually apply to that. So just thinking outside of the box has really helped us.
Thank you. Merritt, would you like to add anything to that?
Yeah, so I mean, I think as you know, all of us are ECMO coordinators or have been ECMO coordinators. As soon as you get that letter that says, whatever you achieved, gold, platinum, you start thinking about you look at your scores, okay, we need to improve this. And I think we're all very well intended and wanting to say we're going to jump in and we're going to get going. But then, other things happen. So we fall behind on the schedule that we so very much wanted to put in place. But I know as a coordinator, I feel like it is constantly on your mind, like what can we use to level up our next application? Who can we get involved? And I know for me, my training is perfusion. So this is my, I think, 4th application that I've put in for Center of Excellence. The first 2 I did were gold. The first one I came in was we had a change in leadership. We didn't even know the application was due. So I threw it together, not really even having much background working with ELSO. And we got gold like barely. And I didn't even know that there were different levels. So that I made it my mission that we were going to get platinum next time, and we didn't. And it hit hard. It was like a knife to the heart, right? And you're like, I've put all this work in for 3 years. What am I doing wrong? And then I realized that's what I'm doing wrong. I'm doing all of it. And I need these people to help me. So you reach out to your surgeons, you involve your team, you involve the nursing leadership. And that was what really leveled us up to platinum, was once I realized it wasn't about me getting platinum, it was about all of us, because we're all putting in this work and we needed everybody. So that was huge for us. And that's really made a big difference in our last 2 applications.
Thank you, Merritt. Sure.
I just have a few things to add. This last application was my first, and we gave us 6 months to put it together, and that was probably the biggest mistake of my perfusion career. It was a lot of time and hours and bugging surgeons and physicians constantly to get our answers. And I think I'll be better to answer what we're doing this next time around with the next question, but definitely changed up our game plan for this next application.
Thank you, Carrie. That leads us, and I'll let you lead off for the next question, because we've talked a little bit, all of us here sitting here today talked about it, is what ideas or plans are being made today to prepare you for the next submission? For example, schedule meetings, ongoing reviews of the application process, like what areas were you deficient where we excelled in, and like what we're going to do for the next one instead of waiting to that crunch time to improve it.
So I don't know if everybody's aware, but UPMC actually has 3 adult ECMO sites and 1 pediatric site, and we all have put applications in for Center of Excellence. So the plan is to create this committee where we have quarterly meetings, where all the sites meet together and we go over the application together. At Presbyterian, we have already started our quarterly meetings where we go over application, and basically each meeting will go through one section. We go through all the questions. What can we improve on? What can we keep the same? What do we need to update? And then other things we've done, like for section 6, is we keep a quality initiative repository. So every QI project we do, I put into the repository, and then we will look at them. I would say the plan is a year out to see what can we use in our application, what applies. And again, we talked about that also Domo platform that they have instead of Arbormetrics. We've really dissected that and moved that into some of our quality initiatives. So we are prepared for the next application.
Thank you, Karen. Merritt, you like to add anything to that?
No, I mean, I think that's perfect. We are just looking to work together. Like Carrie said, we don't work like you guys do, Steve, where it's like the whole university is one application. We have like 4 separate applications. So I think really pulling that together across our centers is really going to make a big difference.
Heather, would you like to add something to that?
Yeah, one of the things that we're doing, we're not very good at keeping up with the meetings when we're this far out. We like the fire to our feet, unfortunately. But one of the things that we are doing this year is we're actually trying to set up a meeting with one of the ELSO reviewers to sit down and look at our application and to see where we can change things, what we can do to improve our score for next time. So hopefully we'll get something good out of that, and then we can take that to our committee and really bring it in.
Thank you, Heather. Steve, would you like to add to that?
Yeah, absolutely. And just to piggyback on what Heather said there, we actually did that when here at Michigan, we had actually gone 0 for 3 trying to get platinum, which was obviously a little bit embarrassing when you're ECMO center #1 and you had a head start on everybody to try to, get platinum. So I actually sat down with Tracy Morrison at ELSO in Seattle, and she was very gracious with her time, spent an hour going over like what our deficiencies were. And like she had the heart of a teacher, but was also very blunt. So brace yourself, because if you make sure that you're ready to hear the criticism that you're going to hear. But she was definitely with the idea of trying to help us improve. So I probably should ask her if it's okay to tell her tell everybody that I'm shouting her out this way, but I'm doing it anyway, I guess. And then I think for us, like I wouldn't say that we're being necessarily purposeful about having meetings about it right now. Like what we kind of do and what we feel like we have in place is like the kind of the structure to kind of work towards that while we continue to do like just the normal clinical improvement that we work on. So we have our quarterly management meetings that we go over QA, QI data, that we talk about all the M&Ms, and like by doing those processes and having those best practices in place, when we get ready to go write the application, we feel like we're like prepared for that already. And I think that's where like our job as the ECMO coordinator comes in, is to like, aggregate that, know about all of that, and then have that kind of ready. And then, do the cat herding that goes along with the parts of it that you can't write yourself.
Thanks, Steve. That is a lot of pressure being #1.
Yeah, just a little bit.
I just now thought of that. I thought it was hard being #2, but #1, yeah, it makes it a lot worse.
Right.
But all right, so I'm going to finish up the last question, and I'll keep it with Steve. This is a simple one, and this question really comes to me. And my personal opinion, I think it's harder to maintain. But Steve, we'll lead this question off with you. Very simple. What do you think? It's harder to maintain platinum status, or get it the first time?
Well, we haven't reapplied yet, but like right now we're in the midst of trying to get ready for the next application. And right now, I'd say I would have thought like trying to get it that first time would be more pressure, but I actually find it a little bit more pressure packed to try to like get to the level and then maintain it. So I'm super excited to hear from you, Merritt, and like people that have had been able to get platinum, maintain it, to hear your advice. So, but I'd say maintain.
Heather?
I agree with Steve. I think it's difficult to achieve it and to maintain it, but there's definitely that pressure to maintain it. Once you get it, it's gonna feel real bad to say, nope, we didn't get platinum this year. We got gold. So there's definitely that pressure to maintain it.
And we'll go to Carrie.
I don't know if this is applicable to me because you're the one who got Presby's platinum status first, and then I just maintained it. But I will say it was a driving factor. I had to beat my predecessor. So
The only thing I'll add to that, I was in the same boat with Merritt. So I came to Children's. She already had platinum. Then I could help, try to get platinum again. To me, it was more pressure of all the applications I've ever done. The most pressure was probably Children's this year getting it fallen Merritt.
I think that the maintaining is definitely, I would say, is harder than, I don't think it's harder than getting platinum. It's hard to get platinum, but the pressure that comes with it is, it's the same pressure as if somebody says, have you ever had Merritt's apple pie? It's the best. And they're like, no, I've never had it. And they're like, okay, she'll make you one. You're going to make her an apple pie. And it's like, what if it's not the best, right? Like, how do you like make sure that it's the absolute best? Or, your performance evaluation at work, if you get superiors on everything, well, they don't want you to do the same thing that you did last year to keep getting superiors. Now you've got to level it up. There's always that next level up. Like, great, you got platinum. Okay, well, by how many points? Well, it was 1,400. You got 1,410 or 1,420. Well, why didn't you get 1,500? Like, we're a 1,500 center, we're a 1,600 center. So I feel like that pressure is just kind of compounding to not only maintain it, but to also level it up is, it's a heavy weight.
Definitely is. All right, with that said, I'm going to thank everyone. Thank you for joining us from afar. And
We
go ahead and
have
get
one
going.
question.
Oh,
Someone is asking if it is important to also to have the quarterly meetings.
So if you're referring to the quarterly meetings about, scheduling for our center, I don't think it says anywhere in ELSO that there's a suggestion about the number of meetings you have when you're doing your planning. I know when they're looking for maybe your M&M process or how you're educating your staff, they like frequency. But I could be wrong. Steve, Heather, or Carrie, can you think of anything that speaks to the frequency of particular meetings?
I don't recall seeing anything about that, and to be honest, that probably, in my opinion, probably runs very center specific. If you're a low volume center doing 10, 15 patients a year, you can certainly function at a platinum level, and quarterly may not make sense for you if you had just no patients or just one patient on ECMO. So I would tell you, look at your program, look at your outcomes, do your benchmarking, and base it off of that. I'm kind of the opinion that if there's no reason to meet, don't meet. So.
Heather or Carrie, do you have anything else to add?
No, I was just going to say program specific, probably yes.
Okay. Or do we have any other questions that have come in? Nope. Okay. Okay, great.
all righty, jumping around here. Thank you guys for joining.
Thank you.
You're welcome. Okay, welcome back from across the room. We have 3 more talks. I'd like to introduce at this time Dr. Richard Tang. He's one of our pediatric cardiothoracic surgeon. He's here today to talk to troubleshooting difficult infant cannulations and novel ECMO strategies.
Good afternoon, everybody. I'm Rick Tang, one of the new cardiothoracic surgeons here at Children's Hospital of Pittsburgh. I just came out from fellowship 6 months ago from Texas Children's. So this is my talk. I have no conflicts of interest. I'm going to present a patient who's still with us here. There are quite a few learning points from taking care of this patient that I think are valuable to share. At the time that this patient came to us, it's a 2-year-old male who was billed as dilated cardiomyopathy, biventricular systolic dysfunction, severe MR, had a restrictive secundum ASD and evidence of pulmonary hypertension. He came to us with a ejection fraction of 25% and on the left. Also had acute renal injury, also had a lung infection and bacteremia. Started out with milrinone of 0.5 and epinephrine of 0.02, but gradually escalated within the first 24 hours. And in addition to that, was also on propranolol for a history of VT at the outlying institution and was requiring diuretics. Had, as you expect, poor lung compliance, high ventilatory requirements. And this was his x-ray the afternoon of presentation to us. So a whiteout lung with pretty marginal hemodynamics. So, in order to optimize this patient, a bronchoscopy of Cadia was required, but, with the marginal cardiac reserve, there was a lot of discussion about what to do next, whether to just bronch and, see what happens, or take a different path, which is to semi-electively put this patient on VA ECMO and proceed with the bronch with some safety net. And after the prolonged discussion, we decided to go with the latter route. We had already gotten vascular ultrasound that showed that this patient had patent right neck vessels. So, cannulation cervical approach as you would typically expect for a patient of this size. And carotid artery cannulation was uneventful. We used an 8 French arterial cannula for this. The issue came with the venous cannulation. So even though the vascular access ultrasound showed that there was a patent right IJ, once the cervical vessels were exposed, it was very evident that the right internal jugular vein was in fact diminutive. Later on, after some more imaging, we found that this patient had a bilateral SVC with the large left SVC to the coronary sinus. With this patient, he had relatively limited vascular access. His left internal jugular vein already had a central line, which showed a non-inclusive thrombus, so not exactly a good vessel to cannulate if we wanted to go that way. So, and this patient was being considered for an eventual LVAD as a way of bridge to transplantation. We initially tried with the standard 10 French, which is appropriate for this patient's size, to go into the right IJ, but beyond 5 millimeters of into the vessel we were not able to go even deeper. So in this situation, what do you do next? So this is by no means an exhaustive list, but these are the things that we as surgeons think about in terms of how to get a difficult cannulation done. Easiest thing to do, especially in a semi-elective setting, is make sure that you have adequate neck retraction. You want to straighten out that vessel as much as you can to have a smoother cannulation. Of course, in an ECPR setting, that's not going to be easy. And then dilation techniques. So using a fine tip hemostat, a plastic dilator. You can also use a smaller cannula to start with to introduce that. And then upsize if you don't have adequate flows with that. Another option is that can be also as an adjunct is to lubricate the cannula. At Texas Children's, we have a surgeon who calls it grease, but you can use mineral oil, and in other centers sometimes use propofol. And if it's a matter of, maybe you have a valve that's just getting in your way, you can also entertain using a guide wire assisted insertion. And sometimes you just, your clavicle is in your way, similar to, an abnormal angle of insertion because of your neck position. You can anteriorly retract the clavicle to straighten out your path. Or all else fails, you can try to cannulate a more proximal site. Of course, the more proximal that you get, i.e. retroclavicular, it's going to be a harder cannulation. If all else fails, you can consider central cannulation. That's also another consideration. Where I just came from, Texas Children's, we were a little bit more liberal with certain patients that required who didn't have good neck access and, promptly went on to central cannulation, or patients who had sepsis, who required higher flows, smaller babies, where a central cannulation would afford you higher flows because of the larger size of the cannulas that you can use. So what are the advantages to central cannulation? Better venous drainage, improved cardiac decompression. It also affords you the option in these small babies to use a left atrial or left ventricular vent. So you can decompress the left side better. There's less risk of upper body hypoxemia and preservation of vascular access, especially in a patient where you don't have a lot of options. What are the disadvantages? Obviously, bleeding risk, mediastinitis risk, risk with a aortic dissection. It's always a potential risk when you directly cannulate the aorta. There's a potential risk for pulmonary blood stasis. This was a big factor here for our patient, development of adhesions for subsequent cardiac operations. If you're anticipating a subsequent operation, you want to try and make that one as easy as possible. And, maybe a central cannulation wouldn't be as good of an idea in that situation. So going back to the case, despite pretty much most of the techniques that I listed, still was not able to cannulate that vein. So considering this patient was going to eventually need a Berlin LVAD, a central cannulation was avoided. The very proximal right IJ was accessed through a purse string, basically right behind the clavicle. And an 8 French venous cannula was inserted. And with that, we were able to achieve flows. So, VA ECMO was successfully initiated, and the patient was well supported for the bronchoscopy. Several weeks later, underwent a Berlin heart cannulation to centromag after clearing his infections. Several weeks after that, was converted to a pulsatile X-course setup. However, despite improvement in the biventricular systolic function, this patient developed worsening biventricular diastolic dysfunction, and therefore was having worsening restrictive physiology. On top of that, in a setting of worsened MR, trying to attempt to flow higher to overcome that, to decompress the left atrium, this patient developed pulmonary hemorrhage and desaturations. So, we couldn't stay on the ICUS driver for very long, went back onto a centromag with an oxygenator. So, however, even with that, drainage continued to be a problem in a setting of pretty severe diastolic dysfunction. And so, with that being an issue, the decision was made to essentially go back to a VA ECMO setup. Went back to the operating room, placed a Berlin RA cannula. We opted to try to decompress the left atrium as much as we can with an atrial septectomy. We left the LV cannula in place, just to see if we can maximally drain this patient and use the oxygenator to maintain the patient's saturations in the setting of pretty marginal lung function. However, this configuration, as we found, led to competition between the drainage cannulas and ended up having inadequate drainage from either cannula. And so the pulmonary edema persisted, and with evidence of the end diastolic LV pressure in the cath lab varying between the high teens to 20s, and with the need to try to attempt to flow higher, we had worsening AI, from higher flows, higher SVR, and the LA was still dilated with evidence of high pressure. So to try to eliminate the AI, we patch closed the aortic valve and closed the ASD to eliminate the competition of the drainage cannulas. So despite eliminating the competition between the drainage cannulas and the volume loading from the AI, the left atrium still had evidence of inadequate drainage, would still get pulmonary edema. And there was also evidence that this was also impacting our other end organ function from venous congestion. So, with a lot of troubleshooting, including clamping off the LV or the RA to see if anything would improve, both were actually serving some function in terms of decompressing the entire circulation. And it was a very, very delicate balance between the two. The other issue was that every time the patient's mean arterial pressure would elevate, there would be retrograde flow into the right atrial cannula due to the restrictive physiology. And this worsened the LA dilation and the pulmonary edema. And so, this patient was pretty much, stuck. You had to keep him paralyzed, very well paralyzed. And you were running up against, trying to get volume off and affecting the kidneys. So, it was not a very sustainable solution. However, on thinking about this issue, we ended up converting to a durable hybrid VA ECMO continuous flow LVAD setup to overcome these problems. This configuration stabilized this patient so far by doing several things. It independently drained the stiff ventricles, still permitting some antegrade pulmonary blood flow by native ejection, providing oxygenation support with the ECMO portion of the circuit. And we were able to titrate the mode of support between full ECMO and LVAD. So in a sense, this is like a VA ECMO setup with the ability to control the amount of LV venting that you can have. And sorry, going back to this slide. So yesterday we were able to clamp this patient's ECMO circuit, ECMO portion of the circuit, and demonstrate that this patient had recovering lungs. So that's brings us to several advantages of this configuration, which is the ability to independently support the ventricles while permitting some native ejection, which is a feature of VA ECMO, the ability to vent the LV, which is the LVAD portion, and the ability to test the lungs. In dealing with restrictive physiologies, one of the challenges is being able to adequately decompress both ventricles. And another challenge is that when you have really sick lungs, how do you test and make sure that you have viable lungs going into a lung transplant? And so, this requires going back to the thinking board about what your goals are in terms of VA ECMO support, and how can you basically tease out new tricks from an old dog. So with that, there are some take-home points from this case. There are limited cannulation options for neonates and infants as opposed to larger sized patients. And the cervical venous cannulation is not always straightforward. When all else fails, central cannulation may be more expeditious in certain patients. And some patients that are challenging to support require alternative or novel mechanical assist strategies to address those pathophysiologies. And that's my case report. I don't know if there are any questions from the audience, in person or virtually. Okay. Yeah. Well, the patient still needs a transplant, so it's still wait and see, but Thank you very much.
Thank you, Dr. Sang. We appreciate that. Our next case report is going to be offered by children physician Dan Mohan on a neonatal case report. Get you set up. Yes, sir. Yep.
Hello, everyone. My name is Daniel Mohan. I'm a third-year neonatal fellow, and this is just a case report that we had a couple of months ago that some people in this room probably remember and were involved in the care with, of a very interesting patient who ended up having a bit of an atypical ECMO run. So just a very brief kind of background and history of the course presenting. Had a pretty unremarkable birth history. This infant was a 38-week infant, fairly typical size, was born actually at an outside hospital of West Penn. Otherwise had a very unremarkable nursery course, ended up being discharged home. So in terms of the presenting symptoms, family first noticed on day of life 12 that he was presenting with some, decreased PO intake and then some diarrhea and respiratory distress. He actually ended up presenting to RED, where he was found to be hypothermic, and then looked to be in respiratory stress into the ED. His condition continued to look worse in the ED, and had some of the gas findings as noted above. He was initially placed on some high flow for respiratory support, and an infectious workup was started. But then as he continued to deteriorate in the ED, he was intubated before being admitted to our unit. And these are just some images of his X-ray and kind of initial presentation that they got when he was in the emergency room. So just going over his course pre-cannulation, he was initially started on the settings above. We were still working with the diagnosis and kind of etiology that this was likely infection. He remained pretty hypotensive, and he escalated, ultimately kind of maxing out on 2 different pressors, in addition to stress dose hydrocort, receiving quite a few blood products because we did notice he had a significant decline in his H&H in the process of being admitted, as well as very significantly elevated inflammatory markers. The CRP was actually undetectable, in addition to some of the findings of coagulopathy that we see below. So the process of cannulation, it was really, he had remained persistently hypotensive despite really maxing out on our pressor support, which is when ultimately when CT surgery was called for cannulation. He was cannulated to VA ECMO on day of life 14. He did get a 10 French venous cannula in his right IJ, as well as an 8 French arterial cannula in the right common carotid. In addition to the other access, he had right upper extremity pal line and 2 PIVs. Those were his initial ECMO settings, as well as the amount of blood products he received during cannulation. One important point to note is that during cannulation, we never actually were able to visualize the end of the arterial cannula on echo. But ultimately, after cannulation, those were the cardiac findings that we saw. And then the finding below was his first gas after he was cannulated, and those were the settings that he was on. And these were just a picture of the X-ray right before he was cannulated and then after cannulation. So in the first 48 hours on ECMO, he was pretty labile. Ultimately, those were the flows that he was on, which are pretty typical. Those were the venous pressures above, and then those were the sweep gases. And he was able to come off vasopressors pretty quickly, but we noted that he was really fluctuating between courses where he seemed very hypotensive and then very hypertensive, in addition to receiving a lot of blood products. Was remaining on the respiratory setting, initially had pretty robust urine output, and then his urine output began to pretty quickly decline as his creatinine also rose pretty precipitously as well. Initially, we had an initial goal of total fluid kind of goal of 140. He pretty quickly developed hypernatremia. And then really in the first 48 hours, in addition to getting a significant amount of fluid, we noticed that his weight substantially increased with the subsequent decrease in his diuresis. And then those were also the findings on his head ultrasound pre-cannulation. A little bit of abnormality, but ultimately no bleed. The other thing kind of to note here is he was very coagulopathic, and this was kind of the first challenge we ran into. Much like we do our kind of standard protocol whenever we cannulate, is we do cannulate and put them on heparin. But ultimately, as you can see, with just looking at some of the iron arm parameters that we have above, he never actually was able to get therapeutic on heparin despite us continually increasing his dose. In addition to this, Oliv's inflammatory markers were still sky high during the process of the first 48 hours. Ultimately, we did decide to switch off of heparin and switch to bival, but after we got to day 3 of the run, things seemed to settle out where his blood pressures became a little more steady and improved. After we switched to bival and began following PTTs, there was a slow but steady uptick, but compared to the lability we were seeing before with the heparin, seemed to be in a better spot. Those were the echo findings as well once he was cannulated. And in terms of his respiratory settings, initially he was slightly increased because we did have some trouble with just the degree of product that he was given and how much the edema developed, kind of keeping the lungs open. But ultimately elected to kind of decrease and get closer to rest settings and even, allowing maybe a little more collapse. And then those were the nebulizers we were given as well. He did receive doses of SURF, and because of just the degree of lung inflammation we were seeing on previous chest x-rays, we did kind of electively start INO with the idea that hopefully it might help us battle the inflammation that was ongoing in the lungs. And that's just a bit of a continuing of the course. You can see, in addition to what was happening from a respiratory standpoint, because we were having so much issue with diuresis and how fluid overloaded he was at that point, we did also start a course of CRRT to help us meet our fluid goals. We did not have a pathogen at this point, so after discussing with ID, he did get started on levofloxacin, but at this point, we were still working under the diagnosis of culture-negative sepsis. And head ultrasound was steady, but still not demonstrate any bleed. And so similarly, because we didn't have a diagnosis and he had kind of an atypical presentation, allergy, immunology, genetics, rheumatology, and heme were all consulted. They did recommend as an adjunct using Plex therapy to help us combat the degree of inflammation that he was undergoing, in addition to starting methylpred, but then eventually IVIG and anakinra. And then, as we mentioned, coagulopathy improved after switching to bival, but we did see on each day that he was having kind of a slow and steady increase in his bival to meet our coagulation parameters. And then this is where we kind of got into one of the central issues that came up really during the entire course of the run, is that we were never really able to visualize the end of that arterial cannula. We did notice that his flows were very particular to his positioning, and there were times when the patient was moved, there were times that he would very quickly and substantially drop his flows. And really the only intervention that we were able to make that would succeed in getting us back to where we were was really tenuous repositioning. So we had thought that there was a chance that maybe the cannula was coming up against the back wall, or perhaps that maybe it was even in a slightly different place than we thought, because we were never able to visualize it. Ultimately, we did call CT Surge bedside. We tried to reposition, and we found if we really tried to significantly move the cannula from where it was, we also would just really lose almost all of our flows. So electively, we decided to kind of keep things where they were, because rather than go in and do a revision, when we were able to position and sedate him properly, we were able to maintain good flows. Similar along this, one of the other things that we were noticing is he seemed to have a pretty significant differential cyanosis with particularly what would have been his preductal sats, but the sats in the right hand that we were seeing on pulse ox were splitting by as much as like sometimes even 20 points compared to the pulse ox on anywhere on his either left upper extremity or both feet. This seemed to happen independent of flow, so we would increase his flow through the circuit. But one of the things that did seem to help is when we increased his either oxygenation through the oxygenator or by increasing our FiO2. And as a result of this, we had a lot of difficulty discerning how much of this was real in terms of maybe the parts of his body we're not seeing or were actually hypoxic versus was this just some kind of, maybe inaccuracy of the pulse ox, and that was not reflecting the patient because his gases and everything else showed us that he was flowing appropriately and seemed to be oxygenating. So as a result, there were prolonged periods where he did have significantly higher PaO2s because we were getting his gases from his PAL line, which was in his right upper extremity, which was what was saturating properly. And this is just kind of a comparison to day 4 of the run to day 8 of the run after being on ECMO, receiving Plex therapy and CRRT. So after day 8 of the run, we felt that we had made some good progress in terms of his fluid management and diuresis. He was in a better position from a respiratory standpoint, and it seemed like the degree of his inflammation had decreased and gone down. So we felt that we were in a good position to head towards a clamp trial. And I think I'm going to speed up here because I think I'm starting to run out of time. But otherwise, this was the first clamp trial that we tried. That was his gas prior to the clamp trial and his gas kind of towards the end of the clamp trial. There was a question that because he was agitated and showed signs of inadequate sedation, that we figured that we would retry in 24 to 48 hours to see if he was in an improved position. And basically, we tried to do the same thing again, but more or less he failed for the same reasons. Despite our second clamp trial, he was not really able to maintain his SATs. He showed evidence of pulmonary hypertension, and despite our increased sedation, he showed that he was not ready to come off of ECMO. And these were just the echo findings in the clamp trial, showing that as we underwent the clamp trial, he did show some cardiac dysfunction and mostly pulmonary hypertension. And then so on day 10 of the run, this is after he had failed more or less his second clamp trial, and we were still working under the impression of sepsis, but did not actually have a pathogen. We had sent off a whole genome, and it came back for the STOC11 mutation. In talking with genetics, this is when we found out that this mutation is essentially an autoinflammatory syndrome. There had only been a handful of case reports, because I believe this was just discovered and reported in like 2019. And after talking with everyone, they actually felt that this mutation could be consistent with his presentation, not so much from an infectious picture, but from essentially an autoinflammatory syndrome. The next issue that we had is right around the time that this diagnosis was occurring is when we had this right pneumothorax appear. And so part of the issue that we were running into in discussions about the STOC11 mutation, the idea was to start him on essentially immunosuppressive or immunomodulating therapies in hopes that it would tamper down the inflammation and allow his lungs to heal. The problem was with the pneumothorax that it would be very hard to monitor what was happening in the lungs if we had to drop him down to settings to let everything collapse. At the same time, after discussing with CT surgery, they felt that putting in a chest tube in this situation in which we were able to flow would be very high risk. And if you develop a bleed, we may have to come off ECMO. So we elected to defer chest tube placement to drop him down to minimal settings and let his lung collapse in the hopes that our immunomodulating therapies would work. I'll skip through this briefly, but basically for day 10 through 20 of the run, there wasn't too much events that were happening. At this point, we were really just buying time to give his therapies as much time to work as they could, while we hope that eventually we would see a response and that he would be able to re-recruit the lungs and come off ECMO. And this is just kind of summarizing that aspect of his course. And this is just kind of an illustration of what happened with the pneumothorax when we dropped down his settings, and he more or less just became completely atelectatic, but with resolution of the pneumo. So once we got to day 24, this is when we felt that we had given a lot of the immunotherapies time to work, and we elected to do a bronch and hope that we would be able to maybe clear any secretions or debris that was there, and then eventually re-recruit. So a bronch was performed. Unfortunately, during the bronch, as we removed a clot, we found a lot of bright red blood, and it had a lot of resistance when we were trying to go through the process of suctioning and remove. So we were concerned for pulmonary hemorrhage. After the result of going through the bronch, ultimately we elected that to go to CT to see what we would be able to discover. Because ultimately the bronch was more or less unsuccessful because of the concern for hemorrhage and how much blood we ran into. So then kind of continuing on, so day 24 to 26 of the run, again, we were staying with pretty consistent pressures. Ultimately, after what we saw with concerns of pulmonary hemorrhage and the attempts of the bronch, he continued to be just on a T-piece, 10 liters of flow with minimal settings in order to not exacerbate things, along with these kind of same anticoagulation goals. But at this point, you can see his bival had increased quite a bit. This was pretty steady over the course of the run with largely kind of the same parameters. We did drop the bival dose when we ran into the bleeding due to concerns of hemorrhage. And then also right around this time, actually the blood culture came back positive. We had recultured around the time of the bronch, and it was positive for Legionella, at which point antibiotics were restarted. So after all this, we did elect to try a repeat bronch, again, in anticipation of hoping that we would be able to open up the lungs and that the hemorrhage had settled. So after a lot of clots and mucus were cleared, and we got a much better look at the airway, because we were still uncertain if this was really from the alveoli or maybe a local area more in the upper airway. We did discover a lot of old clots and old blood, in addition to seeing findings that was suspicious that he had diffuse alveolar hemorrhage, and some of it that probably happened quite a while ago, just because of the degree of degraded blood product. And then unfortunately, towards the end of the run, after the bronch, he developed a persistent issue of air in the circuit. We tried a number of interventions. Initially thought that maybe it was happening around his cannula site or something with the cannula. So we tried repositioning, redressing. Ultimately, we actually changed out the venous cannula. But ultimately, significant amount of bubbles generation continued to enter the circuit, and we were not really able to identify the cause. So after multidisciplinary discussion, we felt that it was not safe to continue on ECMO, even though we knew that we were not really able to recruit the lungs and get to the spot that we wanted to prior to coming off. And then we decannulated and transitioned to increasing like cardiorespiratory support. And we did give a final dose of surfactant in addition to starting milrinone prior to decannulation, and these were his decannulation respiratory settings. Finally, his post-ECMO course, unfortunately, shortly after decannulation, he did continue to have desaturations. We escalated on our ventilatory settings, but he started to show significant signs of strain in terms of his echo. Ultimately, he did become bradycardic. We did start bagging without a response. And then after a very long ECMO course, we discussed with family, we stopped resuscitative efforts, and he was held and passed away. So this is just a little summary of the course and what had happened. Ultimately, he had, by our standards, a very long ECMO course of 33 days, 31 days, which we ultimately, after discussion with everyone, felt that his presentation was really all due to this kind of DOC11 autoinflammatory syndrome. And after this course, he ended up dying as a result of cardiorespiratory arrest. So these were the main discussion points. I think I'm out of time, but that we kind of ran into as far as the big issues that we had during his run. The differential cyanosis and the difficulty with cannula position remained a mainstay of treatment. That it was very difficult to discern exactly what was happening, where it was coming from, and also how to best management. The pneumothorax and also concerns of his pulmonary hemorrhage made it very difficult to assess what was going on in his lungs and making the decision of are our immunotherapies working and giving us the response we need versus balancing. We don't want to do an intervention that would potentially put him at risk and end the run early. And then, of course, the air bubbles in the circuit, which we ultimately think maybe was due to bronchovenous fistula, but never really got a clear answer for, but ultimately ended up ending the run. Okay. That's all I had. I have some discussion points, but I think I'm over time. So, and if there's other speakers after me. Thank you.
Well, we will continue with the program, and I'm happy to present our next speaker from the motherland, Dr. Joan Sanchez de Toledo, giving us a lecture about the CICU. Thank you.
Thank you, Dr. Castro. It's a pleasure to be here. I think that he was referring to Spain when he mentioned the modern lung, but let me see. Let me make sure that the presentation is up. Please confirm that you guys are seeing the slides.
We see the slides. Just make sure you go into presentation mode.
Perfect. Thank you, Mario. Thank you, everybody. And thank you, the organization, for keeping me here, even though I'm virtually connecting. It is always a pleasure to discuss with you these cases. I think it's great that I'm giving this talk after those two presentations, especially after the neonatal one. I think that it's great to have this multidisciplinary approach from different perspectives and different units that give us the best chance to treat better those patients. I'm going to focus on physiology behind what we do. And I'll try to be very brief. The aspects of the main things that I have in the slides have been discussed before, but I just want to focus on a couple of things based on physiology that I think that are very important. We mentioned those things before when we discussed our case with Rod. I think that our goals are always the same. When we place a patient on ECMO, we have to make sure that we ensure perfusion while we allow to recover the myocardium, but always preserving neurological function. We know that ECMO has complications. Our patients suffer from neurological injuries. So we just need to make sure that we do not harm our patients while they recover. This is cardiac ECMO. This is not respiratory ECMO. And another thing that I took from this seminar today is one of the comments that was on the chat by Tim. He said KISS role for the anticoagulation, but KISS applies to everything. But this is not what the surgeons might be thinking. KISS stands for simple and short, which is the principle of CICU. I know that the second S is sometimes different, but this is KISS cardiac ECMO protocol, simple and short. And this is a principle that applies to every single thing that we do in a CICU setting. Why? Because typically cardiac ECMO, especially in the post-op, is because of something that we need to be very aggressive, and we need to find what the solution would be. This is why looking for residual effects, either by echocardiography or cardiac cath, is very important. We have to anticipate the problems. Let me give you some examples. VT shunt stenosis. What a problem. If we don't diagnose that from the beginning, we don't have lung perfusion. So a rapid shot, an angiogram in this VT shunt detected the problem. So problem solved. What about this patient? Fontan, that arrested. We take a look at the native aorta, and there is a severe thrombosis of the coronary arteries. We know the answer. So we need to anticipate, we need to understand physiology, understand the mechanisms that might put the patient at risk, be very critical in the way we approach our patients in the unit that they are not doing very well, and then be aggressive. Taking the risk of the aggressivity of these techniques, but knowing that the likelihood to find something that will recover those patients is very, very high. Another important finding on these angiograms, critical stenosis of this proximal left pulmonary artery, that if we balloon, we can just ensure that there's better flow, therefore better a cardiac output on those patients. So what I'm trying to say is that cardiac ECMO, especially in the postoperative period, means that we have to ensure that the patient is alive, that we don't have complications, that we preserve the neurological function. And while we try to recover the myocardium, we have to quickly think on those things that will solve the problem that was created. And of course, it's different, the postoperative ECMO than the native ECMO that changes completely the strategy. But either peripheral VA ECMO versus central VA ECMO just follow some basic principles that I'm going to try to discuss in the following slides. In a very simplistic manner, this is what we expect when we put the patient on ECMO, right? We always think that the patient has a decline in his oxygen delivery, the cardiac output is dropping, it doesn't meet his demands, and then we put a machine that takes over his circulation. In a very simplistic manner, we think that the circulation is the arterial pressure. Then, since the heart is not working, there is no pulsatility, but we are achieving good flows during the ECMO, and then the patient recovers, starts to ventilate with the ventilator. We get rid of the ECMO support, and the patient is alive, and it's better. So perfect. But not always things are as simple. And one of the things that we don't typically think is that the native function of our patients while on ECMO not only contribute in increasing his oxygen delivery, but also will have some pitfalls, some problems that will affect the prognosis of these patients. So think about oxygen delivery in a patient on ECMO in a combination of two things, the ECMO contribution and the patient contribution, and try to analyze this couple of independent variables just to understand how we're going to treat and how we're going to solve the problems. Remember the picture that Rod presented this morning. This is a neonate, probably similar to the neonate that we saw before, and that has a severe ventricular dysfunction. And we decide that he's not doing good enough. And since we are a diamond, I think, because there's nothing else, but so we are very good. And I have to say that one of the things that also remember is that the apple pie from Mary, I think, is the best one, and I have no doubt about that. So since we are very good, we decide, and we have Dr. Castro and at the bedside today, we're going to put this patient on ECMO. And what happened? We put this patient on ECMO, and we created a problem. Is that problem common or not? This is what we tried to say before in our discussion with Dr. Rod. So we have a patient that was walking the line with the intubation and inotropy. Now we have a patient with completely white lungs on ECMO. Is that normal? Have we created pulmonary hemorrhage from something that we did, or is the ECMO? So let's try to understand the physiology again. We'll try to make this graph a little bit simple. Let's focus on this lower part, number 6. So when we place a patient on peripheral ECMO, this is what we expect, right? We decrease the right atrial pressure. So we take blood from the right atrium, and we put the right atrium in a system that will give pressure. So the immediate response to ECMO is decreasing the right atrial pressure, decreasing the CVP, and increasing the blood pressure. But let's take a look at what else happens. So while we are increasing the flow, there is more pressure, therefore there is more LV pressure, LV volume. If we increase RPMs, and we increase by a fold of 2, 3, 4, the more we increase, the more afterload that we are putting into this left ventricle that is not functioning well, and the more we are increasing the LA pressure. So if the LA pressure increases, the L volume increases, what we have is what? Pulmonary hemorrhage, severe pulmonary edema. So yes, we are giving flow, but sometimes this flow is creating big problems to the patient. Why is that? Because obviously what we are doing is that we are getting rid of some blood that gets into the right ventricle, but not all the blood bypasses the heart. There's approximately 20-30% of the blood that remains in the right ventricle. If the right ventricle function is good, this will just fill up the left atrium, and that will create increased LVDP and increase a pulmonary pressure. On top of that, the presence of other shunts, like the patient that Dr. Tag said before, aortic regurgitation. Instead of going forward, the blood will go backwards, and that will create more LV volume, LV dilation, LV hypertension, and at the end, that will increase the LA pressure, and this LA pressure will create a pulmonary edema and pulmonary hemorrhage. So remember this thing, right? In a patient that has decreased ventricular function that we place on ECMO, always take into account what the LV distension component will have to do with the bad lines that we are seeing. Again, we place the patient on ECMO, low cardiac output, we place the patient on ECMO, and what happened? The cardiac output is better, but there is more LV volume and there is more LV hypertension. How can we do? What can we do just to make it better? So in cardiac ECMO, what we do is we put the patient on ECMO, and after putting the patient on ECMO, in order to decompress this left ventricle, if we give a little bit of drugs, if we give a little bit of adrenaline, dobutamine, or whatever inotropy you think or you have in your hands, you can increase a little bit the output and decrease the LV volume and the LV pressure. If instead of using vasoactive inotropic support, you use inodilators such as the milrinone and a good combination of inodilators, you decrease the afterload while increasing the inotropic support, you can bring this curve, the LV pressure loop, in a more normal fashion. But the ultimate treatment is this one that we have here. So how do we go from here, severe pulmonary edema, to this one? And this is something that we briefly commented before with Rod, right? This is status post balloon atrial septostomy that can be performed in a different ways. Essentially, we do it in the cath lab, and it can be through the cannulas or through the whatever vessel available you have. But essentially what you do is decompressing the left side in order for the right atrial cannula to be able to suck all the blood from the left side and to restore this LV volume pressure loop and get back to a normal fashion relationship. So what I'm trying to say is that this situation that we have created responds to a very clear physiologic phenomenon that it's secondary to the increased afterload that an ECMO circuit causes to the left ventricular transmural pressure. So ECMO in a dysfunctional left ventricle has to always be associated with some sort of support to the left ventricle. In this case, Dr. Kreutzer just did the balloon atrial septostomy, but there is other things that we can do in a patient with open chest. They can put an LV cannula, etc., etc. But this is not the point of this talk. So again, ECMO, yes, but when we do cardiac ECMO, it is important to make sure that we preserve the myocardium. And in order to preserve the myocardium, we need to decompress this left heart. And in order to decompress this left heart, we need to make sure that the rhythm is is continuously providing AV sequence, that we have a little bit of contraction, and that there is nothing that compresses the heart. So no pericardial effusion, good AV synchrony. If you have an AV block, please put AV sequence to restore this AV sequency that will decompress the left atrium. And if the aortic valve doesn't open, and if you need a little bit of epinephrine just to put forward flow, that will help to decompress the left ventricle. And at the same time, just try to protect your lungs, but just make sure that you don't create a problem by not ventilating the lungs. If we ventilate those patients out of the FRC zone and we create a teletrauma, if we collapse those lungs, it will be probably similar damage that the one that we will create if we over-distend these lungs. So try to keep the lungs recruited, because if you want to keep it short, you will want to take off quickly. And if you have lungs to recruit, that will be a problem. Obviously, if the patient has air leak and there is a severe pneumonia, etc., those things have to be taken with a grain of salt. I won't go through the anticoagulation again. Remember the KISS rule. I think that Tim said that in the chat, and Molly gave us a great talk about our anticoagulation protocol. Stick to the plan, stick to the protocol that you use in your institution, and do not invent the wheel. Things are more simple than we think. Probably one of the most important things is the one that relates that refers to the bleeding. When one of our patients with open chest bleeds, there's always the discussion whether this is a so-called medical bleeding versus a surgical bleeding. It makes me laugh sometimes, because ourselves, we're just trying to say that the surgeons are not medical, the medicals are, I don't know. So I think that the bleeding is a bleeding, and we have to optimize everything that we have in our hands before calling the surgeon and just opening the chest again. I think that there's many things that we have to optimize, but there's two very important things. Besides optimizing the blood products, restoring the factors, I think that we have to always avoid hypertension and avoid congestion. If you have increased mean systemic filling pressure, your organs will bleed. If you have hypertension, your organs will bleed. Again, it was a question in our chat before. How much is too much? Hypertension is bad, high CVP is bad. It's worse to be hypotensive. Yeah, probably, but hypertension on ECMO and with a lot of congestion on ECMO is really bad. And again, in order to avoid hypertension and congestion, we have to diurese our patients. And in order to diurese our patients, we should not be afraid to diurese them. And by that, I mean that if we have to give diuretics, we give diuretics. And if the patient is in an AKI, and there's no way to decrease the CVP, then we have to find ways to decrease it, either with a peritoneal drain if there is ascites to restore the venous return, or perhaps just using a renal replacement therapy through the circuit, because remember that this is the greatest access that we have when a patient gets into extracorporeal support. So do not hesitate to remove fluid just to restore the mean systemic filling pressure of our patients. Infection, again, is was something that that we discussed before, but I think that the most important take-home message from the ID standpoint is that the longer the patient is on ECMO, the higher the likelihood to get infected. And if you think about, and I just placed it, and this is a paper that is very old, but I did it in purpose because it compares infection rates from the late 90s to the 2010, and now we have exactly the same problem. So the longer we stay in ECMO, the longer that we get infected. And the percentage of infections per ECMO days hasn't changed that much through the years. So that means that we can give all the antibiotics in the world, but the longer that we keep those patients in plastic and in the ICU, the more infected they will get. So do whatever you need to do and follow your protocols and the stewardship and antibiotic programs that you have in your institution to make sure that you don't create a problem. But the most important thing, keep the ECMO run as short as you can. Nothing really to mention now on the feeding part. It's important to at least at the beginning, until you don't restore the congestion, your CVP is low, your vasoactive support is low, and you have a good sense of end organ perfusion. Just make sure that you don't create a problem. Make sure that you have good drainage to the liver, good drainage to the gut, and once you have a restored perfusion to those very vulnerable organs, you can decide whether it's worth starting a nutrition. Be very cautious, be very cautious. A neck on a ECMO patient, it's probably a very futile problem. And last but not least, right, it's the neurological problems of our patients. Be very cognitive that this is a real problem. We have to monitor our patients. The longer they stay, the more injuries that they will have, and not to say that we don't know exactly what will happen long term in their neurodevelopmental process. We should be very, very cautious. We know that the ELSO registry hasn't changed much. I mean, the younger ones, the smaller ones are the ones that suffer the most, and this has always been like this, and it will continue to be like this. And we have to be very, very cautious on the way we treat and we monitor them. Remember that we can do, this is a little bit harsh picture, but this is not that long ago. I mean, we do many things to these patients to keep them alive, but if we know that they suffer from the brain, why we are not putting anything into their brains, right? I mean, we have open chests, vents, cables, whatever. But here, it's not that long ago. This patient didn't have anything in his brain. So let's change the paradigm, right? Even patients that are extubated, they should be monitored for well-being. Brain is very, very, very important. And this is something that we here in Children's we started to do from a long time ago. Those are the first studies that we did with the use of NIRS on these patients, and we knew that back then we discovered that these patients, if we monitor those patients and the NIRS monitors were lower during the surgery and the immediate post-op, those patients long-term did worse compared to the others. So let's monitor them very aggressively. We are now putting the EEG on continuously, something that we thought it was very difficult, and there is ways to make it very simple. We are very lucky in our institution that we have people that watch us all the time. But if there is other places that they cannot have continuous surveillance, so that's why they create ways to simplify the EEG reading, and it's something that it has to be easily available at the bedside for our units. Again, the longer they stay in ECMO, the more problems they have. If they have seizures and they have clinical seizures, it's bad. It's still yet to be seen the real consequence of subclinical seizures. The study says that they are not that harmful, but I am hesitant to just accept that. I don't want my patients to have neither clinical nor electrical seizures. I think that it's very important to monitor the neurological well-being is a must in our units. Monitor them, be gentle with sedation, not too much, not too low. remember that there's medications that create a lot of problems. If you can use cisatracurium, use the cisatracurium. The vecuronium has given a lot of problems for those who have been who have been doing ICU for a while. It's very difficult to get the patient off the ventilator after a long run of VEC. So just be very cautious with the medication that you are using. Morphine binds to the circuit, fentanyl to the originator. So be very gentle with your sedation, have a plan, follow the protocol, just try to do less and try to get rid of meds rather than keep pushing meds on the patient. So I think that I just wanted to just give a brief overview of things that I think that are important for our patients, that I think that apply also to patients in other units. But at the end, I think that a cardiac ECMO run should be short, as short as possible. It is very important to look very aggressively for a residual defects. Do the CAT, do your echoes very soon. Just anticipate what the problem would be. I always say talk to the fellows before a patient gets back to the unit after a surgery. Just think about things that could have gone wrong and anticipate the problems. We need to allow the myocardium to recover and protect the lungs, right? Because as soon as we are ready, we need to take off. And if there is bleeding, then things will be delayed. And we have to talk very in a constant fashion with the surgeon just to make sure that we have a plan. If there is bleeding and we gave that and that and that, then and nothing stops, then we have to go and wash this patient out and just make sure that we stop the bleeding. And while we do that, we need to monitor the brain because this is the future for our patients. So we need to keep it simple and short, but with a lot of knowledge background and always going back to the physiology and working as a team. And we are a great team. I'm honored to be able to share with you all this practice. This is a fantastic journey, the one that I've been through here at Children's, and I can be more grateful the whole team of perfusionists, surgeons, intensivists, nurses, and everybody that makes this journey so great. So thank you very much for having me in this venture.
Next, I want to introduce one of our physicians here, Dr. Kelly Austin, MD. She's going to speak about ECMO use and trauma. And just a couple of housekeeping things after this, we're done for the day, and we're going to reconvene tomorrow morning for the hands-on portion for the people who are in-house or staying here. So it's 8 o'clock tomorrow morning, and we'll probably be right across the hallway here. So 8 o'clock. Thank you.
Thanks.
I got you right here.
Thank you.
You're welcome.
I should have everybody stand up, do some jumping jacks, and get ready to like pay attention. No, I'm just kidding. I hope I really appreciate the opportunity to speak to you today regarding ECMO use and trauma. And I just wanted to say that my goal today is to kind of hope that you'll understand some general principles and some statistics about the ECMO use in trauma patients. And I'm going to cover a little bit of adult trauma in addition to pediatric trauma, because there's really a paucity of information regarding specifically pediatrics. There's not that much, and I will cover the big studies. But just to begin with, basically, I don't know how many of you know that maybe you might be surprised to hear that the first successful cannulation and prolonged extracorporeal circuit was used in support of a trauma patient. Dr. J.D. Hill described a patient who was a 24-year-old man who was who presented with a ruptured aorta and after a motorcycle accident, and subsequently developed acute respiratory distress syndrome, and at that time was cannulated with VA ECMO. And he was supported for about 75 hours and was successfully decannulated to survival. And so, while despite this success, ECMO has still been kind of poo-pooed in most trauma for a long time, thinking that because of concerns for hemorrhage in this patient population, as well as potential worsening brain injury and other contraindications to systemic coagulation, anticoagulation in these patients, which was thought to be important at the time for ECMO circuitry. And however, I'd like to present data that will help maybe make people think a little bit more about the evidence for thoughtful consideration for ECMO use in, and to improve the outcomes of severely injured trauma patients. So I think we're all likely familiar with the general flow of trauma resuscitation in the emergency room, such as the ABCs here. But the real question comes down once we get to E, when do we offer ECMO, and what do we already know about its use in trauma patients? So what are the true indications for ECMO in trauma? I think that the most common indication has been used for the refractory trauma, or the ECMO, the trauma patient, with refractory respiratory failure in the setting of ARDS, and most commonly using VV ECMO. But really, there are no formal guidelines to the use of ECMO in trauma, and there is a clinical consensus that acknowledges the potential benefits of ECMO as a life-saving potential support for severely traumatized patients. And so while there are no absolute contraindications, we should consider it for partial or full support in cases where there's reversible highlight, post-traumatic cardiopulmonary failure. And there aren't, again, any real absolute contraindications except for irreversible injuries, such as basically injuries that are eventually incompatible with success for life, such as severe injuries. So if we would jump back a little bit to some past studies done in adult patients, there has been an annual increase in ECMO use in trauma over the last several years. And this is thought to be secondary to improvements in ECMO technology, as we have figured out how to reduce complications on ECMO. Again, the most common in adult patients is the respiratory failure that's refractory, and such as ARDS using VV ECMO. And this could be subsequently secondary to post-traumatic pneumonias, pulmonary contusions, certain abdominal traumas, transfusion reactions, or over resuscitation, such as an hemorrhagic shock, or traumatic airway injuries, a very common potential use for ECMO in the adult patient, and also extensive burn and inhalational injuries. But any acute respiratory failure due to traumatic processes, ECMO can be used. It can also be used as a bridge to lung recovery, or to get someone to the operating room successfully. This is in contrast to traditional protective ventilation, ventilation strategies in patients such as prone positioning in patients with ARDS, because VV ECMO could basically maintain effective gas exchange. It implements superior lung protection. You can have reduce adverse effects of high positive pressure and hyperventilation on lung injury, and it promotes lung tissue repair and can improve prognosis. So it's particularly beneficial for patients with severe chest trauma that are unable to undergo prone positioning. So, I mean, this is, while this is a quick little diagram showing some indications in an adult trauma patient with severe ARDS, pulmonary embolus. This is by no means an exhaustive list of either of potential indications for VV or VA, but it's a quick list. You should also, if you're considering a patient that meets these criteria and you're considering ECMO, it's best to initiate consultation early, so that people can start thinking about maybe the arterial or venous, I should say, the cannulation options for these patients. And then again, here there's some stars on when initiating cannulation about heparin bolus. Again, heparin bolus and infusions are preferred, but clearly not required in patients with high risk of bleeding or in patients at risk for significant neurologic complications of bleeding, such as patients with epidural hematomas or spinal epidurals or traumatic brain injury. But these things need to be taken into account. So again, what about TBI? Well, is it a regular, I mean, it's not an absolute contraindication. It's only a relative contraindication, and certainly it's not great for a traumatic brain injury patient to be hypoxic. That's not ultimately great. So when you've actually exhausted conventional options, we can put patients on ECMO and mitigate bleeding risk, such as using low-dose anticoagulation or delaying anticoagulation or using heparin-free applications or improved heparin binding circuits. And actually, there's been survival that has been fair. Several case reports have reported fair outcomes in patients with multiply injured patients who have traumatic brain injury, and they have had 61% survival rate in some of these and also registries of these patients, which is basically not too shabby. We would consider that. And also, this has been without worsening neurologic outcomes in those patients. They also, the use of extracorporeal carbon dioxide removal has been thought to be particularly helpful in some traumatic brain injury patients where with ARDS, with whom, permissive hypercapnia is not a great option. Ventilation strategies with mean high airway pressures, as I mentioned earlier, and typical ARDS patients may impede cerebral venous drainage, and that's obviously not great for traumatic brain injury patients. So sometimes extracorporeal CO2 removal can be helpful in these patients and reducing their ICP. And also, there's plenty of reports with patients who've had open craniotomies successfully on patients on ECMO. It's not a common thing, but it has been performed successfully. So what is the survival rate of patients who have been on ECMO or trauma patients who've been on ECMO? And again, the largest ELSO registry has something like a 61% survival rate. Now, these are adults, and they compare favorably to the non-trauma indications for ECMO. And so what matters in trauma patients is the index severity score. This seems to add to their morbidity or mortality. Other determinants of survival is there's been, it seems that timing of ECMO initiation favors the earlier timing, the better, less than 7 days of mechanical ventilation. And also, again, it's not a first line of therapy, but more like a salvage therapy. But there is like kind of this fine line to when you have to pull the trigger. In the literature, the survival rates for trauma on all the vast, which isn't that vast, and small cohort studies, and it ranges from 28 to 74%. So the outcome in adults, again, is probably the best study is a meta-analysis of 1,822 patients that has recently been published that shows a 65.9% survival. But interestingly, the VA is worse, and that kind of makes sense versus VV. I'm not sure what the indications were specifically, but this is just in this large meta-analysis. And it is obvious that patients who go on ECMO seem to have longer ICU stays than patients who don't go on ECMO. Again, the trauma patients with AD with acute respiratory distress syndrome with VV ECMO seem to compare when compared to conventional ventilation methods only, had a significantly better survival rate in one study where these patients that went on VV ECMO with ARDS had a 65% roughly survival rate versus 24% survival rate in those patients. This is actually just a plot showing the proportion of survivors in the adult patients requiring ECMO. And if you see here that the average survival was 65% or 66 roughly percent, with the VA patients having roughly 30% or some 39% versus the VV patients. And I think as the years have gone on, we're doing more VV, maybe getting to them earlier or selecting our candidates out better. Perhaps that's skewing this data, but that's why there's more patients who are on VP than VA. What are the complications of our trauma patients on ECMO? Well, renal complications are the number one. Infectious complications are still there, roughly 20%, and thrombotic complications. So let's move on to the pediatric specific information. So unfortunately, this is probably a common slide that you've seen in other trauma talks, but just want to stress that trauma is the leading cause of death in children over 1. And when you add, this is just unintentional injury up there in the blue, but if you look at the orange and green, homicide and suicide, unfortunately, are very high in these age groups as people get a little bit older. And so I just wanted to start by recognizing that this is an important group. And unfortunately, if you look by the causes of death in this graph is relatively sobering. While, recently it was featured in the New England Journal of Medicine, it talks about the changes of mortality over time as far as the top causes of death. And some have remained stable, such as congenital anomalies and drowning and heart disease. But there's a dramatic uptick in firearms. As you can see here, the firearms going up. We've made some great progress in vehicular crashes, but while it's not the focus of this talk, it's something that we have to realize that impacts the lives of children in our country. So when we talk about ECMO use in pediatric trauma, there has been a significant overall, this is overall rare ECMO use in pediatrics. This is an abstract pull from the National Trauma Data Bank that looked at ECMO use in patients under 15, and it shows an increased use in recent years, although this is still relatively old, and we're going to get to newer data. But one of our first studies that was used the National Trauma Data Bank was published with only 36 patients where they found from 31 institutions in patients under 18 years of age. And they looked at the primary outcome of mortality and the secondary outcomes, as you see here. These patients, they identified that 53% were from pediatric level 1 trauma centers, and still a very high amount are done in the adult trauma centers. But the mechanism of these patients that went on ECMO, these trauma patients, 44% were motor vehicle collisions, 17% were gunshot wounds, 17% burns, and 11% drownings. And again, this is from up to 2011, I believe. The survival by age was variable, but obviously the numbers are low. And it did seem that they had more success in the older age groups. And then, and also survival by mechanism, drowning and burns had higher survival rates than gunshot wounds, clearly. But if you go on to just kind of correlates with a longer length of stay in patients who undergo ECMO with an ICU stay of roughly 2 weeks. There also was a higher incidence of acute renal failure and ARDS compared to the non-ECMO cohorts, but 27% of them were discharged home. So in the propensity matching, they found that whether there wasn't a difference in survival in patients who required ECMO versus those who didn't in these trauma groups. Now, more recently, this is published from this year, is kind of a follow-up to that study where they looked at, they extended it out to 2007 to 2018. And they have a total of 217 patients from the National Trauma Data Bank. And this median age was 16 years old, 72% was male. The most common injury sites were thoracic and extremity injuries. And from them, we found that the ECMO usage has also significantly increased over the last several years, with 79% of the cases occurring after 2013. And so this would go along with suggesting that it's become more widely acceptable to consider or apply ECMO to the pediatric trauma population. But interestingly, the actual utilization's expanded to a wider range of injuries, and this varies and is different than the adults. More of our ECMO utilization has covered a wider range of injuries from blunt injuries, pedestrians struck by cars, and stab wounds. And this is comparable, is comparable to the routine or kind of more common injuries in the adult world that's more severe thoracic injuries or ARDS kind of results. And so this article provides some insights on how ECMO is used in pediatric trauma compared to adults and how there's a difference in injury patterns. They found out that the in-hospital mortality was 37% with roughly a 60% success rate, which is comparable to the adult trauma patients. And also regarding that, they also had pediatric trauma patients with traumatic brain injury that had ECMO demonstrated a 59% survival rate, suggesting that ECMO could still be very beneficial in this patient group. If you look at the survival curve, you see that, well, the majority of patients that succumb die within the first 5 days of hospitalization, although there have been patients who make it out longer, unfortunately. But again, the factors that are associated with an increased mortality rate are those with the higher injury severity score, or those with a severe presence of burn injuries and unsuspected intracranial hemorrhage and intentional injuries, which I thought was interesting. And their complications included acute respiratory failure, cardiac arrest, and renal failure. And finally, I want to pass on this last study, which actually is a little bit older than the most recent study I just presented, but it was obtained, it's the largest study that's out there, and it's from pediatric patients on ECMO who are trauma patients, and it was taken from the ELSO registry. And it was actually done here, children's, with Dr. Gaines and Chris Baer. It's presented in the Journal of Trauma and Acute Care Surgery, and it looked at all patients from 1989 to 2017. Who were under 18 years of age in the ELSO database, and they found 573 patients with traumatic injury. And they compared that to ELSO cohort, And interestingly, if you look on, there's a slightly different composition that was identified compared to previously the National Trauma Database study. Here, the majority of patients were drowning and submersion injuries, with 38% roughly, and they had roughly 21% burns, 17% thoracic trauma, and varied of the other injuries. I remember one specifically in the old hospital that I got involved with, which was a blunt trauma. It was a snowmobile rider. He was a teenager who was riding a snowmobile, and he came across a hard wire somewhere that he didn't see that was in the woods. And it caught his chest and just flipped him off. And he quickly went into cardiac failure. And we put him on ECMO in the old ICU over at Children's there. And he ultimately was found to have a mitral valve rupture, I believe, or some type of valvular rupture that was able to make it to repair, which was very satisfying because he was able to walk out of the hospital pretty quickly. And it was something that it's not every day that you're asked to put somebody who's a blunt trauma patient on ECMO, but there are specific things that are definitely worth doing. So in this cohort, the overall survival rate was overall survival rate was 55.3%. For the cohort, which was comparable to the ELSO survival rates for cardiac and pulmonary ECMO supports in recent years. So basically, the outcomes here showed that ECMO was discontinued to expected recovery in 63%. They had roughly a small number of ECMO discontinued for complications, and a high rate was discharged straight home, which was surprising versus which was different than it was also found in the National Trauma Database, but this was a higher rate home. I think theirs was 28%, something like that. And again, the complication profile is favorable, but in the middle you can see that related to ECMO patients, there's no real significantly different complication rate in traumatic patients on ECMO versus those who are on ECMO for other reasons, and they are very comparable. So pediatric studies suggest that basically utilizing ECMO for trauma patients can be done safely. It results in a reasonable survival, and there's high rates of potential discharge to home. I don't think, surprisingly, that it's rare, but it's increasing. The use of ECMO is increasing, and we should remember it in our armamentarium. It's surprising to me that 2/3 of patients who receive ECMO post-traumatic injury survive. And while it's not routine, it's good for salvage. You should definitely consider it, especially when conventional treatments are not being successful. And I feel like, surprisingly, that the traumatic brain injury or other concerns for bleeding should be, again, relative contraindications, not absolute. So the ability to perform ECMO has become a kind of an important quality indicator for trauma centers. And I think it should just be in someone's mind at all times. If you're in an institution that doesn't have this ability, you might kind of consider that as a reason for transfer for a patient who, is heading in the wrong place before they get too sick. All right. Thank you. Any questions?
Thanks, Kelly. We didn't have any questions come in the chat.
Okay.
Thank you. That concludes our virtual program. Thank you to everybody who logged in, and we'll see you guys next year.